Good morning, everyone. We are here, gathered here at the Ramada Gaya Ji for the nephrology update. May I please request our dignitaries to kindly take their seat on the dais. Now, I invite our team to extend the floral welcome to our guest. To begin our proceeding on an auspicious note, I invite our guests to kindly come forward for lighting of the lamp, followed by the Saraswati Bandhana. Okay, sir. Okay. Right, sir. Okay, okay. To formally welcome you all, I invite, I invite, we are honored to have our patron, Dr. Professor N Rai sir with us. May I invite him to the podium? Thank you, sir. It is now my distinct honor to invite our chief guest, Dr. Professor Hemant Kumar, former head of nephrology at IGMS Patna and PMCH Patna, and presently he is president of AIMS Gorakhpur. Padma Shri awardee Dr. Professor Hemant Kumar, please address us. So next. May I now invite us to Indian Society of Nephrology Eastern Zone President Dr. Pankaj Hans sir, Professor of Medicine at PMCH and nephrologist at Ruben Hospital. Next, I request the Secretary of Indian Society of Nephrology Eastern Zone, Dr. Prateek Das, Senior Consultant Nephrologist and BGS Transplant Physician of Eastern Zone. Now, I invite our Organizing Chairman, Dr. Professor K K Lohani, sir. Now, may I invite the Chairman of API Magadh Division, Dr. Neeraj Kumar, sir. सर कोई अगर छोटे हैं ना तो सर यूएस सर आए. Now I invite our guest of honor, Dr. Professor U.S. Rai, former HOD nephrologist, IGMS Patna. U.S. Rai, sir. To conclude this session, I request our Organizing Secretary, Dr. Mritunjay Kumar Singh, for the purpose, the vote of thanks.
I would like to request Dr. K K Lohani sir to kindly welcome and welcome address करा के floor down करा दें. हाँ, Dr. K K Lohani sir, please. इसके बाद floral देगा और उसके बाद lighting और blank होगा, ठीक है? और वो लाया है सब.
Honorable dignitaries on and off the dais, and dear colleagues, on behalf of the organizing committee of Nephrology Update. I welcome you all at Bodhgaya. Bodhgaya, as you all know, is the land of supreme enlightenment. It is this place which transformed a simple human being like Siddhartha Gautama into highly respected Lord Buddha, whom we also call Tathagat, which literally means Bhagavan. The famous People Ka Ped, under which Buddha meditated for years and attained enlightenment, is situated at a walking distance from this place. And so is Mahabodhi temple, the great edifice built by Emperor Ashok in 3rd century before Christ. Obviously, it was renovated on many occasions for obvious reason, and finally in 2002, it was declared a World Heritage Site by UNESCO. Bodhgaya is not only the most sacred place for Buddhists world over, it is also the most widely visited tourist place in eastern part of this country. We are really thankful to ISN East Zone and API Magadh Division for organizing this midterm conference at this holy place. On this very, very special occasion, I welcome our chief guest and the renowned nephrologist of this state, Padma Shri Dr. Hemant Kumar, guest of honor, and another very senior nephrologist of Patna, Dr. U.S. Rai, President of ISN East Zone, Dr. Pankaj Hans, Honorary Secretary, Dr. Prateek Das, and above all, our patron and guardian of the medical fraternity of Gaya, none other than Dr. Professor N Rai. I also take this opportunity to welcome all faculty members and delegates who have traveled from different parts of this state and country at Bodhgaya to attend this scientific get-together. I take this opportunity to wish my good luck to Chairman of API Magadh Division, Dr. Neeraj Kumar, because API Magadh Division is the host of this conference. And last but not the least, the dynamic organizing secretary, Dr. Mritunjay Kumar Singh, who has worked very hard to organize this midterm conference. Nephrology, needless to say, is a very challenging and fast-growing branch of medicine. Every day and everywhere, we come across cases of nephrology, kidney, and urinary system, right from simple UTI to deadly end-stage renal disease. I'm quite sure after this CME program, we will be updated on this very, very important subject. So, wish you all a very useful and fruitful conference. Thank you.
Thank you, sir. Now we will facilitate our guests for this event, and I will request Dr. Neeraj and Dr. Alisha to kindly felicitate Dr. A. N. Rai, sir. To Dr. Hemant Kumar, sir, Padma Shri Awardee. To Dr. U.S. Rai, sir, our guest of honor. To Dr. Pankaj Hans, sir, President, ISNEZ Zone. To Dr. Prateek Das, Secretary, ISNEZ Zone. Our Organizing Chairman, Dr. K K Lohani, sir. And without wasting time, we will go for lighting of the lamp and Saraswati Bandana. इसको ऊपर लाओ नहीं ये जो काम करो ना हाँ उसको ला रहे सब है So I will request our guest to kindly come forward for the lighting of lamp. And after that, I will request audio visual team to recite Saraswati Bandana.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमां आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीम्
To begin our proceeding on an auspicious note, I invite our guests to kindly come forward. I invite our organizing chairman, Dr. Professor K K Lohani, sir, to Now, may I invite our chairman of API Magadh division, Dr. Neeraj sir, to share few words with us.
Good morning. I, on behalf of API Magadh division, as a chairman, would like to welcome, I am feeling privileged to welcome you all. And I will respected chairpersons, faculty members, and esteemed delegates, and my seniors and colleagues. On behalf of API Magadh division, I am privileged to welcome you all at the holy city of Gaya. And I feel gratitude to the senior most faculties from all over Bihar, including Dr. Binod Singh sir, Dr. Hemant sir, Padma Shri awarded, Dr. U.S. Rai sir, Dr. Om Kumar sir, Dr. Pankaj Hans sir, and even from outside our state, like Dr. Brozen sir, Dr. Prateek Das sir, I would like to welcome you all at this holy city, and under the leadership of Dr. Professor N Rai sir and my senior Dr. Mritunjay sir, on behalf of API, we are organizing this nephrology update after 2022, and I would again like to thank you all who have spared their precious time from their Sunday weekend to make this program successful. Thank you.
We are honored to have our patron, Dr. Professor N Rai sir, with us. May I invite him to the podium to share few words with us.
Today's chief guest, Dr. Hemant Kumar, RD, Professor Dr. Hemant Kumar, Professor Dr. U.S. Rai, guest of honor, Dr. Pankaj Hans, President, East Zone, Indian Society of Nephrology, Dr. Prateek Das, Secretary, Dr. K K Lohani, Chairman, Scientific Committee, Dr. Mritunjay Kumar, Organising Secretary, and Dr. Neeraj, Chairman, Magadh Division. On behalf of the Organizing Committee, as a patron, I welcome you all to the holy city of Gaya Ji and Bodhgaya. As you have heard from Lohani, Bodhgaya is famous for enlightenment. Gautam Buddha got enlightenment here, and all those who have come from far distant side, they have come to learn something. Nephrology, actually when we were students, nephrology was not very important. Now we can see the rapid increase in the lifestyle diseases, communicable diseases like diabetes, hypertension and others, obesity. Kidney disease is very common. And if you go in the ward, especially in ICU, 50% of cases are having either CKD or AKI. I always tell Dr. Mritunjay on the round, I think more than 50%, sometimes 70% cases have either CKD or AKI. Patient coming in gets acute diarrhea, vomiting, presenting AKI. Patient having septic shock, presenting with AKI. And diabetes and hypertension is the most leading cause of CKD. So the kidney disease has are really very frequent. And I'm glad that Indian Society of Nephrology is taking lead. And today's conference, everybody, I think the topics are very pertinent. And we physicians, we are the part of the nephrology. Physician is a mother. Physician is a mother of nephrology, cardiology, gastroenterology. They have to know everything. Nephrology, once you go in super specialty, you have a tunnel vision. But as a physician, we always know nephrology, not update in nephrology, but know nephrology, cardiology, gastroenterology. So physician is a mother. So any specialty, super specialty conference is definitely going to help the physicians. So I'm sure we are all will enlightened. Thank you once again, everybody. Thank you.
Thank you, sir. Now, I would like to request Secretary of Indian Society Nephrology Eastern Zone, Dr. Prateek Das, sir.
Good morning, everyone, and my sincere gratitude and towards this organizing team. This is API Magadh, with collaboration of the Indian Society of Nephrology Eastern Zone. I am very delighted to be here in the holy city of Gaya. I also express sincere gratitude to Professor K K Lohani, Dr. Neeraj Kumar, Professor N Rai, Dr. Pankaj Hans, especially for organizing this whole program, President, Dr. U.S. Rai, our guardian, and finally Dr. Hemant Kumar, Padma Shri awardee, Dr. Om Kumar, Dr. Bharat Kumar Singh, and everyone present, all dignitaries in the hall. Nephrology is basically a young subject. If you compare it with the cardiologic medicines or the neurology or other fields of medicine, it's relatively young. So in our student days, hardly we got any chapters dedicated towards nephrology, and very small things were taught even in the postgraduate courses. So overall ideas about the nephrologic patients or the renal patients has not been developed amongst us. All of us, while treating the patient, when a patient comes with respiratory distress, we think of heart failure first, then we think of a kidney failure. But today, there is no scope that you can deny these diseases, because your 13.5 to 15% of the Indian population is suffering from this CKD. The burden is very high, and it is rising nationwide. Although there are some hotspots all over the world where the diseases are much high, specifically some tropical diseases in some hot climates of Chhattisgarh, Odisha, Andhra Pradesh, and some parts of the Jharkhand also. The disease is most likely due to the diabetes and the hypertension that is been increasing. So the health budget that has been allotted in the field of nephrology was not very high. So Indian Society of Nephrology has always tried to spread the knowledge of the kidney diseases amongst the physicians and the practitioners all over the country, and Eastern Zone is no exception. In every year, we perform few CMEs in the cities where the physicians dominate the clinical practice, so that they can be updated with the specialized knowledge, and the identification of the patients of the chronic kidney disease becomes earlier. That reduces the cost of the treatment to the families and huge socioeconomic burden to the country that can be reduced, and more budgets and the plans can be shifted towards the field of nephrology. So the interest has been grown. Indian Society of Nephrology Eastern Zone having now around 300 members. We started 2-3 years back, it was only 160, 170. The seats has been increased in the DM and the DNB nephrology courses. We are increasing, so we need more and more like this kind of CMEs, so that we can exchange our knowledge amongst ourselves, update ourselves, and give the patients the proper care. So I am very happy and very delighted to be here to see all the physicians and the local practitioners, from my own college and the own area. Some physicians are also there, Dr. Neeraj. And with this, I end my talk, that I think if you hear the session wholly, this will be an enlightening session. The program has been well designed by Dr. Pankaj and the local committee, and I think it will be helpful. Thank you for inviting me, and we are delighted to be here. Thank you very much.
Thank you, sir. Now, I would like to invite our guest. Now, I would like to invite President of Indian Society of Nephrology East Zone, Dr. Pankaj Hans, sir. Pankaj Hans, sir.
Honorable dignitaries on the dais and off the dais, as the President of ISN East Zone, I welcome all of you to this first conference of Gaya Ji. The previous conference was held at Gaya. So this is the first conference of Gaya Ji actually. Now in this conference, first of all I welcome Dr. N Rai sir. He is actually teacher of teachers. And I have been knowing sir since I was a child, and had the opportunity of getting treated by sir during my childhood also. Next, Dr. Hemant sir, he is Padma Shri Awardee. He is our guardian of our nephrology society, and whenever we get any problem, we just go to him. Just on our one request, he accepted to be the chief guest of this program. Thank you sir for this. Dr. Yuvesh Rai sir, who is the busiest nephrologist of Bihar, he too accepted our program, and he never refuses to come to Gaya whenever we asked him for this program. Dr. Prateek Das, as we all know, is a busy transplant physician and nephrologist at Calcutta. He is the secretary ISNEZ. I welcome him. Dr. K K Lohani, actually I know him since my MBBS days, and he has been the HOD of medicine at Magadh Medical College Gaya and Beta Medical College also. I welcome you, sir. In the audience, we have guests from outside Bihar also, Dr. Sharad Kumar, sir, Dr. Brojan Singh, Dr. Ashok Vaidya, Dr. Pankaj Mishra has of late just come, and Dr. Prateek Das is there. I welcome you all. We will have academic deliberation by stalwarts of nephrology from Patna and elsewhere, namely Dr. Om Kumar. We have Dr. Professor Vinod Kumar Singh over here. Dr. Amresh is here, Dr. Shalini, and my friends Dr. Jamshed, Dr. Chandan, Dr. Gyan, Dr. Rupak, and listen here, Dr. Manoj is here. Dr. Nisha is also, I welcome you all. From the API side, I welcome Dr. Pramod Kumar, who is a very senior physician at Gaya. Then Dr. P.K. Sinha and others, if I forget your name. Dr. Vijay Jain sir is the senior most pediatrician at Gaya. We are well connected since years or decades together. I welcome you, sir. And we have formulated a program which is of much use to the physicians. I request you to just interact at the end of the talk if time permits. If time doesn't permit, then it is better to discuss during the lunch time or after the session ends. Now this whole program, the man behind this program has been Dr. Mritunjay and Dr. Neeraj. And they deserve a big round of claps for this preparation for this. And yesterday during dinner time, they have promised that they will do it yearly, a nephrology update at Gaya Ji actually. With these words, I end my talk. Long live ISNEZ and long live API Magadh. Thank you very much.
Thank you, sir. Pankaj Hans. Now I would like to request our guest of honor, Dr. Professor U.S. Rai sir, to share few words with us.
Respected dignitaries sitting on the dais, ladies and gentlemen, this is my privilege to stand here and to attend the nephrology update in the Gaya Ji. First of all, I want to congratulate the whole organizing team, especially Dr. Mritunjay Kumar, Dr. K K Lohani, Dr. Neeraj Kumar, under the guidance and the dynamic leadership of Professor N Rai for organizing such beautiful conference. I think this is a good platform where we can interact with each other, we can share our knowledge, which is ultimately transferred in the patient management. This is also a good social gathering, so we have chance to meet our old friends. If you see the different lectures which is included in today's program is of the various interest. It includes the preventive nephrology, then the clinical nephrology, dialysis and kidney transplant. Even in the clinical nephrology, the topics, few of the topics which are very commonly we see like management of nephrotic syndrome from one side, to other side the recent advances of the management of anemia and the cardiorenal syndrome and many other AI in the nephrology. So this is sort of mixed fruit chart where I think we'll enjoy all of us during these lectures. Finally, I congratulate and I wish for the great success of this conference.
Thank you, sir. Now I would like to request our chief guest, Dr. Professor Dr. Hemant Kumar, Padma Shri awarded, currently President of AIIMS Gorakhpur. I would love to hear few words, sir. Please come.
Good morning, everybody. I will start with homage to Professor Indu Bhushan Sinha, mentor of many leading nephrologists of Bihar, who started nephrology in our state. Patron of today's program, Professor N Rai sir, all the dignitaries present on the dais, all the leaders and ambassadors of nephrology of Eastern Zone. I am seeing Dr. Sarath Kumar, very cool. He is all the way coming from such a far-flung place of the country. Thank you very much for coming to Gaya Ji. What we have been doing for the last more than 40 years is propagating the message of escalating nephrology science. I remember I started observing nephrology way back in 1986 when I joined as a PG student in PMCH. There I saw what were the troubles which were encountered by our mentor, Professor I.B. Sinha, when the PD set was not available, and he used to do peritoneal dialysis with IV set. So those were the days we have seen nephrology. And that was infancy of nephrology in 1986, which I encountered. But I'm very happy to see that how this nephrology science has escalated in the eastern zone and particularly in the state of Bihar. And if I'm rightly observing, more than 5 centers are doing kidney transplant in Patna. And I can tell you that doing transplant is not only the commitment. The commitment of nephrology is take the services of nephrology to far long place in the villages. And that is what we are doing. Back to back, we have 2 CMEs, one yesterday organized by Dr. Sasi, and today being organized by Dr. Mritunjay, Dr. Neeraj, and Professor Pankaj Hans. I would like to congratulate them for this kind of advanced CME in Gaya Ji, and I'm very happy to see that most of the nephrology leaders are present in the hall. That's a very satisfying thing. A very small story I will like to tell you about the spreading the message of nephrology in our state. Probably Dr. K K Lohani, he will agree with me. I was called by him more than 15 years ago to attend a CME to speak on some subject on diabetic neuropathy probably, and I attended the CME. Then he told me that I will take you to Begusarai. Then from here, we traveled to Begusarai, and then when I completed my talk there, then he told me that I will take you to Darbhanga. Then I could understand why he is taking me to different places for nephrology CME. So Dr. Lohani is one person. I can tell you that he has encouraged all the physicians to participate in the science of nephrology. And then I got a call from my wife. That time she was posted in Gaya Medical College. And then she asked me, what are you doing? I told her very frankly that I'm selling. I have become a salesman. Then she asked me, what kind of salesman? Then I told her that I'm selling nephrology in the state. So this kind of vision and this kind of passion you have to propagate the science of nephrology in the villages, in the district level, in the divisional level. So my final message is, without the help and interaction and participation of physicians, we cannot have a full-fledged nephrology anywhere, whatever state it is. Even in the country, we don't have a number of nephrologists who can cater the patients suffering from kidney diseases. With these words, I conclude here. Thank you very much.
Thank you, sir, for such inspiring words. To conclude this session, I request Organizing Secretary Dr. Mritunjay sir to sign purpose of the vote.
First of all, I would like to name a few persons who have been left, and Dr. Pankaj sir has requested me to name them. Dr. Pritpal, welcome you. Dr. K.M. Sahu, and Dr. Sashi. And if any other name have been left, excuse us. When we are conceptualizing this CME, this update, we have been talking about this, then we have thought that this should be for the physician, nephrology for the physician, and you will see the academics have been prepared like that. You know, even the basic test like urine albumin test has been done very infrequently in our day-to-day practice, which is the inexpensive test, but not done in our clinical practice. So you will see that after this CME, after this update, we all will update our knowledge and we will go here with some enlightenment. Next, I would like to extend my sincere thanks to Dr. Hemant Sir, Padma Shri Awardee, who is the guiding force, who is the guardian of nephrology here in the Bihar, Jharkhand and East Zone. I would also like to thank my mentor, Dr. N Rai Sir. I would like to thank Dr. Pankaj Hans Sir, who is the man behind this update. I would also like to thank my Dr. Prateek Das, who on the one phone call has agreed for this meeting. I would also like to thank Dr. US Rai Sir, who has agreed for this coming to here, who has agreed for coming here. I would also like to thank our Organizing Secretary, and the man behind this update is Dr. Neeraj, who needs a big applause from the audience, who has done a wonderful job. And I would also like to thank Dr. Dr. Om Sir, my teacher, Dr. BK Singh Sir, and I would also like to thank T. Brojan Singh and Dr. N Sarat Kumar, who have come from far from here, and they have taken a big pain to come here, and they are coming here to enlighten us. The last time we have done CCDSI, CCDSI is actually my society, so name has been in my mouth. So last time we have done this nephrology update here is in 2022, and I remember the date, 24/7/2022. And I would like to request, because who's who of ISN East Zone is here. I am seeing Dr. Hemant Sir, Dr. Pankaj Sir, Dr. Om Sir, all is here. So why not, we would happily like to do ISN East Zone annual conference here if you all agreed. So with this note, I would conclude my talk, and thank you all for coming here. Thank you.
Thank you, sir. We will now proceed with the felicitation ceremony. I request everyone to please stand up for the national anthem.
Kindly bear with us for few minutes. We will be preparing our stage. कुछ नहीं करना है, बस तुम्हारा इससे होगा, बस यहाँ से। इसमें सबसे पहले चेयरपर्सन को बुला लेना है, बुला के और चेयरपर्सन और स्पीकर को बुला लेना है, ठीक है। और उसके बाद मोमेंटो प्रेजेंटेशन करवा देना है ना सबको। नहीं एट द एंड पहले करवा देना है, बस बुला के और चेयरपर्सन को बोलना है कि आप हो जाएगा ना। तो स्टार्ट करो तुम, इसको तुम स्टार्ट करो, जो इंट्रो करी वो स्टार्ट करो।
ओके
इंट्रो किसका इंट्रो करवाना है?
सर अबाउट नेफ्रोलॉजी।
हाँ हाँ कर, बोलते रही ये कौन से साइड?
Respected dignitaries, esteemed guests, fellow nephrologists, dear colleagues, it is profound honor to welcome you to the Nephrology Update organized by Indian Society of Nephrology East Zone API Magadh Division here in the historic city of Gaya Ji. Today, we are gathered not just to share clinical advancement, but to strengthen the bond of our medical community. We are deeply grateful to have such a distinguished group of experts here to share their wisdom with us. I hope this session proves intellectually enriching for all, and I wish you have a productive and insightful conference. Thank you.
फर्स्ट क्लिकिंग को बुलाना है ना, फर्स्ट कौन? फर्स्ट सेशन तो आप चेयरपर्सन को बुलाइए, उसमें पहले
Moving forward, I would like to request our chairperson for the first session, Dr. N Rai sir, Dr. Hemant Kumar sir, Padma Shri awardee, Dr. Anurag Manna sir, Dr. Rajiv Jha sir, Dr. Sanjeev sir, to kindly take their seat on the stage.
कुमार सर को बुलाइए, डॉक्टर कमलेश कुमार को बुला लीजिए, इज मेडिसिन एचओडी फ्रॉम मगध मेडिकल कॉलेज। कमलेश सर को बुलाना है, हम बोल देंगे आप सर। audiovisual team kindly arrange for the presentation of Dr. First speaker on this screen. I would like to request Dr. Professor Om Kumar sir to kindly come on the stage, and Dr. Kamlesh sir, he is medicine HOD, will accompany him on the stage. Dr. Kamlesh sir, kindly accompany Dr. Om Kumar sir to the stage. One more information for the chairpersons speakers, that due to shortage of time, the felicitation program will be held on the side by standee. There is one standee stage made for the felicitation issue, for the felicitation purpose. So that we can keep on moving on to the next program on the stage without any interruption. Now I would like to hand over the mic to the respected chairperson, sir. Kindly proceed.
Thank you, Dr. Neeraj. Good morning. Now we are going to the start scientific program, and the opening batsman is none other than Dr. Professor Om Kumar. He is a professor and head nephrology and also dean, Indira Gandhi Institute of Medical Sciences, Patna. He is going to speak on very important topic. This is important for every clinician, irrespective whether he is a nephrologist or not. And the topic is early detection and prevention of CKD in clinical practice. So I request Dr. Om Kumar to deliver his talk. Thank you.
ये स्लाइड चाहिए ये आगे बढ़ेगा. So very good morning or good afternoon. At the outset, I must thank the teacher of teachers, Professor N Rai, and the whole organizing team led by Dr. Pankaj Hans and the scientific chairman Mritunjay Ji and Dr. Neeraj Kumar for giving me this opportunity to be here at, very aptly said, Gaya Ji. When Dr. Mritunjay phoned me to attend this conference and to speak on topic, I asked him, please allot me the topic. And when he allotted me the topic, I was very disappointed because I think this is a very difficult topic to speak for in a conference like this, because these are the era of, for last 1 decade we are hearing about the very new molecules like NS, MRA, SGLT2 inhibitors and GLP-1 receptor agonist. So I thought that the prepare slides for this presentation will be very difficult and more of a philosophical thing. In 2026, it is very difficult to talk about the importance of controlling the blood pressure, controlling the glycemia. Now we are talking about the 4 pillars of therapy. But as my introductory slide is showing, the 4 important but very, very strong message that the kidney is not a loud organ. It speaks in whispers before it screams. So our job as a clinician is to listen early. And as Professor Hemant Kumar was saying, that in Patna 5 centers are doing transplantation. So do we need only dialysis physicians or transplant physicians? But in my opinion, the focus of CKD care has been shifted from renal replacement to kidney life preservation. So it is important to do the high-end services of nephrology, but if you prevent occurring of CKD or you delay the progression of CKD, it will save lot of money, lot of resources of the country. And CKD prevention is no longer an aspiration. It is a measurable, protocol-driven clinical responsibility. And the most important for a place like Bihar in India is equitable access And affordability is the new efficacy. You all know as a nephrologist that we are having so many drugs for treating IgA nephropathy. But can we afford any of them? Still we are managing IgA nephropathy with ACE or ARB and steroids. All those new molecules are not affordable in India. It is not available in India. So, mind it, affordability is the new efficacy. Just talk of Inrenon. It is very costly. It is very efficacious for kidney and renal and cardiac outcome. But how many patients, our patients, are able to take those drugs, all 4 pillars of treatment? So, it is not just a cartoon. You can see that a tale of 2 pressers. We are having so many preservative food items which are very rich in salt. And we Indians, almost 45% of Indians are salt sensitive. And if you are taking high amount of salt, they make ACE and ARB less effective as an proteinuric drug. So salt intake, especially the lifestyle for today, is very important. Similarly, a tale of 2 epidemics. We produce obesity and then we treat obesity with so many novel drugs. And again, Indian obesity is different from Western obesity. Central obesity is very marked and the West ratio is different in Indian population. So, this is the roadmap for today's presentation. We should detect earlier. We should risk stratify by the cause, glomerular function, and albuminuria. And this is the most important message I want to, that we should prevent silently some of the drivers of CKD like low birth weight. One pediatrician, senior pediatrician is here. So low birth weight associated with low nephron endowment, AKI, especially the pregnancy-associated AKI, which leads into AKD and CKD, nephrotoxins, obesity, pregnancy. Then the treatment has shifted to the treatment of upstream targets. Upstream targets means hemodynamic targets, not the fibrosis and inflammation. They are the lower stream targets. And then you have to build a system so that you can organize your treatment plan. It is not working.
दूसरा है
ये तो pointer है slide. So after this roadmap, we could see that CKD is an epidemic and it has been projected as 5th leading cause of death globally by 2040. And the role of physician is to prevent premature CV death at all stages of CKD. And again, to highlight that India is having 27% of low birth weight of all the births occurring in India. So you can imagine how important it is to address this issue. So who should be screened? Especially the high-risk patients. You are all aware that diabetic, hypertensives, having CVD, obesity, history of AKI, family history, low birth weight, prematurity, pregnancy, hypertension, preeclampsia, recurrent UTI, autoimmune disease, nephrotoxin exposure, aging with frailty, and sarcopenia. So these are the high-risk patients in whom you have to screen on their first visit. And you all are aware this common pathway. Why CKD is progressive? Why it is reversible? Because once more than 50% nephrons are damaged, the etiology goes backstage. Whatever the etiology, whether diabetic or glomerulonephritis, the CKD will take its own course, and now the paradigm shift has been there in the causation of CKD. Now it is predominantly SGLT2 driven. That is why this DEPA-CKD trial has the huge effect of 40% in risk reduction of renal outcome. So, coming to the basic, CKD is defined as abnormality of kidney structure or function for more than 3 months with implication of health. And it can be labeled as what is the cause of CKD, what is the GFR category, and what is the albuminuria category. It is not only an administrative tag, it also tells you the prognosis, frequency of monitoring, when to refer, and the treatment eligibility. For example, if patient is having IgA nephropathy, we should level IgA nephropathy stage G3A and albuminuria of A2 with moderate risk of progression and severe risk. Here I want to emphasize that normal aging also causes decrease in GFR, but that will be usually without proteinuria. So the lacunae of or limitation of today's CKD classification or staging is that the unnecessarily many elderly patient can be classified as CKD. So what are the tools to do early diagnosis? The most important is urinary albumin creatinine ratio. Cystatin C can be done in situations where we are confused about the real staging of the CKD, and this is based on FIND CKD trial which was done in UK, that these type of screening helps in the ultimate management of the CKD. So calculation of urinary albumin creatinine ratio is in a single void spot urine sample is most convenient to measure albuminuria. And what are the confounding factors? Exercise within 24 hours, any infection, fever, heart failure, marked hypoglycemia, menstruation, and marked hypertension may elevate urinary albumin creatinine ratio independently of kidney damage. So you should repeat these values when these confounding factors are gone. And what is the level of proteinuria which we want to decrease? We want to decrease proteinuria below 30 milligram per gram. But if patient is having any amount of albuminuria, reduction of 27% has been shown to benefit the progression of CKD. So this figure is important. Now these are the various methods to calculate eGFR, and the most important or practiced formula is CKD EPI, and you can see that if all patients are having same creatinine like 1.2, 1.2, 1.2, but for different age the value of GFR is different. And you can see that 80-year male having creatinine of 1.2 will have eGFR of 61, and same serum creatinine the female will have eGFR of 46. Similarly, the slight increase in serum creatinine, 1.1 to 1.3 to 1.4, can cause marked. So not only creatinine is important, you have to calculate the eGFR, which are available as simple apps on your mobile. So you are all aware of this heat map, which is classifying CKD according to the GFR, G1, G2, G3A, and G3B. G3 group has been sub-classified into G3A and G3B. Similarly, the albuminuria has been classified according to the severity, that is A1, A2, and A3. And you can see that even if patient is having G3, like G3A, but albuminuria is A1 only, then it is not of so high risk. But if the patient with same GFR becomes A3, then it becomes very serious. So I think albuminuria is more important a predictor for progression of CKD, progression to ESKD, and other comorbidities or mortality related to CV disease. So for Bihar, a state law like Bihar, this is a busy slide, but very important. How do we realistically implement systemic UACR-based CKD screening in Bihar, where many patients first present at stage 4 or 5? So these are the 3 or 4 tier systems where we can use urine deep-stick test or multi-stick test at PHC level, then district hospital level should be equipped with UACR, then medical college should be equipped with classifying CKD according to the CAG criteria. Then the telemedicine from the medical colleges and the screen at every diabetic and hypertensive visit who are the high-risk patient, then quality camps like we are having here, and the training of the district CMOs. So these are the red flag signs when you should refer this patient to a nephrologist. And mind it, referral is not a surrender. It is a risk sharing for diagnosis, refinement, and therapy optimization. And that those patients can refer back to the treating physician. So again, Bihar is suffering from the lack of nephrologists. In a population of 13 to 14 crore of population, around 40 nephrologists are there. So these are the measures how to prevent this, to bridge this gap by teleconsultation, mandatory referrals. If GFR is less than 30, then you have to refer these patients to the nephrologist. Then early fistula counseling, dialysis readiness, and state health policy recommendation and training district medical officers. So coming to the basic of prevention, the primary prevention is stop CKD from occurring. The secondary prevention is early detection and slow progression, where comes the role of all those drugs. And the tertiary prevention is prevents ESKD, end-stage renal disease, and cardiovascular, and optimize the patient for dialysis and transplantation. So few forgotten causative agents of CKD. We only talk about diabetes and hypertension. Of course, they are the major causes, but pollution is very important role. And as Prateek Das was saying, that some part of the world are having CKDU in clusters, especially in hot and humid area. And India is also having such areas in Andhra Pradesh, Odisha, Jharkhand, and Tamil Nadu. And this is very important to address those issues, because the incidence of the CKD in those populations are in the tune of 50%. Coming to the low birth weight causes reduction in the nephron number, glomerular hypertension, then FSGS, and they develop CKD by the 3rd decade. So clinical action is screen all low birth weight adults from the age 18. If you are having a record of low birth weight from a hospital, then follow up these patients at the age of 18 by doing simple albumin test, creatinine test, and estimating GFR. So born too soon, lifelong kidney risk, and the importance of early intervention is there. So this again signifies that all low birth adults should have annual blood pressure, eGFR and USR from the age 18, but it is not routinely practiced in India. So it should be, I emphasize that it should be practiced. So again, if a child is born of a mother who has developed trachea during the pregnancy, So if they are premature and low birth, they should be having the Bucks bundle. And Bucks bundle is blood pressure, urine dipstick, check growth, development of kidney function, serum creatinine, and the size of kidney on ultrasound. Similarly, the patient, female patient developing Praki, they are again very prone for developing. In our days, we were taught that obstetric AKI is very benign, but it is not there. You must have witnessed that the patient coming with Praki have very bad prognosis as far as CKD and even mortality is. Dr. Amresh is here. He has studied and he has done PhD on this thesis, Praki incidence and prevalence and the outcome of the Praki in Bihar. So he has shown that there is high mortality among Praki patients. So Praki survivors again should be followed for development of CKD. Again, this is follow-up stratification, and the Praki bundle of care is there. Bundle of care is there, that is kidney function, advocacy, medication, blood pressure, pregnancy planning, and sick day management. Coming to the target of blood pressure, you are all aware that KDIGO has advocated that it should be low, that is less than 120 millimeter of mercury of systolic blood pressure. Lifestyle treatment has now become very precise, and the smoking suggestion, weight reduction, and obesity, these are the very important factors which have been structured and included in the lifestyle management. So salt intake should become less, protein should be in measured way, weight reduction should be there, exercise, especially the resistant exercises should be there, and smoking. And smoking has not again proved that how much smoking is bad, but usually more than 20 cigarettes per day for more than 40 years or more than 30 packs per year are very dangerous for CKD progression. And any amount of smoking is dangerous for CV outcome. So smoking has to be stopped. Again, coming to this 4-pillar therapy, the RAS blocker, SGLT2 for normal CKD, and Finrenon and GLP for diabetic CKD patient, they have still not recommended in non-diabetic patients. You are all aware of DEPA CKD trial, where DEPA demonstrated a risk reduction in the tune of 40%, EMPA in the tune of 28%. Only thing that they included the broader spectrum CKD, non-albuminuric patient. Fidelity trial, Finrenon, Dr. Pankaj will be speaking on this. So Fidelity showed that it is cardiovascular and renal outcome are better with use of Finrenon. Confidence trial, they have given combination of SGLT2 and Finrenon, and they have shown that the incidence of hyperkalemia is less, but this confidence trial was only for 6 months. It is not an outcome trial. So it was based on the biomarker, that is, they causes reduction in UACR. So they have planned a fine pad study where Finrenon on DAPA is being tested as phase 3 outcome trials. Now, flow trial, you all are aware that this is very important for managing directly obesity and indirectly the cardiovascular and renal outcome. And now the SELECT CD trial, SELECT CKD trial is also being done in non-CKD, non-diabetic patients. So these are the recommendations. One, a recommendation for screening, diagnosis, use of RAS and SGLT2, and 1B recommendation for use of Finrenon, GLP-1. Bicarbonate, one of the cheapest intervention to slow the progression, is 2B recommendation. So beyond 2026, therapies are moving upstream. One very common question asked whether these uric acid lowering agents retard the progression, but this study has shown that allopurinol has got no role in retarding the progression, especially the febuxostat has no role in retardation of progression. Some studies are coming that have shown beneficial effect of allopurinol. So what are the take-home messages for tomorrow? That screen diabetic and hypertensive patient annually. 90% of CKD patients are diagnosed late. SGLT inhibitors are the new standard care in CKD. Add finerenone in type 2 diabetic CKD patient already on RAS and SGLT2 with residual risk. Semaglutide is the third pillar, and low birth weight patient should be followed. Nephrology referral threshold should be low, and there are some recommendations that IgA, especially in the field of IgA nephropathy, new therapy has come to treat IgA nephropathy. So again, I thank you and end my talk with the same slide that this should be our motto of nephrology practice in Bihar or India. Thank you very much.
As usual, wonderful talk by Professor Om Kumar. Yes, I will open to the House, sir, with few comments. One comment is, in the high-risk patient list, birth hypoxia is to be added. Salini is smiling behind. Do you agree, Dr. Salini? So the obstetricians, they are to be taught that birth hypoxia is to be prevented. We have to look into the birth hypoxia. You will take the history of young CKD patient, you will find that most of them, they have a history of birth hypoxia. Why I am talking? Because this was my DM thesis subject, and I have worked on it over the last 30 years. You take the history, you will find this. So this is the opinion I have just given for the House. And one good news that 3 days ago only, there is a fine CKD trial result has come out in NEGM, and now they have given a message that one can use finerenone in non-diabetic, non-proteinuric CKD patient also. Now this session is open for a House discussion.
It was a very good talk by Dr. Prakash, and being a pediatrician, any child, we recommend the patient to take an ophthalmologist for ROP, retinal prematurity POP, retinopathy of prematurity. Similarly, I think there should be a screening for the kidney disease also, renal functions. Second, sir, please tell me, for an elderly patient, to prevent CKD, what dietary restrictions should be there? I mean the vegetables, fruits, dry fruits, except you have told the proteins. But a patient is having CLD also, and he's advised proteins 1 gram per day, 1 gram per kg per day. That means if he's in 60 kg, 60 grams proteins. So in those cases, what should be the restriction of the proteins, and what type of proteins, vegetable proteins or animal proteins, what should be given?
In general, the vegetable proteins are preferable in CKD patient just for two reasons. They produce less acidosis and they causes less hyperphosphatemia, which is a feature of CKD. Regarding the protein intake, it is a very controversial issue. Normal protein, low protein, very low protein with keto analogs. But malnutrition is very common in our patient. So if we talk in the context of the patient from Bihar or at large from the India, and you audit their diet chart, we don't need to restrict in majority of our patient, except very affluent patient who are habituated on daily non-veg meats. So if patient is also having CLD, I think 0.8 for CKD is good enough for CLD patient also. And only thing that you have to take the precautions of CLD also. And it has been seen that many drugs, diabetic drugs like pioglitazone has been very effective in these associated CLD conditions. Dietary restriction, again the salt is most important. As I have talked that Indian patients are very salt sensitive. So usually the general recommendation is salt intake should be less than 5 grams. But it has been seen in the many studies that less than 2.3 grams is beneficial for CKD patient because it is the most effective way to control blood pressure and to make ACE and ARB more effective, and it also prevents in recurrent stone formations. So it is, apart from the hydration, the salt restriction is a very important aspect in renal disease, stone disease.
Okay,
management.
thank you, thank you.
Thank you.
Thank you, sir. Just a minute, sir. Myself, Dr. L.K. Prasad from Patna. You see, we have got 4 pillars for this treatment of CKD. So if the patient is not hypertensive, but having USCR less than, more than 30, and EGFR 60 or like that, why don't you start SCE or AK, SCE inhibitor or SCI? To start with, the patient is not hypertensive.
Patient is not hypertensive, but patient is having increased USCR.
Yeah.
They should be started on a SGLT2 inhibitor. They should be started on SGLT2 inhibitor.
This is what I am getting.
Thank you, sir. Now we are concluding our session.
Thank you very much.
Now I would like to request the speaker, sir, and chairpersons to kindly collect their mementos in the nearby standing point on the right side of the stage. And moving on to the next session. Start.
Moving right along, now I would like to request our next chairperson, Dr. Professor U.S. Rai sir, Dr. Professor P. K. Sinha sir, Dr. R. Verma sir, Dr. Chandan Kumar sir.
Start with speaker group, right?
It is pleasure to welcome Dr. K. M. Sahu sir, who will now enlighten us on the current concept of HF stabilizer regarding the anemia in CKD.
Good afternoon. As we know that the anemia is the most common comorbid condition in these patients, and it has been treated for the long time with the oral and IV iron and erythropoietin. But now the current concept, a group of the medicine which is known as HF stabilizer, hypoxemia inducible factor stabilizer, which is being used for the treatment of anemia. Probably it is a new molecules, and they induces the erythropoietin production, they reduces the inflammation, and probably they are helpful in the utilizing the iron in more better way. I will invite Dr. K. M. Sahu, who is head of Department of Nephrology in Medanta Hospital, to deliver his lecture.
Sir, the floor is yours.
ये क्या स्लाइड यहाँ
Good morning, Gaya Ji. Thank you, Dr. Rai sir, and other chairpersons for the kind introduction. At the outset, I would like to thank Dr. Neeraj, Dr. Mritunjay, and Dr. Pankaj Hans sir for inviting me. So my topic is anemia in CKD, current concepts and HF stabilizers. These are very basic things. Definition of anemia: 13 gram in males and postmenopausal women and less than 12 gram in females. The incidence or prevalence increases as the CKD stages increase, and it's very high in patients who are on dialysis. The potential causes could be multiple. Main important ones being apodeficiency, iron deficiency, acidosis, hyperparathyroidism, and some uncommon ones. The rarest being what is called PRCA, pure red cell aplasia, that forms as a result of antibody formation to erythropoietin. The question being asked is, more often being asked, that does anemia accelerate CKD progression? To date, there is no evidence. However, there has been association. It has been seen that anemia is associated with faster decline in kidney function, doubling of serum creatinine, and progression to kidney failure and requirement for kidney replacement therapy. The table on the right side shows so many things that are associated with anemia. So with those things in mind, it becomes important to treat anemia adequately in CKD population. Benefits, as we can all understand, it increases by increase in hemoglobin, we improve quality of life. Whether that translates to mortality benefits is still unclear. This is monitoring frequency for anemia. We all do much more frequently than this. In CKD5 dialysis patient, we generally do monthly, whereas recommendation by KDIGO is every 3 months. So we are probably more active or proactive on this front. This slide will be a bit difficult to read. I know the fonts are very small. This define iron deficiency and severe iron deficiency. So if I can read it out. Okay. Basically, it describes in terms of serum ferritin and transferrin saturation. So there used to be terms like absolute iron deficiency and functional iron deficiency. These terms have been changed now, but the meaning is the same. By functional iron deficiency, we mean ferritin is adequate, whereas transferrin saturation is still low. And in absolute iron deficiency, both ferritin and transferrin saturation both are low. Okay, we can skip this slide. This is the thing. Now the absolute iron deficiency term has been replaced with systemic iron deficiency. Here the ferritin is low and TSAT is low. The absolute numbers varies as per the stage. The ferritin less than 100 nanogram per ml and okay. TSAT less than 20. This is in brief the iron regulation happening in the normal and anemia. Here the two molecules are important. There are many, but two molecules are important. One is hepcidin and another is ferroprotein. In hepcidin, in brief, it's a negative regulator of iron metabolism. In iron deficiency states, hepcidin decreases and makes more iron available. Wherein in iron toxic states, the reverse thing happens. Can someone help me? It doesn't move. क्या है देखो आगे नहीं बढ़ रहा. Yes. हो गया. So these are the latest KDIGO recommendation from 2026. Recommendation 2.1 in people with anemia and CKD G5 receiving hemodialysis, we suggest to initiate iron therapy if ferritin level is less than 500 nanogram and TSAT is less than 30. This is recommendation 2.1. Recommendation 2.2 in people with anemia and CKD5D who are initiating iron therapy, we suggest using intravenous iron rather than oral iron. So dialysis patients, if they are iron deficient, they should be given IV iron. In people with CKD 5D in whom iron therapy is being initiated, administer iron using a proactive approach to maintain stable iron status. Proactive approach will come few slides later. That is based on this pivotal trial. Recommendation 2.3 in people with anemia and CKD not receiving dialysis or those patients who are on peritoneal dialysis. We suggest initiating iron if ferritin is less than 100 and it's not or, it's and TSAT less than 40%, or ferritin more than 100 and TSAT 25%. Recommendation 2.4 in people with anemia and CKD not receiving hemodialysis in whom iron is initiated, we suggest using either oral iron or IV iron based on person's values, preferences, degree of anemia and iron deficiency, and relative efficacy, tolerability, availability, and cost. Here we have to make a judgment, keeping the patient's preferences in mind. Practice point 2.2 in people with CKD treated with iron, it is reasonable to withhold routine iron if ferritin is more than 700 or TSAT more than 40%. This is usually, this question is asked, when should we withhold iron or discontinue iron? So the absolute values are ferritin more than 700 and TSAT or TSAT more than 40%. We must discontinue iron. In people with CKD and profound iron deficiency, that is ferritin less than 30 and TSAT less than 20, but no anemia. Here, this is an interesting condition. Consider treatment with oral or IV iron. Now, many may not disagree with this point, that if there is no anemia, if hemoglobin is adequate, why do we want to give iron? The point is that they want to replete the iron stores. So here, even if the patient is not anemic, one should give iron. Again, it may be oral or IV. Recommendation 2.4. In people with anemia and CKD not receiving dialysis, in whom iron is initiated, we suggest using oral iron or IV iron, again based on patient's choices. And in people with CKD treated with iron, it is reasonable to hold same thing if the ferritin is more than 700. Now, what will be the recommendation regarding IV iron despite high ferritin? Here, the KDIGO recommends that consider a trial of IV iron in patients with TSAT less than 20% and ferritin 700 if they have refractory anemia or they have got high erythropoietin requirements. This is one of the conditions what we call functional iron deficiency. This is the pivotal trial. This was published sometimes in 2018, and it tried to look for proactive high-dose IV iron versus reactive low-dose IV iron. It was basically a non-inferiority trial. They came out with a conclusion that proactive high-dose iron significantly reduced major cardiovascular events and heart failure hospitalizations. Benefits were achieved without increasing infection risk, which is one of the risks of IV iron, over a median follow-up of 2.1 years. This is one of the practical points. If IV iron has been administered or blood transfusion has been given, we should avoid doing TSAT for up to 2 to 4 weeks, as it may be falsely high. Iron formulations and dosing again depends on place and preference. In the West, they are still using iron dextran, which we have largely discontinued. Here, now we are mostly confined to either iron sucrose or iron carboxymaltose or iron isomaltide. There is not much difference in terms of efficacy or side effect. They claim that hypersensitivity reaction to IV iron is lesser in iron carboxymaltose or isomaltoside compared to iron sucrose. Iron dextran is largely has been discontinued in our part of the world. Almost same thing. This we are not using at the moment, particularly the IV one. Reactions to IV iron, we all know that. Now the hot topic, erythropoiesis stimulating agent, HIF, PHI, or simply erythropoietin. HIF stands for hypoxia inducing factor prolyl hydroxylase inhibitors. The brand names we are all aware. As per recommendations, up to date, do not recommend HIF things in non-dialysis patients. while this FDA, they have approved it in dialysis patients, couple of molecules, not the molecule that is available with us. Mechanism of action we all know. So the practice point, they say, in people with anemia and CKD, whether receiving dialysis or not, the decision to use erythropoiesis, ESAs or HIF, PHIs to raise hemoglobin should be made through a shared decision-making process, considering each individual's symptoms, potential for harm from red blood cell in transfusions, and potential risk of adverse effects. The slide informs that the efficacy of ESH is almost similar. Safety remains uncertain, especially in non-dialysis CKD patients, and that's why UpToDate doesn't recommend it. Some HIF, PHIs may increase major adverse cardiovascular events and vascular excess thrombosis. Daprodustat and Vetadurestat, FDA approval only for dialysis-dependent patients. The molecule that we are using here, it's not available in US. So major events are thrombosis. It may result in stroke, it may result in MI, or it may result in clotting of vascular access for dialysis. These molecules, mainly they are preferred by the patients for oral route. It can be considered in where erythropoietin or darbepoetin, they are less effective or hyporesponsive. It has not been studied, and it's not recommended for pregnant patients. One usual question comes, can we combine ESA, that is erythropoietin or darbepoetin, and these HIFs? The answer is clear-cut no. They do not recommend combining ESAs and HIFs. The usual risk, that is high cardiovascular or thrombotic risk, consider ESA when HB is 9 gram or lower. And they recommend that it should be promptly discontinued or dose reduced when the hemoglobin is 10 or more. All in all, they suspect or they suggest that HIFs may have more thrombotic event and thrombotic risk compared to erythropoietin and darbepoetin. We all know that we should not target very high hemoglobin in CKD patients, whether on dialysis or not. 11.5 is the usual maximum point that we should go. We try to keep it around 11, and if we increase hemoglobin beyond 11.5, they have shown increased mortality, increased CV events, and vascular access thrombosis. Risk is greatest in congestive heart failure and ischemic heart disease. And another side effect, important side effect of erythropoiesis stimulating agent is increased hypertension or increased risk of accelerated hypertension. Almost similar thing, nothing. In cancer patients who are having CKD, they suggest that consider ESAs for chemotherapy-associated anemia when treatment is not curative and HB is less than 10 gram. If the treatment is curative, they suggest to withhold it. Not recommended for most non-chemotherapy associated anemia except selected low-risk MDS patients. Maintenance therapy, almost same bit of repetition. The target hemoglobin should not be higher than 11.5. Same thing. Dosing they recommend for erythropoietin, it's 50 to 100 international units per kg per week. We can start with lower dose, that is 50 milligram, 50 units per kg, and then we can go up to 100. In rare cases, we go beyond that. For darbepoetin, it's in the microgram, 40 to 100 microgram per week. ESA's range is a bit broader. We can go up to 150 or even higher. Almost similar thing, monitoring. We should stick to the higher hemoglobin level. So this is the question, million-dollar question, should we combine ESA and HIF? No RCT supported combined ESA and HIF. Limited data suggests possible ESA dose reduction if we combine. But they are very clear that it's not recommended routinely due to insufficient evidence. Does it cause more harm? The answer is we do not know. Generally, ESAs or HIFs, they start working after 2 weeks. So the recommendation is to start monitoring after 2 to 4 weeks, and in stable patients every 3 months. That should be okay. These are the various molecules. The colored one is a molecule available in our part of the world and being used quite frequently nowadays, I will say increasingly. Ease of taking, no need for injections, and price compares favorably with available injectable agents. So, ESA hyporesponsiveness is defined as failure to achieve target despite high ESA dosage. It has been associated with increased cardiovascular events. Kidney failure and mortality can be acute or chronic. Chronic is defined by more than 4 months. No cause has been identified in more than 30% of cases. Commonest causes are iron deficiency, inflammation. You may add parathyroidism, secondary hyperparathyroidism, metabolic acidosis, and other vitamins deficiencies. Again, the dose of ESAs and HIFs may be increased after you have ruled out iron deficiency and all the deficiency things. This is treatment algorithm, and this will depend a lot on the practicing nephrologist and physician. By and large, it's replete the iron stores, give erythropoietin or darbepoetin in recommended doses. Doesn't work, you may try replacing with HIFs. Rare cases, you may combine it, though it's not recommended. Practice point 3.7.3, in people with anemia and CKD, if a decision is made to use HIF for the treatment of ESA hyporesponsiveness, use the lowest dose that alleviates anemia-related symptoms or reduces the risk of requiring an RBC transfusion. Many of the points are being repeated. I'll skip those. Blood transfusion. When do we consider blood transfusion? In people with anemia and CKD, base the decision to transfuse on symptoms and signs caused by anemia rather than an arbitrary hemoglobin threshold. And we all have experienced, usually 7 to 8 is the cutoff line. Sometimes we transfuse when the hemoglobin is less than 7 in a patient who doesn't have any cardiovascular problem, and in less than 8 when patients have coexisting cardiovascular problems. Risks, we know all the fancy names, TRALI, TACO, infections, allosensitization, iron overload, and all those things. For a potential or prospective kidney transplant patients who is on dialysis or who is not on dialysis but planning to go for transplant, we try to avoid blood transfusions because it increases the risk of allosensitization. So we should try to avoid as much as possible. In those cases, sometimes we maintain the patient even on 6 or 7, and we try to expedite the transplant process. One confusion is that washed RBCs or leukodepleted, does it prevent sensitization? The answer is no. So there should not be any confusion about that. And obviously, more transfusions, more the risk. Almost same thing. The second point, it's clearly written that leukoreduction does not prevent HLA allosensitization, and we should remember this. Almost same things. The numbers. Restrictive transfusion strategy preferred in stable hospitalized adults in whom hemoglobin is less than 7 gram, hemoglobin less than 7.5 in cardiac surgery, hemoglobin less than 8 in orthopedic surgery, or significant CVD. Same thing. Thank you.
Hello. Yes, thank you very much, Dr. K. M. Sahu, for a nice presentation of anemia with CKD. Friends, ladies and gentlemen, it is open to the House. Any question? Yes.
Thank you very much, Dr. Sahu. I have a small query. What is the place of hypoxia inducible factor in the management of anemia, and at what level we should start, under what condition we should start, in what doses? Hypoxia inducible factor, and which one is superior, your erythropoietin or this molecule?
I believe most of the points have been covered in the presentation.
Dr. Sahu, you can add my question also with him. Is there any study comparing the erythropoietin and the HAF factor stabilizer?
So the indication for starting ESA or HIF is after you have repleted the iron stores, you have ruled out other deficiency factors, and still hemoglobin is not increasing. And in absolute numbers, 9 or less than 9. Sometimes when we are aggressive, we try to start the ESAs at an hemoglobin of 10, which is a bit more aggressive. So 9 will be a more reasonable level. If hemoglobin is 9, and you have ruled out all deficiency factors, iron deficiency, B12, folate, parathyroid, hyperparathyroidism you have ruled out, or you have corrected metabolic acidosis. So for erythropoietin, it's 50 to 100 units per kg per week. Let us transfer. If a patient is something like 60 kg, which is typical of our patient, so 60 times 50, it becomes around 3,000. So 3,000 units of erythropoietin sub-Q in non-dialysis per week. And you may increase, you may go up to 100, that is double the dose in heavier patients. So that will be around 6,000 units. Heavier patients, you may go up to 10,000 units per week. But the dose must not be increased before 2 weeks or preferably after 4 weeks, because that is the time it takes to work. So that is, HIF is by and large, you can say that it's an oral alternative to erythropoietin. Head-to-head trial, sir, I am not aware. Combining, there have been trials with combining them, but head-to-head good RCT, I am not aware. If it's there, someone can correct me. The dose of HIFs in terms of the desidustat that we have available here, we start with 50 milligram 3 times a week. And we can go up to 150 milligram again in a graded manner. 2 to 4 weeks gap, make 50, 100, again wait for 2 to 4 weeks, go up to 150. After that, if it's not responding, increasing the dose further may not be helpful, rather it may have deleterious effects. So if I have covered this thing, anything else?
So thank you, sir. And now with this question, we are going to conclude this session. Thank you, sir, for nice.
Thank you very much, Dr. K Lohani ji. For my physician friends, 2 important cause: erythropoietin deficiency, because of not producing, kidney is not producing it. And second, at least in Bihar or in our Indian settings, chronic iron deficiency, which is in absolute in nature, so showed by the decreased ferritin level and decreased transferrin saturations. For physician friends, we need to go first replacement of the iron deficiency, and then to go for EPO. That is one of the most important message that I want to deliver. Thank you very much, and we conclude the session.
Thank you, Speaker sir and Chairperson sirs. And I request the Speaker and Chairpersons to kindly move on to the award presentation podium nearby the main stage. And moving on to the next, I would also request Dr. Professor A N Rai sir. Dr. Professor A N Rai sir, kindly felicitate the Speaker and Chairperson sirs. Now moving on to the next session, the third session, and I would like to call upon a stage the chairpersons, Dr. Professor K K Lohani sir, ex-HOD from Netaji Subhas Medical College, Medicine Department, Bihar, and Dr. L K Prasad sir, ex-HOD Medicine from NMCH Patna, and Dr. Kamlesh Kumar sir, he is present HOD Medicine from our own NMCH Gaya, and Dr. Nisha. Please come on the stage. And the speaker for the next session is our own Dr. Pankaj Hans sir, who is the president of ISNEZ and is the man behind this conference. I would privileged to call Dr. Pankaj Hans sir on the stage, and all the chairpersons kindly come on the stage. As we are running 1 hour late, more than 1 hour late approximately. Now Dr. Pankaj Hans sir is going to talk on the breakthrough medication we all know. So I would like to hand over the mic to respected chairperson sirs to start the third session. Thank you.
Good afternoon, everybody. And myself, Dr. L K Prasad, a physician. My coming to this conference is to enrich my knowledge about the kidney diseases, and also since Dr. Om Kumar is the first speaker of early detection of the CKD, That was my interest also. So we have learned 2 sessions. Now the third one is the Dr. Pankaj Hans is speaking of phenomenon, a breakthrough in the heart and lung and the kidney disease. So we already discussed about the pillars of the CKD treatment, and the third one is this phenomenon, mineralocorticosteroid antagonist. So we have got few studies like Vidilio study, Picado study. We also the beneficial effect of this molecule in kidney disease and the heart prevention. So with this word, I just request Dr. Pankaj to have his speech.
Thank you, sir. Honorable chairpersons, respected, it is not moving actually, respected seniors and dear colleagues. The topic of my presentation is about finerenone and its role in mainly cardiac and renal protection, disease modifying therapy. And I shall be discussing it under these headings. So as we all know, that type 2 diabetes, that is a leading risk factor for the onset and progression of cardiovascular and kidney diseases. So far as cardiovascular diseases are concerned, there is a 2 to 3 times increased risk with higher rates of hospitalization and survival. And in Indian context, 37% is the prevalence of albuminuria in diabetic patients, and there is 10 times higher prevalence of CKD5 in diabetic patients as compared to a non-diabetic patients. We all think that less than 30 milligram per gram of UACR is normal. But just see in the first slide that if it is more than 10 milligram per gram, the cardiovascular mortality starts increasing. So we should start targeting therapy even if the patient is not having moderately or severely increased albuminuria. Similarly, if GFR is less than 75, just see this cardiovascular mortality starts increasing, and at the GFR of 45 there is a steep rise. The GFR suddenly starts decreasing and cardiovascular mortality increases. In the morning we have listened to Dr. Om Kumar that albuminuria is more important marker. So at all stages of GFR, whether it's more than 90, that is stage 1 CKD, between 60 to 90, that is stage 2 CKD, and stage 3 and 4 CKD. Higher the albuminuria, more is the cardiovascular mortality. That is being shown over here. So international guidelines recommend about screening at least annually. We have already knowing this from the first talk by using urinary albumin creatinine ratio and eGFR. But if the patient is a high risk patient with UACR of more than 300, or if eGFR is less than 60, then in these case patients it should be screened annually. Sometimes even 3 monthly screening is also needed. So for the definition of CKD, we all know that it is a structural or functional defect persisting for more than 3 months with implication upon the patient's health and eGFR less than 60 ml per minute. Either of the two should be present. In the functional defect comes this albuminuria, and that is more important than the renal function. That is to be we should always try to target, if we have to target one thing, albuminuria or GFR, you should always target albuminuria first over the targeting this GFR. So this gentleman, just see, is having a G2 category, 62 ml is the GFR, and proteinuria is A1. The heat map is showing that it is in green zone. Now the same person, if this proteinuria increases to 350 milligram per gram, the same person who was in the green zone is now shifting to the orange zone. That is, the heat map is now showing that progression of CKD might occur rapidly in this subset of patient. So more than GFR, it is albuminuria that is mattering for the patient. So far as CKD, heart failure and diabetes mellitus are concerned, they are interrelated. And risk factors are also common. If one is there, one is increasing, other is bound to increase. If you are treating one, the other will also improve simultaneously. And the common risk factors, they include obesity, inflammation, and vascular diseases. And for diabetes and CKD, it is older age, male sex, hypertension, and smoking that is to be targeted from the very beginning. So for this MR activation, which contributes to, now we have got drivers of CKD and CVD that includes metabolic and hemodynamic factors that we are knowing since decades. Recently, inflammation and fibrosis has been proposed as another newer driver for CKD and CVD, and that is for this inflammation and fibrosis, it is mineralocorticoid receptor overactivation which is responsible, which is caused by aldosterone, cortisol, oxidative stress, and higher degrees of albuminuria. And because of this, all these pathogenic mechanisms, it leads to kidney failure and heart failure. So we should have a drug which causes MR overactivation blockade, and such a drug is finerenone, which blocks the recruitment and binding of transcriptional cofactors, ultimately reducing inflammation and fibrosis. That ultimately culminates into kidney and heart protection. So this slide is showing that the famous renal trial that came about 2 decades ago that compared placebo and losartan. Even after using losartan, this residual risk was there. Now if we use canagliflozin along with ACE inhibitor and ARB, the residual risk is little reduced. DAPA plus ACE inhibitor or ARB, it is further reduced, but the residual risk is still it is there. That can be taken care by finerenone. Now finerenone is a bulky non-steroidal MRA. It has got a higher potency, highly selective for mineralocorticoid receptor, and has got no breast-related side effects like gynecomastia. Half-life is just 2 to 3 hours with no, because of no active metabolites, there is lower risk of hyperkalemia, and effect on BP is very mild or no effect at all. And it is most commonly used in CKD associated with type 2 diabetes mellitus. But this doesn't mean that we should stop using spironolactone altogether. Spironolactone still has got edge in heart failure with reduced ejection fraction, in resistant hypertension, in primary hyperaldosteronism, and moreover it is a cheaper drug as compared to finerenone. So just in this slide, finerenone has been compared with spironolactone. Finerenone causes lesser reduction of blood pressure as compared to spironolactone, and hyperkalemia with spironolactone is higher as compared to finerenone. So when we should use finerenone and when should we avoid it? The 5 F's we have been studying in our medicine classes, the causes of abdominal distension, fat, fluid, feces, etc. The similar 5 F is there for finerenone also. Initiate treatment when serum potassium is less than 5. Withhold treatment when potassium goes above 5.5. Initiate treatment when eGFR is more than or equal to 25. And finerenone reduces the risk of ESKD by 1/5. And finerenone reduces the risk of heart failure by more than 1/5. So F is there in all the 5 conditions. So the number of trials are there. The famous Figaro and a trial, and the Fidelity trial basically, that is a combination, the pre-specified analysis of individual data from Fidelio DKD and Figaro DKD trials. The eligibility criteria included type 2 diabetes, CKD, the patients on maximum tolerated dose of single RAS inhibitor, and serum potassium less than 4.8, and the patient must not be having symptomatic heart failure with reduced ejection fraction, because these patients are already on spironolactone or other drugs. The GFR range was also very wide in such group. And the key outcomes are the cardiovascular outcome, time to cardiovascular death, non-fatal MI, non-fatal stroke or heart failure, and more than 57% eGFR reduction from baseline, kidney-related death or kidney failure. This was about the patient characteristics. So in fidelity, on the top of RAS inhibitor, finerenone has been shown to reduce the cardiovascular composite by 14% and kidney composite by 23%. That is the advantage of using finerenone in DKD. Finerenone has been shown to reduce all-cause mortality as well as cardiovascular mortality in this subgroup of patients. Finerenone has been shown to reduce sudden cardiac death, that is reduced, just it is over there, but it doesn't reduce death due to acute MI, it doesn't reduce death due to cardiovascular procedures or other cardiovascular causes. The other two trials, Fidelio and Figaro. Fidelio trial, the main thing was, the primary aim was the kidney disease risk reduction. In Figaro, it was about cardiovascular reduction. And the primary endpoint of Fidelio was the secondary endpoint of Figaro and vice versa. The Fidelity trial we have already discussed that finerenone reduced the risk of cardiovascular morbidity and mortality by 14%, and finerenone reduced the risk of CKD progression by 23%. This drug has been shown to reduce the risk of heart failure. It is class 1A recommendation. It reduces heart failure in this risk of first heart failure by 22% and new onset heart failure by 32%. If we start finerenone just at the end of 4 months, the eGFR reduces by 32%, and our aim is to reduce eGFR by 30% so as to get maximum benefit out of it. And this benefit persists throughout. So that is the benefit of using finerenone earlier. Now all drugs have got some side effects, but the side effects of finerenone is comparable to placebo. Just see any adverse effect, acute kidney injury, gynecomastia, all things are similar to placebo. There is no change in HbA1c. Hyperkalemia is definitely a bit higher. Hyperkalemia is higher, but hyperkalemia leading to permanent discontinuation and hyperkalemia related to death, it is not there. So when we have to start finerenone, first thing I told earlier also, check potassium. If it is less than 5, then you check the eGFR of the patient. If the eGFR is more than 60, start in a dose of 20 milligram. If it is between 25 to 60, start in a dose of 10 milligram. Monitor potassium at month 1, month 4, and thereafter every 4 months it should be monitored. If serum potassium remains below 4.8 and you have been using the dose of 10 milligram, increase it to 20 milligram. If you have been using 20 milligram, continue with 20 milligram dose. If it is between 4.8 to 5.5, you continue with the same dose 10 or 20 that you have started. And if potassium increases to more than 5.5, you just withhold finerenone for some time, let potassium go below 5 and then start in a lower dose and do monitoring once again like that. This finerenone, this is a fine arts heart failure, Fidelio and Figaro trial that has shown that finerenone reduces death from any cause, cardiovascular death, heart failure hospitalization, and composite kidney outcomes. They all are significantly lower in finerenone group as compared to placebo. The second important trial is confidence trial that of late came 3 to 4 months ago. In this, a combination of finerenone and SGLT2 inhibitor has been shown to decrease albuminuria more than either treatment all alone. The inclusion criteria included eGFR of 30 to 90, UACR between 100 to 5,000, type 2 diabetic patients with a HbA1c of less than 11, and patients on clinically maximally tolerable dose of ACE inhibitor or ARB for more than 1 month. Exclusion criteria were type 1 diabetes, potassium more than 4.8, heart failure patients, and patients who have been treated with any MRA or SGLT2 inhibitor within 8 weeks. This was the protocol of the study. Initially, day minus 14, the patients were stratified that whether the UACR is more than 850 or less than 850, whether the GFR is more than 60 or more less than 60. Then the patients were divided into 3 groups. One group was Finrenone with EMPA, second was Finrenone with placebo, third was EMPA with placebo. The study was continued till 180 days. Then there was a washout period of 30 days, after which the primary efficacy endpoint of relative change of UACR from baseline to day 180 in the 3 subgroups was studied. The study was carried out in 14 countries at 143 sites with 818 participants, almost equal number of participants in all groups, few drops out in all groups. And it was found that, and this was about the patient demographics, average age of 67, predominantly male patients, systolic blood pressure of 135, relatively higher BMI of 29, predominantly Asian patients, mean eGFR of 54, and majority of patients were, 98% patients were on ACE inhibitor or ARBs. Now the end points of this study were the simultaneous initiation of Finrenone and SGLT2 inhibitor led to early reduction of UACR. With only Finrenone, this reduction was at end of 4 months. And with simultaneous usage of Finrenone and SGLT2 inhibitor, this reduction of 30% we got at the end of 14 days only. Now the simultaneous initiation of Finrenone and SGLT2 inhibitor led to early and additive reduction of UACR that is going to further improve with passage of time. And 70% of patients, they achieved 30% reduction of UACR, that is the target, with simultaneous initiation of Finrenone and SGLT2 inhibitors, and 55% of patients even fare better. They get more than 50% reduction of UACR with simultaneous initiation of these 2 drugs. And there is numerically lower incidence of treatment emergent hyperkalemia when combination therapy is used. With Finrenone alone, the incidence of hyperkalemia was 11.4%. With the combination of SGLT2 inhibitors and Finrenone, it is 9.3%. So the incidence of hyperkalemia is also, it is because of distal sodium delivery that promotes kaliuresis. Distal sodium delivery is the effect of SGLT2 inhibitor that promotes kaliuresis and potassium level decreases. Treatment emergent hyperkalemia events leading to permanent discontinuation of the drug, grossly uncommon, and the adverse effects profile was similar in all groups. Mean change of blood pressure, there is slightly additive impact upon the systolic blood pressure. Just see on addition, the BP falls slightly more, not much difference between the BP, but incidence of symptomatic hypotension is quite low, even after combination. This initial eGFR decline that was there, that improves later on after this drug withdrawal. So that is yet another effect of this. Low incidence of AKI, just 1.9% in the combination as compared to 1.1% with Finrenone alone. Now this is a very important slide, that if you use RAS inhibitor and SGLT2 inhibitor, you can delay this ESRD by almost 15 years. If you add NSMR, that is Finrenone, it can be further delayed by 12 years. So whether to use this Finrenone or not, it is upon you to decide. You are giving the patient this GFR below 10, that is end stage. The patient is getting a life without need of dialysis or transplantation of almost 12 years by addition of Finrenone in the beginning. So whether to use or not, it is but it is advocated that it can be used. Here also the same thing is being shown. If we use Finrenone in the beginning, the green one is Finrenone. If we use just residual risk is much less, and just see the green arrow, that is, it is on the bottom and the progression is much slow, residual risk is much reduced if we use Finrenone from the very beginning. So the takeaways from confidence trial is that simultaneous initiation of finrenone and a SGLT2 inhibitor provides early and additive effects on UACR reduction that are statistically and clinically significant, and symptomatic hypotension, acute kidney injury, and hyperkalemia leading to drug discontinuation are uncommon. Regarding the pillars, 4 pillars of type 2 diabetes and CKD, we all know ACE inhibitor or ARBs, SGLT2 inhibitors, non-steroidal MRAs, and GLP-1 receptor analogs. How to use these 4 pillars? So the traditional approach was to start with a 3 month of ACE inhibitors, titrate to maximum dose, then you add SGLT2 inhibitors, re-evaluate albuminuria for 6 months. If you don't get any such satisfactory reduction, then you add finrenone. Again, you titrate dose over next 6 months and re-evaluate for albuminuria. Then you add finrenone then you add GLP-1 receptor agonist and then titrate. So 6, 6, 12 and 6, 18 months will be needed in the traditional approach for adding all these 4 pillars. Then in high-risk patients, it is suggested that we should go for an accelerated approach or rapid sequence approach. In the accelerated approach, the time frame has been reduced, 3 months of ACE inhibitors and SGLT2 inhibitors combined, and 3 months of this finrenone and GLP-1 receptors combined, and 4 months of titration of the dose. Altogether in 10 months, all these 4 drugs are added. And a further better approach is a rapid sequence approach. That is ACE inhibitor, non-steroidal mRNAs, GLP-1 receptor agonists, and SGLT2 inhibitors. All these drugs to be added in the first 3 months only, and titrate the drugs in the next 6 months. And in which sequence you will add these drugs, that depends upon the presence of comorbidities that are present in that patient. So all these recommendations, whether it is ADA, AAC, KDIGO or AHA, they recommend that finrenone should be used for reduction of CKD progression and cardiovascular events. So in the confidence trial and by talk, the key takeaways are guidelines recommend both eGFR and UACR testing at least annually for comprehensive CKD screening, barring few patients with a higher risk factors in which it is to be done 3 to 6 monthly. Early stage CKD management is frequently missed, yet appropriate intervention can slow or halt the disease progression. Despite a standard RAS blockade and SGLT2 inhibition, patient still remains at a significant risk for CKD progression. Mineralocorticoid receptor overactivation that drives inflammation and fibrosis, representing a key therapeutic target for CKD progression. Finrenone targets MR overactivation and effectively slows both heart and kidney disease progression in type 2 diabetes patients. And finrenone demonstrates efficacy in slowing CKD progression and preventing cardiovascular events with good tolerability across all CKD stages. So we all are dealing with finrenone in diabetic patients. Has it got any role in non-diabetic CKD? Yes, nowadays role has of late come. This is the FIND CKD trial. This trial was done for 32 weeks. Yesterday only, in the yesterday released NEJM, this has been shown that this is from NEJM only, that if we use finrenone in non-diabetic patients, initially there might be change in the GFR, slightly GFR might fall, but ultimately there is gain above the placebo. And just see the bottom one, at the end of first 3 months, the GFR is less in patients with finrenone. The fall of GFR is more in patients on the finrenone, but later on the completion of a study, it is less in the finrenone group. And finrenone has been shown to reduce composite kidney and cardiovascular outcomes. It reduces composite kidney outcomes. It reduces composite cardiovascular outcomes in non-diabetic CKD also. And in IgA nephropathy also, finrenone has got role. this slide definitely shows that if we use a combination of SGLT2 inhibitors and finerenone in biopsy-proven IgA nephropathy patients, the proteinuria decrease is much more as compared to use of either drug alone. And this additive effect of DAPA and finerenone on albuminuria on non-diabetic CKD has been shown in yet another study in which 4 weeks of DAPA or finerenone followed by 4 weeks of combination of the two was used in non-diabetic CKD, and it has been shown that proteinuria reduces 36% in the combination group, but the fall of GFR is more in the combination group. Now, this is a very interesting slide. Which drug to use first, DAPA or finerenone? If we use DAPA and then finerenone, then the preservation of fall of UACR is more. But if we use finerenone first and then we add DAPA, then we see that fall of UACR is not as much as it was adding finerenone to DAPA rather than adding DAPA to finerenone. And this finerenone has also been shown because of air pollution also, there is increased incidence of adverse cardiovascular and kidney events, and finerenone has shown to lower the relative risk of composite cardiovascular and kidney outcomes versus placebo because of air pollution. So I wanted to just emphasize upon that finerenone has got a role not only in diabetics but also in non-diabetic CKD. And thank you for your patient listening.
Dr. Pankaj, yes. First of all, let me congratulate you for a very, very interesting description of finerenone.
Thank you, sir.
You have explained everything very nicely. But I'm asking you this question because you are professor of medicine, at the same time a well-established nephrologist in Patna. So you have got experience of both worlds. We have got many cases who has got diabetes, hypertension, patient is on RAS blocker, statin, dapagliflozin, and metformin. There is no albuminuria, ejection fraction is normal. In such type of patient, I mean established patient of diabetes and hypertension, should we start finerenone or we should wait for something to develop then start it?
So this question is very difficult to answer, but in one of my slides I have shown that even if the UACR is 10, there is a rise of there is increase in the cardiovascular events. So just to decrease these cardiovascular events, one may add finerenone, but there is no as such any recommendation regarding this.
And the second question is again a very practical problem. Finerenone is a wonderful drug, there is no doubt about it. After RAS blocker and SGLT2 inhibitor, perhaps this is the best thing which could happen in the management of nephrology and cardiology. But the fact is it is a costly drug. So in patient who cannot afford it, is spironolactone a poor man's finerenone?
Spironolactone I have shown you, sir, that it causes a greater fall of GFR. It causes more of hyperkalemia in these CKD patients. And moreover, I have shown in one of my slides that if we add finerenone, we can delay ESRD by almost 12 years. So adding a drug which is costing just 100 rupees a day and delaying ESRD by 12 years, I think everyone will say that it is better to delay ESRD rather than avoiding finerenone.
Dr. Pankaj, what about the hypophosphatemia?
Hyperphosphatemia. Hyperphosphatemia, sir, if it is present in any patient of CKD, it has to be targeted because it will just not only promote this mineral bone disease and hyperparathyroidism. All the consequences of CKD, they are related to it. So it has to be targeted. Finerenone relation with hyperphosphatemia. Sir, I am not aware of this.
Hello, sir. Sir, if the patient is using both RAS blocker and finerenone, and if patient develops,
yes.
If the patient develops hyperkalemia, so which drug we should stop first, or straight away?
Actually, when we are using RAS inhibitors, it is very interesting to know that all of us are using RAS inhibitors. But how many of us are using RAS inhibitor to its maximally tolerable dose? I think none of us. And in worldwide study, it has been shown that only 25% of nephrologists, cardiologists, and physicians, they are using RAS inhibitors maximally because of fear of hyperkalemia. So development of hyperkalemia should not stop you from prescribing RAS inhibitor or this finerenone. You add a potassium binding resin and just continue with RAS inhibitor and finerenone. This will help the patient better than avoiding RAS inhibitor or finerenone.
I have a comment. The Americans and the Europeans, they dictate the terms and we follow them. Yesterday we had a CM in Patna. I talked about a lifestyle modification as fifth pillar, but I have to add something more here today. All these 4 pillars, how did they get the position of pillar? They were in steps, step 1, 2, 3, 4, then they become the pillars. Now there are again 4 steps, that is management of hypertension, management of blood sugar, management of lipid profile, and lifestyle modification. In future, I predict that these 4 management will be added to another 4 pillars, and we will have 8. Thank you very much.
Thank you so much, sir.
Sir.
Now we can conclude.
One small confusion in my mind.
Question.
I am from Uma Shankar from Patna.
Sir, everyone knows you, sir.
You have very nicely explained the role of finerenone in diabetic CKD. But there is confusion in my mind why finerenone is not effective in non-diabetic kidney.
Sir, I have shown in my last few slides that finerenone is effective in non-diabetic CKD also.
But
In any GM that has been released yesterday, there is an article, Find CKD trial. That trial shows that finerenone reduces the composite risk of cardiovascular mortality and morbidity, renal mortality, morbidity, and combined cardiorenal mortality and morbidity in non-diabetic CKD also.
One question, sir. Sir, you suggested that it will take 18 months to establish the 4 pillars.
In the traditional approach.
So what is the harm if we start giving the benefit from right first day?
That is what I was trying to emphasize in the rapid sequence approach and the accelerated approach. We should try to use all the 4 drugs as early as possible.
Why not from first day itself?
From first day itself, because if we use all the 4 drugs simultaneously, there will be precipitous fall of GFR and the patient might develop acute on chronic kidney disease. So that is because of this, let the body get acclimatized to the drug one by one, and within a span of 3 months you add all these 4 drugs.
Thank you, sir, for the wonderful presentation. Moving along, now we are going to move forward to facilitation ceremony. I would like to request Dr. N Rai, sir, for Dr. Om Kumar, sir, for momentum. Now moving forward to, I would like to request our next chairperson for the session, Dr. Professor Pritpal Singh, Dr. Uma Shankar Prasad, who is former HOD at NMCH Patna, Medicine Department, Dr. Ashok Singh, Dr. Shahid Iqbal, Dr. Khushbu Rani. To conclude our scientific session, we welcome Dr. Prateek Das, who is Secretary of Indian Society Nephrology Eastern Zone and kidney transplant physician at Kolkata, who will speak on kidney transplantation, what physician should know about. Sir, the floor is yours.
Good afternoon, everyone. First of all, I thank the organizer for honoring us to chair this session. The topic of this session is kidney transplantation. What a physician should know. I am basically a physician, not a nephrologist, so I think I will learn much more from his talk. And the speaker for this session is a very powerful speaker, and he is the Secretary of the Indian Society of Nephrology, East Zone. He is none other than Dr. Prateek Das. So I welcome and invite Dr. Prateek Das for his presentation on kidney transplantation, what a physician should know. Over to Sir, Dr. Das.
Thank you, sir, for the nice introduction. In next few minutes of time, I will be talking on something which might be slightly technical for the physicians or might be too simple for the nephrologist. But I think the overview is important because in the era of, in this century, everyone should know something about the transplantation. So this transplantation is basically breaking the barrier. Our CKD patient means a conservative treatment using 4 pillars, doing biopsy, doing dialysis, but one step ahead to give a more valuable life to such patients is the transplantation. I can take this kind of patient which every one of us have probably seen. Initially, this is a 25-year male having a creatinine of 10.5, 46-year male who is a diabetic with a cardiorenal something, DCM creatinine of 8.5. This is a female having a postpartum AKI, subsequently developed CKD, or an elderly female who is a diabetic nephropathy. But common to these all 4 patients who have a high creatinine level and a low GFR, we call it CKD stage 5, or sometimes non-conventionally it is called an end-stage kidney disease. So these patients called CKD stage 5 because the GFR is less than 15. What is the implication of this low GFR? Whenever is a less GFR less than 15, life cannot be sustained without support. Means we have to give a support from outside. This life support can be a dialysis, maybe hemodialysis or a peritoneal dialysis, or this can be a renal transplantation. Only medicines are not enough. So this patient has a more, why this is important? Because this patient have a more chance of die prematurely. This patient have a reduced quality of life. Even they survive on dialysis, the quality of life is very poor. The high cost for the government and the public, private, every setup, they have a huge cost involvement in the treatment. There are lots of disability of this patient. There is a psychological harm not to the patient but to the family. At the same time, that high cost to the individual and family is to be borne. So if this patient develops CKD stage 5, this is a disease that should be a preventable disease, as Dr. Pankaj was discussing, because once it ends in a stage of stage 5, then everything, whatever the worst thing that can happen, that happen to the family, to the society. So I have chosen this patient from a huge number of the patients. You can see this is the worldwide prevalence of the CKD, and they are mostly due to diabetes, hypertension, etc. And this is almost 8,000 million patients. And they are increasing every day, and it is presumed that in 2040 it will be the 5th common cause of the death worldwide. Now it is the 10th common cause of the death worldwide, and the WHO has recognized is the most significant disease causing death in humanity recently. So CKD stage 5 is a deadly disease, and it is increasing day by day. It is distributed all over the world. You can see the dark regions, they have a higher prevalence. India is in between, just below the highest prevalence, and it is not less, it is 8.5%. So one patient in every 100 is having patients a CKD. So it is increasing day by day. So it's a huge burden. So something needs to be done for such patients. And this is an interesting slide. You can see that in the next few years, up to 2040, the mortality related to the cardiac disease or maybe stroke, maybe chronic lung disease, that may basically reduce. You can see this is a darker line that shows the projected rate of death, and the yellower lines, this is the recent rate of death. If you see the cancer and the CKD, the now present death rate will increase by 2040 as they are predictable. From 10th cause of mortality, it might be the 5th most common cause of the mortality. So if the patient develops in such situations, 3 options are there, because huge social and economics are involved in the treatment of such patients. Many of the patients, about almost 70 to 75% of the patients, they remain on conservative treatment, doesn't have access to dialysis. Even they get the access to dialysis, they cannot afford it. They can go for a conservative care. The early, some patients go to the dialysis, and only 4 to 5% of the patients, they can afford or avail the transplantation, and they go for a transplantation to increase their quality of life and the life duration. So these are the road ahead. These are the options: dialysis, transplantation, or conservative care. So what happens if you do an end-stage kidney disease patient to a conservative care? Even you can diagnose here, and if you go that by controlling the blood pressure, blood sugar, managing the anemia and other palliative care, protein restriction, at some point of time, you can carry over the patient, but after some time, patient will show every telltale sign of death. In those situations, palliative care should be done, and then there is a bereavement. This is not ideal to the physicians, but this can be an important part of the treatment of a disease which has socio-economic implication. And if you see that if the patient receives the dialysis versus transplantation, what will be the survival? If the patient has a survival, this is a 5 years follow-up data. This is you can see the patient remains on the dialysis, lower green line, they have a significant mortality. Compared to the patient is having a transplantation as the living donor, that is a higher survival in comparison to the patients of dialysis or a brain dead or a deceased donor transplantation. This is the survival benefit of the patients of the dialysis versus transplantation. So the yellow lines are the transplantation, and the blue bars are basically the dialysis. If the patient remains on dialysis, chances of survival is much less compared to the transplantation. So it is also cost effectiveness. If you compare 3 types, one is the conservative care, dialysis versus transplantation. Is one-time cost is higher in cases of the transplantation, but it is in the long run, the cumulative cost of treatment is much higher in the dialysis patients compared to the transplant patient. So by doing a transplantation of a patient who needs it and can afford it, can avail it, you will have a 68% lower risk of death, 3 to 4 times lower risk of the survival versus dialysis. If you do the preemptive transplantation, means thereby doing a transplantation without doing a dialysis, in those situations you will get another 2 years advantage, and the cost of treatment is lesser compared to the long-term dialysis and a long survival of some patients. So there is a non-negotiable rule. If somebody comes to you and he has been on dialysis for 2 to 3 years, there is every possibility you can prescribe such patients for a transplantation. The question should be like this: why should you asking the patient whether they want a transplant? You should ask them, why don't you have it done yet? That is important. The approach should be like that. The thinking should be changed in that way. If you think of the morbidity, mortality, and the cost involvement. And if you see the transplant versus hemodialysis data in Indian patients, you can see the survival, cost, and everything, because the dialysis facilities till few years back was not available to the remote areas, and the patients used to die for not availing the dialysis facilities. Way back in 2000, there was only 2 to 3 dialysis units per Indian city. Then in those situations, European countries had around 30 to 35 per cities. So the transplantation has done, it is called a miracle. It is published in New England Journal of Medicine, and they called it a miracle of the 20th century, like development of insulin is a miracle, and this is another miracle, organ transplantation. But the first 50 years of the century was not very much attractive. You can see this is all the people have tried, failed. And after that, in the 50s and 60s, the era came when the first successful renal transplantation was done. and it is in 1954 in between the two identical twins. Everyone knows the name of the Joseph Murray. This is a surgeon who got the Nobel Prize, but in between, in the middle man is a nephrologist. Hardly we know his name. This is a Joseph P. Merrill. He is a nephrologist involved in the transplantation. It was done between two identical twins, so they are genetically matched, and there was no immunosuppression was given. It was successful. For that, the surgeon Joseph Murray was awarded Nobel Prize following that in 1990s. Encouraged by that, the subsequent years, the lots of kidney transplantation was there, but that was not between identical twins, that between these the related or this other way related, unrelated, or one human being to another human being, the result was disastrous. You can see this is a 1960 publication which shows that out of 54 patients they got transplanted, only there is a 3 patient went home live. So this is a miserable one, until and unless there is development of some immunosuppression. If we go to the history of the immunosuppression, because if you want to do a transplantation between two persons, there is always a self versus non-self conflict. So you have to suppress the immunity of the recipient, whoever getting kidney, and that's why the kidney can be get accepted. So that once survival was almost 0%, it increased when the depleting agents or anti-T cell antibodies are first utilized. Then came the era of these calcineurin inhibitors, or the tacrolimus, or the cyclosporin. Those increase the survival of the transplantation by 1 year, it goes to 80%. And subsequently, now we have a survival of the kidney transplantation patients in the first 1 year of life is around 90%. This is not because of the development of the immunosuppression, but it is also we have now better surgical techniques, laparoscope, robots, and better surgical hands, better knowing of the anatomies. We have a better lab facilities because the immunological test can be done easily and as a cheaper cost. And we have a now very good infection control. That is one important thing. In a country like ours, we have better antibiotics, better diagnostic facilities, better culture facilities. So from a graft survival of 0% in the 1950s, now we have a more than 90% graft survival following kidney transplantation. So you can see this is a comparison study between long-term survival. Most of the patient, more than 90-95% of the patient survives in the immediate months of the post-transplantation. But what happens to them in the long run? This is a long-term survival, is a 20 years follow-up study of the kidney transplantation in different. This is a live donor and this is a brain-dead donor. You can see that the survival is almost 90% in the initial year. It becomes around 40 to 60%, in around 60% if the donor is alive, is a live donor, and is almost 40% if the deceased donor. And that happens to be a good care for the donor and the recipient. This is a recent New England Journal publication which shows what improved the survival of the patient, donor, and the recipient in a kidney transplantation. But the things are not very easy. This is a very complex kind of scenario, and we have so many. I have shown this slide yesterday also. There are lots of barrier to the transplantation. Immunological barrier is one of them. ABO antibody. ABO incompatibility was considered to be a contraindication to the transplantation. But here the rule, unlike the blood, the universal recipient and universal donor concept works. O can donate to anybody, AB can receive from anybody. And there is also the HLA system that is most important in the solid organ transplantation. And this test should be done before the transplantation procedure. And we overcome this procedure by doing the immunosuppression therapy that comes either in the immediate phase, that is a clearing the field by doing a removal of the antibodies, or can be an induction treatment, can be a maintenance immunotherapy, or the treatment of the rejection. Rejection is considered to be one of the important one of the important consequences of the transplantation. So this prevent this rejection, self versus non-self conflict always predisposes to a rejection. So rejection, anti-rejection drug has been developed over the time. You can see these 3 drugs, they are used as an induction treatment, means it is given in the day 0 of the treatment, or immediate post-transplant that prevent the infection. And other drugs are utilized in a tablet form in a longer survival of the patients. And this induction and maintenance immunosuppression therapy that has been changed over the time. Initially we used to use these depleting agents, and the ATG has gone up. There are so many drugs, I'm not going into the detail. And maintenance immunosuppression, you usually give 3 drugs. One is called calcineurin inhibitors, like cyclosporin or the tacrolimus. You can see the use of the cyclosporin has gone down over the years, and over the years, and the use of the tacrolimus has gone up because of the effectivity as well as the side effect. Azathioprine as an anti-proliferative drug, which are used previously, now has gone down. We use more of a mycophenolate mofetil, and steroid is an essential part of the transplantation, post-transplantation care. So mostly this patient remains on a 3-drug immunosuppression in the post-transplant period. So who can be a candidate? Is everyone is a candidate for the transplantation? Yes. Every patient who is suffering from end-stage kidney disease or CKD stage 5 is a candidate, except there is some contraindication. If the patient is having something which can get worse after doing the transplantation, suppose the patient having an infection like active tuberculosis or active HIV disease, they are not absolute contraindication, but as long as the disease is there and you do the immunosuppression post-transplantly, there will be an aggravation of the disease. And active substance abuse, this is considered to be one important factor. Most of the patients are defaulter of the drug, and substance abuse associated with so many comorbidities. In any way, the patient is having a chances of death due to their severe cardiac disease, pulmonary disease, as advanced CKD, very poor dilated cardiomyopathy, and unacceptable risk. The patient will not survive for more than more than 2 years' time if you do the transplant. If you do anything to such patients, doing a transplantation and utilization of the resources are not advisable for this. If the candidates avail, this is the ability to adhere to the medical. Post-transplant medication is important for the transplantation. If the patient is not in a mental steady state, so he cannot maintain himself, cannot take the drugs, in those situations it should not be done. And malignancy, you can see the immunosuppression aggravates infection, immunosuppression aggravates malignancy. So any malignancy which is active or treated in the recent times, another contraindication for doing a transplantation. So these are the patients, and recently KDIGO says that if the patient is having a multiple myeloma, that we can discuss. If the patient is having multiple, which were initially considered to be an absolute contraindication for the transplantation, kidney transplantation, now they tell if the disease remains in remission with or without bone marrow transplantation, you can go ahead, and following that you have to monitor and maintain and treat in the post-operatively. Rest I have already discussed. Advanced comorbidities which limits the life of the patient is a state where he should not do a transplantation. So these are the relative contraindications of this is kidney transplant recipient, of which I need to discuss. One is called a frailty. Suppose a patient is very frail, is on dialysis, and somebody, many of us also tell that if this patient is not doing well in the dialysis, is very frail, recurrent hospitalization, go ahead for the transplantation. No, the patient who do worse with the dialysis will do worse with the transplantation. And another some diseases which was initially considered to be an absolute contraindication, like the disease has a very high recurrence. Suppose a patient having a dense deposit disease or a complement mediated TMA, in those situations C3 glomerulopathy was initially considered to be an absolute contraindication, but now you can, the KDIGO tells that you can counsel them. There are the drugs available like eculizumab, and go ahead with the transplantations. Is the age is a barrier for the transplantation? Who can go ahead with the transplantation? Suppose the two extremes of the age. Yes, it has been seen if the baby is an infant, transplantation is always very difficult, technically difficult, immunologically difficult, and not very successful, because this patient have a very severe kind of disease and they have a genetic abnormality. So if the child gets at least crosses infancy, 1 year of age or a 10 kg of the body weight, in those situations the transplantation is advisable. At the same time, if you do go the transplantation of very elderly patient, sometimes it might not be successful, but the studies tell that in the elderly patient, if you do the transplantation is more successful. Why? Because immunologically they are down. You need a lesser immunosuppression. And this is a comparison between dialysis and a transplantation in a very elderly patient. They do worse with the dialysis, they do better with the transplantation. So infancy, no. In between is yes. And very elderly patients, we have to judge, is a good 65, good 75, there is no contraindication for the transplantations. This is a long term, this patient, if the elderly patients who the elderly patient do worse, if the patient is having a coronary artery disease, cerebrovascular disease, or having in a peritoneal dialysis, this is a report which shows these three groups of the elderly patient, they do worse with the transplantations. So then after the recipient, the second part is like a 4 pillar you are discussing. Second pillar of the transplantation is who can donate. It can be an either deceased donor. Deceased donor means patient is having a brain dead. This is unlike a body donation in the anatomy room. This is not like that. The patient is staying in a hospital on a ventilator. At the same time, due to some reason, his brainstem gets brainstem is dead. In those situations, other organs are active. These are the situations where the disease donation can happen. Also nowadays, this is happening. The patient is having a circulatory death also. And the second part is a living donor, means the patient is healthy and alive and willing to donate. So living donation, there is also age bar also is there. You can see below 18 years of the age, who is not an adult and cannot take decision by himself, is not eligible for donation of the kidney. Elderly patient, yes, they can donate, but with time our kidney function goes down. After 40 years of age, everyone loses kidney function 1 ml GFR per year. So if an elderly patient have a lower GFR, in those situations it is not advisable because there is a probability of worsening of the renal functions. Then it is irrespective of the sex, male, female is not different. Blood compatibility should be there. There should be a sound mentation. A mentally retarded person, psychologically inactive person. We get many families, one son is affected in CKD and needs a transplantation. The parents bring another son who is mentally abnormally schizophrenic or maybe mentally retarded and say, take his kidney because he is mentally retarded. He is of no use in the family. This is law says you cannot take kidney from such a person. He or she should be in a mentally fit position to donate. He should understand the meaning of organ donation. So medical fitness is important and they have to undergo the initial screening test followed by the test related to the transplantations, and ultimately you have to undergo the surgery. That has to be explained clearly that you have to undergo a surgery under general anesthesia and with some amount of risk involved in it. So the contraindications of having transplantation donation, this is written here, you can see I have shown that is less than 18 years, this is a busy slide. So patient who cannot donate is a high suspicion of having a kidney disease, the HLA and the ABO incompatibility. Type 1 diabetes patient cannot donate. So we can discuss about something about the diabetic patient, whether they can donate or not. So before taking a patient's kidney, the assessment is there that they are of two risks, whether they will develop an perioperative death or not. Perioperative risk of anesthesia and surgery will not be there, that it should be tested and it is a proper anesthetic checkup. Secondly, they have a clear state of mind before donation. Thirdly, they have to be assessed whether this patient is having any chance of developing an CKD or end-stage renal disease in future or have increased mortality due to cardiovascular disease or not. Here is the GFR assessment. If the patient is having GFR of less than 60, he or she is not eligible for donation of the kidney. You can see this is the part, upper part, they are not eligible for donating the kidney. But if the GFR is more than 80, we take the kidney with a more GFR of more than 80, and most of the recommendation is more than 90, then there is a projected probability of not getting CKD in the future, and that should be assessed. At the same time, this patient should not have any chance of developing kidney disease, like that they should not have a diabetes conventionally, they should not have a proteinuria, they should not have a kidney stone disease, and those situations GFR should be measured and acceptable if this is more than 80 or the 19 different guideline. This is an algorithm that has been shown that how you select a donor, living donor for the kidney. In any transplantation procedure, the donor safety is first. So if a living person is donating kidney, if there is some amount, 1% chance or risk is there, you should reject the every way you should reject as a transplant physician as a donor, because recipient, even after receiving the kidney, it might not work, there may be a death, but the donor's safety is the first. So routinely we accept more than 90, individualized. If it is a 60 to 90, there should not be proteinuria, there should not be possibility of getting kidney stone. And what happens if they donate kidney in a longer run, there straight away you can see the GFR goes down to 50%, it remains like that. And if it has been compared over 30-40 years, because transplantation science is not more than 50 years it is working, and in 50 years follow-up it has been shown that these patients do not have an increased chance, or these donors do not chance of a CKD or a cardiovascular disease. But there is a but is also there. If you compare them with the creamy layer, best of the best patients, if you compare the donor, yes, they have a risk of some amount of developing the CKD or a more cardiovascular disease if they donate kidney in longer run. So this is an, I'm not going to the detail, and this is albuminuria evaluation, is a less than 300 milligram albuminuria should be there, and pre-existing diabetics as a donor or not. Is a conventional teaching, diabetics you should not take, this is but nowadays you will get diabetic parents in every house, and there is worldwide this is applicable. In those situations, rejecting directly the diabetic donors is probably not good. So this is an American association, they have prescribed if the patient is more than 55 years of age, is a more than 3 years duration diabetic, no hypertension, no dyslipidemia, and this is active, this lifestyle is good and not gaining weight, in that proteinuria is less than 30 milligram per gram albumin creatinine ratio, and in those situations you can take the kidney from after explaining the probable risk of developing CKD in future. So patients with the overall glucose intolerance, we don't take the patients. Type 1 diabetes cannot. Even in the type 2 diabetes, pre-diabetic patient can donate, but this is counsel the patient regarding the problems of the development of CKD in future. So if the patient is getting, if you are considering a parent being a diabetic and a donor, and the son is the recipient, whether you should see whether he or she is also diabetic or not. This is the relationship between diabetic patient. If it is D minus R plus means non-diabetic donor to a diabetic recipient, they have a better chance of survival. This is a good one. If the non-diabetic patient is a diabetic patient is giving to a non-diabetic recipient, the chances get are higher. And highest is being if the donor is diabetic and recipient is diabetic. The recipient outcome. This is recipient. So if the patient is also diabetic, donor is also diabetic, in those situations outcome is not that good in terms of recipient. So in diabetic patients, if you are taking a diabetic donor, you try to give it to the non-diabetic recipient. So these are the immunological test, self versus non-self test. We call it an HLA that is expressed in all nucleated cells. I am not going into the detail. It is the purpose of doing HLA are two. One, you can establish by DNA method a relationship between the two, because in the law says you cannot do the transplantation clearly until and unless you establish the relationship, and there is also assessment of the sensitization and compatibility. This is, I am not going to the details. Reports come like that. This is HLA, class 1, class 2, A, B, C, then DP, DQ, DR, and they are matched just this is a mother and son relationship. You can see there is a 50% match in each segment, and this is acceptable. This establishes the relationship and gives an idea about the outcome. Although OTPN registry, whether if the better match, better outcome for a living donation. The OTPN registry has shown that in a spousal donor there is a better outcome, no HLA match. So this is a query for the deceased donation, the brain dead patient is a donor. In those situations, more HLA match, better is the outcome. For the living donation, it might not be the thing. So it happens because before transplantation, you need to do a cross-match test. This is a person called Paul Terasaki, 1969. He first raised the question that there might not be a compatibility between the donor and the recipient, because there might be an antibody formation in the recipient, and you should not do a transplantation if there is this is like a mock test. You take the lymphocyte from the donor and the serum of the recipient, mix it up, and if there's a reaction, then you can expect there is a rejection when you put a kidney from the donor to the recipient. So this should not be done if a cross match is positive. The concept of cross match is given in by him, and this was published in those situations. And this is the finally after immunological evaluation, you do the radiological evaluation, like the CT scan, where the surgeons decide which kidney needs to be taken, where it should be put, either one artery, two artery, one vein, two vein, one ureter, two ureter, etc. So this is important, and this is another, like a diabetes malignancy screening also is important for the donor and the recipient, because if the donor having a malignancy in the recently or the immediate past, there is every possibility that there is a transmission of the malignancy from the donor to the recipient, and if the transplantation is done in a patient who is having an active malignancy, there is every possibility that it will flare up with the immunosuppression. So the active malignancies, any of them is an absolute contraindication for the transplantation, and there is a guideline which cancer, how much days after you can take that. In a breast cancer mother having a complete remission, after 5 years can donate, and as a son is having a papillary CA of the kidney, they cannot take a kidney in the first year of the post-malignancy life. So these are the different donor-derived transmission of the renal transplantations. Now we tell something about the deceased donor. Deceased donors means the patient might have a brain dead or a circulatory death. Brain dead means they have a brain stem is lost because there is a cortical death due to unconsciousness. There will be a brain stem death, no respiratory effort, apnea test is positive, and he is not taking, he is on ventilator, other organs are working, you can take the kidney. The brain dead is considered to be similar to the death of the patients, and sometimes there is a circulatory death. In those situations, there is a cardiac arrest that happens in the ICU. And the criteria of the deceased donor, there is a call comes. So whenever there is a declaration of the brain dead and family wishes to donate the kidney, then in situation you get an alert call, and they give the 5 or 6 informations. They will give that patient is having a normal renal function, the hypertension not requiring any treatment, doesn't have any diabetes, there is a no known malignancy, no known bacterial infection, there is an acceptable urine analysis, the no proteinuria, and at the same time viruses are negative. If these 7 criteria is fulfilled, then you can tell yes, we are agreed to accept this deceased donor, and there is an alert call is responded. So now this criteria has been expanded a bit. I am not going to the detail. There is things called an marginal donor, where we take kidneys where the creatinine might be slightly high, slight amount of the proteinuria, infection not limited to the urinary tract, we can take the kidneys in those situations. And if you compare this live donor versus deceased donor, it is seen that there is a long-term survival is always better with the live donor compared to the deceased donor. So you can, how long you can keep the organs. If a brain dead patient is declared brain dead and donating the organ, you can take 1 heart, 2 lungs, intestine, liver, pancreas, and 2 kidneys, but you have to utilize. The ischemia time is not same in all patients. If you want to take a heart, it will last only for 4 to 6 hours. Kidneys are relatively compatible. You can use it within 24 hours, but heart and the lungs, they should be transplanted in a very fast way. If the transplantation is done either from a deceased donor and a deceased donor or maybe a living donor, there's so many things happen in the post-transplantation period. There are lots of very knowledgeable nephrologists and transplant physicians are there. They seize the tidbits of these. But for the follow-up, it's a follow-up. After some time, they will leave you. They leave the station of transplantation and go to the practitioner at their place. And how do they do? This is the European practice they have started that has been published by using this eye box as a predictor of the kidney failure. Here, it can see that it can assess the activity of the disease in a very precision way. At 3 years, 5 years, and 7 years, you can see this is basically artificial intelligence that is predicting the outcome, and this is quite good. Here you have to put some information. I think Dr. Amaresh will tell more about that. And after that, you get a precision medicine, precision prescription. You can follow in a PDF matter, and you can follow it up. So it is the future, but discussion of every patient, it is better always to consult with the physician who have done the transplantations. So where do we currently stand? This is some epidemiology you should know. India is the 3rd highest country have doing the transplantation after USA and the China. This is in terms of the living donation. You can see this is a living donation, means this is a bluish or a greenish line. This is India is the 3rd position after USA and the China. But if you think of the living deceased donation and a cadaveric donor transplantation, we are in the 67th position. This is quite, you can see this is the India's position in the 67th, and that is the position where we held in the deceased donation. So long way to go for a deceased organ donation, but it is increasing. Living donation has increased over the last decade from around 5,000. Now we are doing 15,000 kidney transplantations on this, and the living donor from the deceased donor, it has not much increased, but it is a possibility of more increasing. And there is a demand of about 2 lakh kidneys per year, but we get only 50,000 transplantation done. That is quite worse for the liver and the heart. And this is not only India, this is worldwide. There is organ supply. This is organ supply versus demand. There is a gap. So breaking this barrier, we are now taking more and more patients who is having incompatibility initially. We are getting some healthy, willing donor to taking them into the swab donation or a donor donation. It's a chain of system. We are taking blood compatibility, incompatible donor, or a cross-match positive donor. So this is not the thing I'll be going to discuss. So this is a swab transplantation that is active in some parts of our country, the western part. Here you just exchange one A blood group patient having a B blood group donor, and another is just the reverse. You can exchange them and take them the main pool without desensitization. Otherwise, 1/3 of the patient has been denied due to the blood group incompatibility. This is a nationwide, this is the application of the swab program that should be the future, and there is a there is a software now available provided by the ISOT for getting this swab transplantation. Lastly, I'm not taking more time. This is the third pillar of the transplantation is a law. Because every day or I heard there is an organ transplantation, there is a possibility of deviation from the law. So there's a law has been in line since 1994, and in 2004 the last amendment has been done. And this is from Act to the laws. The main purpose, the concept of the brain dead that has been accepted. Only live related donors are allowed. This is that there should not be a monetary transaction between the donor and the recipient, and this is a hospital requires a license before performing a transplantation, and there is a punishment procedure that has been applicable for this doing and commercial dealing in the organ transplantations. So this is the Organ Transplantation Act. And lastly, you have to go further because there is always a gap between the the demand and the supply. And the future is in the genome transplantation. This is a pig. This is not a chimpanzee because they're available. Their organ sizes matches with a human being. They are, although they are genotypically not very similar to us, but doing some thing, there's doing something because by doing
Dr.
this
Das,
different genetic.
Your time is up.
Yes.
Please sum up.
Yes. So this is xenotransplantation is the fourth pillar that is going to be in the future. So this is the summary I have to do. This is organ transplantation in India. This is mostly done in the private hospital, not in the government hospital. I have told this different ratios over there, and this is the different areas where we do the transplantation. The green areas we do the most number of the transplantation, followed by this is the saffron areas, followed by these red areas. This is the organ, the state-wise, this is not, we are very much eastern zone, we are not very much prominent in the field of transplantations. This is a study in 2023. But still we are doing the transplantations because there are lots of figures we are now available for funding the transplantation procedure. And here we get some good hopes and the good stories. You can see here that this is Dr. Pankaj Center who is doing the transplantation, successful discharge. Dr. Jamshed and Dr. Shashi is there, and here Dr. Harshavardhan is there, and here is one of a few of our transplantation. So there is always being a ray of hope, and this is the thing we should promote amongst us. This is a pledging form. This is available in the Noto. This is a Noto on side, noto.admin government in. You go there and download a form which is called the Form 7. You can inform that your name, address, and everything. You can tell your neighbor's patient. You can pledge your organs. Unfortunately or fortunately, if we die in ICU, in ventilator, and brainstem death happens to us, our family can take the decision that this patient's wishes was to donate the kidney. It's a pledging form. Till now, 1.5 lakh patient has filled this pledging form. This should be circulated and propagated. This is very easy to perform. So this is not the end. If you donate the organ after your brain death situations, there is so many. This is a gift of life. Nothing can be superior like that. Thank you.
Thank you, Dr. Das, for your brilliant talk. You have given so many practical points. You have given very loud message, and I will request that if any question on the floor, it will please ask Dr. Das on the lunch time. And once again, I thank you, sir. Dr. Hemant Kumar, sir.
Not talking anything scientific. There is an appeal for all the members of ISN East Zone. Presently, Dr. Prateek Das is our secretary of ISN East Zone. He has been nominated for ISN Central as secretary. So let us give him a big hand to represent us as the national secretary, and we will be really proud of that moment. Thank you very much.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you,
Next
Speaker, sir,
session.
Chairperson, sirs. Due to limitation of time, we are running 1 hour late, and it's almost lunch time. So we will move to the next session, and this is the last session before lunch. So please bear with us. We will only we have half hour in place of 1 hour lunch. We will only go for half hour lunch, and I would request the audience to give a round of applause for all the nephrologists, not only Dr. Prateek Das. This transplantation, this talk was such a wonderful talk, and it's my nostalgic moment that he is from the same alma mater, Calcutta Medical College, from where I did my MBBS, and he's 15 years senior to me. And we physician, I was thinking that what is this in this talk for physicians, but this was only for physicians. So we have to keep in mind that we have to motivate for transplant, for cadaveric, for organ donation, we have to motivate in the society. So I would request for the next session, moving on to the last session before the lunch, I would request the chairpersons, Dr. Gyan Prakash from Patna, Dr. Rupak from Begusarai, and Dr. Kranti Kishore, leading pediatrician from Gaya, Dr. Nazar Zubair and Dr. Sandeep Kumar, physicians from Gaya, to come on the stage for the next session. And the speaker for the next session is Dr. Professor Amresh Krishna, and he will deliver his talk on the topic, the interesting topic, that is AI in nephrology. So the chairpersons kindly proceed with the talk.
Good evening, everybody. Now I invite respected Dr. Professor Amresh Krishna, sir, Professor and Head Department of Nephrology, AIIMS Patna, to deliver his talk. Over to you, sir.
Good afternoon, respected seniors and dear colleagues. At the outset, I would like to thank the organizing committee, especially my friend Dr. Mritunjay Kumar Singh, for inviting me. And the topic I'll be presenting is artificial intelligence in nephrology. To introduce the topic, I would like to quote Bill Gates, who in his microblog in 2023 wrote that development of AI is as fundamental as creation of microprocessors, the personal computers, internet, and the mobile phone. And it will change the way people work, learn, travel, get health care, and communicate with each other. That is, AI is the next big thing in the technology, and it will have impact on every aspect of our life. And parallel to the development in technology, there has been a paradigm shift in practice of nephrology. So now we have moved from the traditional reactive nephrology, where the primary focus was managing complications, especially end-stage renal disease, and the key tools for us were dialysis and transplant, and our goal was symptom control and renal replacement therapy and its preparedness. But now we have moved to early detection, slowing the disease progression, and AI and precision medicine play an important role in it. The goal of today's proactive nephrology is to preserve kidney function and to delay or avoid dialysis. And here comes the role of artificial intelligence in proactive nephrology. So coming to certain terms, AI is actually a branch of science that enables machines to mimic basic human cognitive behavior. So it mimics, but it cannot replace our thinking, learning, reasoning, and acting on our previous experience. There are different subsets of AI which include machine learning, robotics, and natural language processing. So coming to certain important terms related to AI, algorithm is the set of rules that defines the sequence of operation for computer. So basically, algorithm leads to programming. Machine learning is the process by which an algorithm encodes statistic regularity from a database which develops into a pattern through which we can make prediction. Then artificial neuronal networks are arrangement of neurons in layers so that they are interconnected with each other, similar to the neurons in our brain. We have convoluted neural network, which is distinct from artificial neural network, that all layers are not fully connected to each other. So there are many deep layers in CNN when compared to ANN. Decision tree is a type of learning method where choices and outcome are represented as a tree, and they have different branches which are values. And many trees, when come together, they form random forest. And coming to deep learning, which is a subset of machine learning, where multiple layers of computation are used to arrive to a decision. So neural network is series of algorithms that leads to recognition of relationship in a data. We can see here that there are different data sets. There are different trees, decision trees, and these trees form the forest. And the computer reaches a decision based on majority voting. And this is deep learning, which we can see that is the subset of machine learning, and these artificial intelligence are require inputs from the computer sciences, from the data sciences, from the behavioral sciences, and we can see the deep neural network where the inputs are connected to many multiple layers of hidden layers, and then we have the output. So these hidden layers are required to perform non-linear mathematical transformations. And in order to develop a AI tool, there has to be a developmental life cycle which begins with the problem identification. We must clearly identify the problem. For example, if we want to detect acute kidney injury in a subset of CKD stage 4, then we will have to extract data and we have to process it. And then we will have to develop an algorithm and we will have to train the machine on this model. And once we do this, then we have to evaluate. We have to cross-validate it. We usually look at the mean square errors, which predict that how good the machine is working. And once the internal validation is done, then machine requires further refining, and then it is put into test in a different hospital or the external validation. Once the machine has been externally validated, then it is deployed, and post-deployment refinement is also required. So in order to have a working AI tool in clinical setting, we must train it, we must internal validate it, we must externally validate it, then we should evaluate it prospectively, and then the outcome should also be validated. In this case only, then we can use the AI tool. And artificial intelligence has great role in nephrology. Almost every field of nephrology, from acute kidney injury to imaging, to renal transplant, to chronic kidney disease, to renal pathology and dialysis, can benefit from the artificial intelligence. Coming to artificial intelligence in acute kidney injury, we know that traditional markers delay the measure of injury. And based on artificial intelligence tool, we can continuously monitor the risk of developing AKI. For example, we can have fresh predictions for AKI every 6 hours. And this can provide us predictive lead time. So using AI models, we can detect AKI up to 48 hours before the biochemical changes occur. So in a study by Singh et al., using the deep learning method, it was found that the machines were able to predict acute kidney injury following cardiac surgery, and this prediction had an area under receptor operative curve of 0.92, meaning that it was able to predict very well the chances of developing acute kidney injury. Similarly, Tomsev et al. Applied the random forest artificial intelligence model and showed that they were able to predict future acute kidney injury in ICU, and it had a prediction value of 0.84. So when we compare it to the traditional logistic manner, which has an area under receiver operator curve of 0.68, the machine fare much better. But there are certain issues with with AI-based prediction of AKI. That is, there is threat of over-alarm. So high-sensitive triggers can alert even benign shift in the baseline. So the algorithm should be such that it should have a good positive predictive value, then only it is clinically useful. Now coming to artificial intelligence in chronic kidney disease. So artificial intelligence in chronic kidney disease can provide for automated screening. AI-powered renal screening uses the advantages of algorithm to detect AKI by invading various non-invasive data. So we can use retinal scans, medical images, and routine lab result in order to identify the chronic kidney disease. and we can detect it early. And AI can identify subtle changes which our human eyes can miss. Also, AI can be used to screen for rare kidney disease such as Fabry diseases. So, one of the tool which has been developed is the RETI CKD system, where over around 80,000 retinal scans were used for deep learning model, and the machine was taught that eGFR of less than 60 or albuminuria is an indicator of CKD. These machines were trained on data from United Kingdom, and when they were used in Korean patients, they showed very good correlation. Similarly, by Dolaria et al., they extracted data from 57 studies, and they were able to predict and diagnose and study the progression of diabetic kidney disease very well in their artificial intelligence model. One of the model which has been approved by the FDA is the kidney index model, which is basically a bioprognostic test which can predict the risk of CKD in patients with type 2 diabetes with early stages of CKD, that is stage 1 to 3B. And it uses machine learning algorithm to combine with certain blood-based biomarkers along with clinical data and electronic health record. And they can stratify the risk of progression as low risk, where 92% of patients will not progress with decline in CKD, and high risk, which have 18 times more chances of developing progression of CKD. So this is a typical report by the Kidney Index S DKD system. Now, coming to the use of artificial intelligence in dialysis. Dialysis patients have a good amount of electronic health data. They have notes, they have social determinants of health. The dialysis machine can continuously stream a number of data in real time, including the blood pressure, the ultrafiltration. These patients can have high quality of imaging, and now with wearable devices, we can also continuously monitor various aspects. So these can be used in artificial intelligence, machine learning methods, and artificial intelligence can be used to improve the dialysis adequacy, predict intradialytic hypotension, dose adjustment, monitoring of dialysis access, as well as mortality prediction. Artificial intelligence will also have an important role in transplant, because every aspect of transplant can be touched by artificial intelligence, including organ allocation, immunosuppressive therapy and its adjustment, transplant imaging, transplant pathology, and graft survival. So iBox is an integrated box is a validated algorithm that has been designed by the Paris Transplant Group to predict long-term allograft survival. It has got a high accuracy with concordance statistics, or the C index, of being 0.81, and it also individualizes risk factor for individual patient. So there are number of inputs which are required for this artificial intelligence, and it was trained for 3 years. We can see that it was trained here for 3 years, and then its predictions were followed. So it can be seen that the prediction made by machine was very accurate for up to 10 years. Now, other applications of AI in transplant indicates that we can make a continuous point system instead of rigid system which we presently have, and this can reduce disparity in patient selection as well as will improve the survival of the patients. We can also use artificial intelligence model to decline the marginal donor, because it can predict the recipient survival outcome using marginal donors, and it can compare that what is the mortality on wait list compared to mortality by receiving this graph. So this is based on a theory which has been shown. It is a complex algorithm which again requires a good amount of data. So the frontier of AI keeps expanding, and AI finds further use in nephrology in clinical research, because electronic health data provide diverse data for machine learning, so the clinical trials can be conducted at a very low cost and it can be done in a shorter time. So machine learning can be applied to real world data to generate real world evidence. Again, AI also has use in medical education because artificial intelligence can provide personalized learning path, can automate the administrative task, and can provide immersive clinical stimulation. So its primary role is to serve as supportive tool both for the educator as well as the student. A concern with AI is that AI may prevent the trainees from developing foundational clinical reasoning. So there are certain limitations of artificial intelligence. That is, it lacks common sense and context. It only reads the pattern. It cannot understand the context behind a pattern. Then at times it hallucinates. It gives false information with great confidence, and it may be accurate. It has to be trained against data, and bias in these data can lead to bias in AI result. There is absence of creativity. The AI is not creative, and there is the black box problem. That is, we know that the input, we know the output, but there is no transparency. There is also the medico-legal issue which AI has. Any decision taken by AI, the person who is using it will be responsible. Then there is the challenge of data quality. What quality of data has been used? Then there is safety, black box problem I have already told, and AI also has bias. But there are ways which these AI biases can be removed. This is, we should always look for the bias and detect it. We should de-bias the algorithm. We should use diverse data for the training. Training of AI is very important. Then we should have regular audit, we should have transparency, we should use AI ethically, and the results of AI should be reinforced with human learning. So coming to AI in nephrology, the conclusion, we must understand that AI is not a futuristic tool. It is here to study, it is here to stay. It will be a permanent transformation fixture. So we will be continuing using it more and more in everyday practice. And we should also work towards building AI competent medical workforce. The training for AI should begin right in the schools before the medical college, should continue in the preclinical and clinical rotations, and in residency and follow-up, and we should also have CME and certification for AI. So the take-home message is that AI has tremendous potential to transform the delivery of kidney care. It does address many unmet needs in areas such as early detection of AKI, drug dosing, dialysis, kidney transplant, and kidney pathology. AI needs to be included in medical curriculum, and AI is not intended to replace the nephrologist. Rather, it intends to enhance the capacity of physician and other healthcare professional. So finally, AI will not replace the nephrologist, but a nephrologist who uses AI may replace the one who does not. So I end with this cartoon that if a mistake is made by AI, then it could have its impact. Thank you.
Thank you, Professor Amresh Krishna. You very well spoke on the use of AI in nephrology. Starting from early diagnosis, even before the clinical symptom appears, the stages of disease progression, use in dialysis, reducing the complications, as well as in transplant and in future research also. Since AI is itself in learning phase, so with the passage of time, with more and more data input, the outcome will definitely improve better, and it will also reduce the human error, which commonly happens. So you very well said your last line that AI will not replace the nephrologist, but the doctor who is not using it will replace those who are not using it. Thank you. Any question from the audience?
Professor is smiling. I may say something which AI may not agree. you have your Android in your hand as the best example of AI. Am I right?
Yes, sir.
Best example, everybody has got AI in his hand. It depends how do you use it, how do you manipulate it. The problem is AI has a very big bank. It will take some more and more time. I will give you a very small example. If you take help of AI right now for Bihar regarding CKD or herbal nephropathy, probably this will mislead you because they don't have data about it. So that is the thing. I'm giving one example that you have to be a bit cautious to whatever they predict or whatever they guide, you have to understand. Another example I will give you, I tried once in a portal where I fed the need of dialysis of a patient coming out of the SD room. When I fed the data, the next dialysis was proposed was after 1 month. So remember, so you have to need to choose the portal in AI. That is very important because I am very much fond of using AI and reading about AI. Thank you very much.
Thank you, sir, for the wonderful presentation. So as we are running little late, so we are going to request you all for have a lunch for half an hour break after this momentum ceremony. And I would like to request Dr. Pankaj Hans, sir, for momentum ceremony.
Post lunch, we are going to meet at 3:30 sharp. Our next session will be at 3:30 sharp. Kindly try to come before that. 3:30 we will start the session. welcoming you again from the Team API and ISNEZ post-lunch session. We have 5 more sessions, so we are going to start. We are already more than 1 hour late. So the next session, we have chairpersons for the next session. Dr. Ratan Kumar sir, kindly come on the stage. Dr. Ashish Prasad sir and Dr. Rakesh Kumar Chandel sir, kindly come on the stage. And the speaker for this session is Dr. Professor N Sarat Kumar. Sir, kindly come on the stage, sir. Audiovisual team, kindly put on the presentation of sir.
It's moving.
Yes, yes.
This is the one?
Yeah. It's our privilege and proud moment for Gaya Ji to have a speaker from Imphal. He has spared his time. Thanks to sir. And the chairperson, sir, kindly proceed with the session.
Now we are going to start the session, and the topic is decoding nephrolithiasis, acute renal colic to metabolic prevention. And the speaker is Dr. Professor N. Sharat Kumar from.
Yeah, I'm from Imphal, Manipur. इसको थोड़ा बड़ा कर देना, दिखाई नहीं देता है। Good afternoon, everyone. After lunch, it's very difficult to keep attention to the talk, and especially when we talk of a subject which everybody feels belong to a urologist. But to tell you frankly, we have been neglecting a subject like nephrolithiasis, which we presume to be a urological condition, but no. So kidney stones are a major increasing health issues now in the society, and because of this urbanization, then dietary changes that we have, sedentary lifestyles, then climate-related conditions, and increasing metabolic syndrome. So kidney stones are not a urologic condition, but probably an underlying metabolic condition presenting as a kidney stone. So India is also considered as one of the highest burden for kidney stones. So approximately 10 to 15% of the Indians will have a chance to develop kidney stone in his lifetime. And out of this, 50% of the stone formers might have a recurrence within 10 years. So the around 2 million people are affected annually, and prevalence is increasing due to the various factors. So why nephrologists? Nephrolithiasis is a matter of importance to the nephrologist, because stone disease is associated with chronic kidney disease. It can also be associated with acute kidney injury, can be associated with hypertension, reduced bone mineral density and fractures, and also a burden to the healthcare utilization. Now, nephrolithiasis is increasingly viewed as a manifestation of an underlying metabolic and systemic disorder rather than an isolated urological event, as I have said earlier. So a role of the nephrologist as well as the physicians, general health providers, is that to identify secondary causes of stone formation, then prevent recurrent stone formation or stone events, preserve long-term kidney functions, and reduce CKD progression risk through targeted metabolic interventions. So every stone episode is an opportunity to uncover an underlying metabolic abnormality and prevent further damage or further kidney injury. As we all know, pathogenesis, I will not go much in detail. There's a various multiple steps of development of kidney stone. The first is urinary supersaturation. When the concentration of the stone-forming substances exceed their solubility, the crystals precipitate. And the important stone-forming substances like calcium, oxalate, phosphate, uric acid, cysteine. And the promoting factors like the low urine volume, high urinary calcium levels, then high urinary oxalate level, hyperuricosuriia, acidic or alkaline urine, urinary stasis, infection, etc. The next step is the nucleation. These tiny crystals form from supersaturated urine. There are two types of nucleation. That is one homogeneous, which forms spontaneously, and the second is the heterogeneous, which form on an existing surface like cell debris, bacteria, foreign bodies, or Randall plaques. So Randall plaques are interstitial calcium phosphate depositions at the renal papilla. It serves as a nidus for the calcium oxalate stone attachment. And this is commonly observed in those people who form stones, idiopathic stone formers. The third stage is the crystal growth and aggregation. These crystals will enlarge and aggregate into stones, and those factors which favor stone formation are the persistent supersaturation, urinary stasis, and reduced amount of inhibitors in the urine. Then the next step is the crystal retention. Usually, normally the crystals are washed out in the urine, but some of these stones developers will have these crystals adhere to the renal tubular epithelium. So they, like a patient who has got tubular injury, who has got Randall plaque attachment, who has got reduced flow. So in these cases, the crystals will be retained in the urine, and because of the deficiency or inhibition of the natural inhibitors of stone formation, these crystals will grow in size. So, and the stone formation is because of the imbalance between the promoters of stone formation and inhibitors of stone formation. So promoters are the calcium, oxalate, phosphate, uric, cysteine, etc. And inhibitors are mainly citrate and magnesium. Of course, we have the TAM, phosphol, protein, nephrocalcin, osteoponin, etc. Stone composition. So every stone tells a different story. So stone composition is the cornerstone of precision prevention. It helps identify the underlying metabolic abnormality. It also identifies some of the systemic diseases. There's a risk of recurrence can be found out from the type of stone, and we can have a targeted dietary as well as pharmaceutical intervention for the stone. The commonest stones are the calcium oxalate, which is of course the commonest. Next is the calcium phosphate, and rarely we have uric acid stone, struvite or the infection-related stones, and cysteine stones. So calcium oxalate is the most common type of nephrolithiasis that we get. Low urine pH is often more important than hyperuricosuriia in uric stone formation. Calcium phosphate stones should prompt us to evaluate for distal RTA and also for primary hyperparathyroidism. Every recurrent stone former should undergo stone analysis whenever stone is extracted or passed out. So clinically, there are various presentation of nephrolithiasis. The most dramatic one is the acute presentation, where the classic renal colic, sudden onset pain radiating to the groin, testis, labia, etc., associated with various constitutional symptoms like nausea, vomiting, microscopic hematuria, etc. They can also present with fever, nausea, vomiting, oliguria, anuria. But some of the stones do not present dramatically. They are there as a silent stone. So this is, while renal colic is the classic presentation, some of the kidney stones will present like recurrent urinary tract infection. So stones act as a nidus for the bacterial colonization. So bacteria can persist within the stone matrix and making eradication difficult. So Struvite stones is one example which is associated with urease producing organisms like Proteus, Klebsiella, Pseudomonas. So repeated UTIs, despite appropriate antibiotic therapy, should prompt evaluation of occult stones. The stone may be the cause of infection, not merely the consequence of infection. So patients can present as progressive nephrocalcinosis. It's a diffuse calcium deposition within the renal parenchyma, particularly in the medulla, and it's often a manifestation of specific metabolic disease rather than a surgical condition. So common causes like distal renal tubular acidosis, primary hyperparathyroidism, medullary sponge kidneys, primary hyperoxaluria, and then excess vitamin D and calcium citrate. Calcium intake. Then sometimes the stones are found on incidental imaging. Then clinical question is, when these silent stones are there, whether is the stone clinically significant? Is there evidence of obstruction? Does the patient have an underlying metabolic disorder? So these are the questions that should come in our mind when we find a person who comes with an asymptomatic kidney stone. So even asymptomatic kidney stones can enlarge over the time. They can produce obstruction in future. Often they predict recurrence. So asymptomatic stone formers have a higher likelihood of future symptomatic episodes compared to the general population. So they can also present with recurrent microscopic hematuria. So apart from the glomerular causes of hematuria like IgA nephropathy, the common cause of non-glomerular microscopic hematuria is the kidney stones. They can also present with declining kidney function. Stone disease is increasingly recognized and one of the causes of chronic kidney disease. In fact, in many of my presentations in the past, I have described kidney stones because this is quite common in my place, and it probably comes in third or fourth common cause of CKD in my place. So we have a lot of patients who develop in the late stage silent stones presenting as kidney failure. Probably the patients were kept by the physicians, local physician. Stone is silent, don't worry to disturb, but probably they'll end up in CKD. Then resistant hypertension is one which the stone formers have. So if someone has say resistant type of hypertension, then probably we should also be looking whether the patient has got kidney stone. So some of the red flags requiring immediate attention: patient develops fever, sepsis with obstruction, rising serum creatinine, solitary functioning kidney with stone, bilateral obstruction, then patient has got anuria, pregnancy with kidney stone and obstruction, and immunocompromised patient. These are the group of patients in whom we should take immediate actions. So some of the diagnostic tests, of course, urine analysis, the crystal types, these are there. Then urine culture if we suspect infection, blood tests like renal function, electrolytes, these are routine investigations. The diagnosis is done by imaging, and NCCT KUB is the now gold standard for diagnosis of kidney stone. It detects almost all stones, and it can also show obstruction, and it measures the size and density properly, and the sensitivity and specificity is very, very high. Ultrasound useful in pregnancy and children. It is cost effective, can be done repeatedly, but it can also show hydronephrosis, but it is less sensitive when, especially in the lower ureteric stones. X-ray KUB detects radio-opaque stones, but misses the uric acid stones. IVU, intravenous urography, previously it was very common, but I think it has been replaced by CT scan. We can do metabolic evaluation like 24-hour urine examination for volume, calcium, oxalate, citrate, uric acid, sodium, cysteine, etc. Then whenever there is a stone available after extraction or after being passed by the patient, we can have a stone analysis. Treatment depends on the size, the location, the symptoms of the patients, then acuteness or other comorbid conditions. And small stones we can manage conservatively. Less than 5 millimeter of 5 mm of stone can pass spontaneously or with medical expulsion. We can use analgesics for pain. Then for medical expulsive therapy, especially for the lower ureteric stones, we can use alpha blockers like tamsulosin. Then emergency management, as I have mentioned earlier, if patient has got sepsis, obstruction, AKI, solitary kidney, then we can use methods like ureteric stent, percutaneous nephrostomy, which is a part of the urological intervention. Definitive procedures, we can do ESWL, extracorporeal shock wave therapy. Of course, this belongs to, again, the urologist. We can do ureteroscopic, like any endoscopic stone fragmentation and removal. We have got now a lot of laser therapy for this. Percutaneous nephrolithotomy can be done for large stones or Stackhorn calculi. Open or laparoscopic surgery is rare now. Many of my urology colleagues, they never do open surgery now. Most of them are doing endoscopic surgery with laser fragmentations of the stones with much less complications. Stone-specific treatment, if you can find out calcium stone, it can be treated with thiazide and potassium diuretics. Uric acid stones with alkalinization or allopurinol, febuzoxide. Struvite stones, they are infected stones, they have to be completely removed and proper antibiotics to be given. Cystine stones, it's found in cystinosis, and it's need to give very high fluid intake, urinary alkalinization, and some chelating agents to bind the cystine in the intestine. Now, the common metabolic prevention of kidney, this is, the prevention is crucial because recurrence of kidney stone is quite common. And the general preventive measures like increased fluid intake, make the urine output, say, more than 2 to 2.5 liters per day. Then reduce the sodium. Sodium, again, is not good for even for stone formers. Then we can take normal calcium intake. The myth is that calcium should not be taken if a person has a kidney stone. It's on the contrary, low sodium paradoxically increases the absorption of oxalate from the intestine, thereby producing more calcium oxalate stones. We will also reduce the oxalate-rich foods like spinach, nuts, teas, chocolate, tomato, etc. Then reduce animal proteins because they are likely to have uric acid stones. Then sometimes we acidify urine if there is infection, but most of the time we alkalinize the urine for uric acid stones, cystine stones, etc. The complications of kidney stones could be hydronephrosis, as we all know, it could be recurrent UTI, pyonephrosis, and then ultimately, of course, they can also land up in chronic kidney disease. One word about deflazacort. I think most of the pharmaceutical people are pushing deflazacort as a medical expulsion therapy, but it's only for the lower urinary tract infection, impaction of the stone, where it acts as an anti-inflammatory or anti-edematous substance, thereby producing easy passage of the stone. So it does not usual dose 6 to 30, so it is usually combined with alpha blockers, but one must know that it does not dissolve the stone, it doesn't act on the stone, it does not fragment, and it does not treat large obstructing stones, so it doesn't replace the surgical procedures. Contraindications, of course, steroids, all of you know, side effects. So the current practical position of of kidney stone in modern urology practices that the alpha blockers are used more commonly. Steroids are sometimes optional. So the deflazacort is not universally accepted and prescribed. So some urologists prefer short course of steroids if in selected patients. Distal ureteric edema or significant inflammation, if there is, we can use deflazacort. So future directions in stone, we have some emerging frontiers like genetic profiling, identification of monogenic and then polygenic stone formers, then earlier diagnosis of high-risk stone formers, family screening and risk stratification. Then we also have the urinary and gut microbiomes like oxalobacters, lactobacillus. They are being tried to prevent recurrent stone formers. To summarize my talk, kidney stones are a major and increasing public health problem in India also. Approximately 15% of Indians may develop kidney stone during their lifetime. Kidney stones develop due to urinary supersaturation, crystal formation, aggregation, and retention. Major stone types include calcium, uric acid, struvite, and cystine. Patients commonly present with renal colic, hematuria, and urinary symptoms. Diagnosis relies on urinalysis and imaging. Treatment ranges from conservative management to endoscopic. There is a role for steroid in some selected cases. Long-term metabolic prevention through hydration, dietary modification, and targeted pharmaceutical therapy is essential to reduce recurrence. Thank you very much for your patient listening. And we invite you, can you put the slide back? We invite you, we are organizing the East Zone Conference of Indian Society Nephrology at Imphal from 11th to 13th September. So all of you are invited to visit Manipur. Those who have come also are requested to come back again. Thank you very much. I can take few questions.
Thank you, sir, for a very nice presentation. So one question I just want to know, use of Deflisa coat, what size of the stone will be very effective for the expulsion?
Maximum 7 mm.
7 mm.
I don't go beyond that, but the urologists say up to 10 they can go, but I think 7 mm is the ideal that we should go, especially in the lower ureter. It may not work for the upper ureter, and it only helps to dilate the ureter a little bit.
Yes, sir. Yes. So floor is open for questions.
Yeah, tell me. आपने बोल दिया पहले. No, most of the time, commonest is calcium oxalate.
Right.
So you go for calcium oxalate. Calcium phosphate is a big stone. Usually, you get it in the urinary bladder, around a thing like that. So it's also very rare, only when you get the infection. In my younger days, I used to get a lot of patients who have got calcium phosphate stones, which are round, it fills up the bladder. But calcium oxalate forms the staghorn calculi. They are the commonest. So target for calcium oxalate. Then also you can measure the urinary 24-hour urinary, say calcium oxalate levels. So whether they are having oxaluria like that. So mostly, if you don't have facility, take it as calcium oxalate.
Himalaya drug, they advocate cystone tablet or cystone DS tablet, or they say that it dissolves the stone up to 6 to 7 millimeter. What is your opinion?
Yeah, I couldn't get you, sir.
Himalaya Drug Company, they say that cystone tablet, either DS tablet or they dissolve.
I think they are all Ayurvedic. I'll tell you a story. In my place, there is a Padma Shri awardee, Lashram Nabakishore. He was the first Padma Shri awardee after BJP government came. He was practicing Ayurvedic, local herbal medicine for the treatment of kidney stones. When I was very new even as a nephrologist, many people don't come to me, they go to him. But he used to pass a lot of small fragments, but scientifically I cannot say. So these are all herbal medicines, may work. But as a allopathic doctor, I never prescribe cystone or niri or whatever it is. That's my personal opinion. So maybe this may be working. Some of these local hubs may be working. Thank you.
Thank you, Professor Sarath, sir, and respected chairperson, sir. You can kindly come on the award distribution podium to collect your memento and I would request Professor Hemant Kumar, sir, to kindly facilitate with memento to the chairperson and speaker, sir. Now moving on to the next session, that is the topic is gaps in current management of cardiorenal patient, focus on hyperkalemia. And for that we have chairpersons, Dr. Professor Binod Kumar Singh, sir. Kindly come on the stage, sir. And Dr. Sasi, sir, Dr. Suresh Agarwal, sir, and Dr. Abhishek Kumar. Kindly, chairperson, sir, kindly come on the stage. And speaker, sir, Dr. Ashok Kumar Vaidya, sir, he is from most eminent nephrologist from Jharkhand.
लोअर वाला है निकल जाएगा 7 mm तक निकल जाएगा कौन पहले हो गए स्लाइड चेंजर ये है Our speaker is Dr. A K Vaidya, a renowned nephrologist from Jharkhand and especially Ranchi. Needs no introduction, and he will talk on hyperkalemia. Dr. Vaidya, please.
Good evening, chairpersons and dear colleagues. Congratulations and thank you to Dr. Pankaj, Dr. Prateek and Dr. Mritunjay for hosting another successful conference at Bodhgaya and giving me an opportunity to talk in front of this august gathering. So, coming to the topic, gaps in the current management for cardiorenal patients, focus on hyperkalemia. So this is my disclosure. And this is the 10 takeaways for the nephrologists on the management of people with chronic kidney disease from the KDIGO 2024 clinical practice guidelines, starting with the comprehensive treatment of CKD patients, not just only seeing the urea and creatinine, to the plant-based dietary management of CKD, and individualize and optimize the treatment of hypertension. This is, I think, very important because even today, the patients are taking antihypertensive drugs, but the blood pressure, optimum blood pressure control is not there. They don't achieve that. So the primary aim should be to control the blood pressure. That is very important, and that is, I think, the most important step in the management of hypertension. And the next is cardiological imaging and management of cardiovascular complications. And if there is acute decline in kidney function in CKD patient, identify the important cause and treat it. Then symptomatic treatment of CKD, treatment of complications of chronic kidney disease, and the advanced care management of chronic kidney disease. But out of these 10 important factors, the most important for all of us, and that has been discussed by earlier speaker, and they have made my life easier. The 4 pillars of management
of CKD. So out of these 4 pillars, 2 are RAS inhibitor, second one is SGLT2 inhibitors. As of date, these 4 pillars, another 2 important pillars are already you have listened from the earlier speaker, that is NSMRA and GLP-1 receptor agonist. So I think out of these 10 key factors, this is the most important because it retards the progression of kidney disease, and if you find the diabetic kidney disease in earlier stage, you can revert back to the normal. That is the importance of these 4 pillars of CKD. So this is 5 years survival of patients with heart failure, and that is not more than 50%. The survival, 5-year survival is only 50%. And this mortality is similar to any other cancer, common cancers in our society. So the intractable heart failure or heart failure which is refractory to the GDMT, they are prone to develop different kind of cardiovascular complications and mortality. These are the various guidelines which have shown that the RAS inhibitor therapy that is recommended for the treatment of heart failure, chronic kidney disease, and type 2 diabetic patients. So these are the different guidelines like KDIGO guidelines in CKD and European guidelines in heart failure patients. They recommend the maximally tolerated dose of RAS inhibitors to reduce the mortality and cardiovascular mortality and morbidity. This is the incidence of hyperkalemia. If you compare the risk of hyperkalemia in general population and other patients like our CKD patients with diabetes and who are on RAS inhibitors. So in general population, the risk of hyperkalemia is only 2.3%, but in CKD diabetic patients who are on RAS inhibitors, this is up to the tune of 40 to 50%. That means this group of patients is more than 20 times risk of development of hyperkalemia. Similar in heart failure patient, it is up to the tune of 40%. In a dialysis patient, this is up to 25%. And earlier it was thought that hyperkalemia is one incident, and but this is not true. There is certain group of patients which, if the patient develops hyperkalemia, then this hyperkalemia is recurrent one. And is subsequent recurrence occurs at a shorter period of time interval, more number of patients develop hyperkalemia, and the grade of hyperkalemia is more than the earlier one. What about the risk of hospitalization? If you see in the CKD patient, there is 3.8 times higher risk of hospitalization, and in heart failure patient, the risk of hospitalization is 2.8% higher than the general population. Hyperkalemia is a barrier to the maximum use of RAS inhibitors. If you see this graph, in patients with mild hyperkalemia and in patients with moderate to severe hyperkalemia, only 40 to 50% of patients are able to tolerate the maximum recommended dose of RAS inhibitors. What about other patients? Other patients, either we need to discontinue the therapy or don't titrate the dose. So what the real world data says? So discontinuation of RAS inhibitors that persists following a event of hyperkalemia. If the patient develops hyperkalemia, then, and again you are going to start RAS inhibitors in the same group of patients, probably they will not be ready to take that drug because that patient thinks that this is the culprit, and because of this drug, I got hospitalized due to hyperkalemia. So this group of patients is not ready to take again the same medications.
So reintroduction of RAS inhibitors is very, very difficult in that group of patients who develop hyperkalemia once. And in both the studies in heart failure patient and CKD patients, hyperkalemia was the most common reason for discontinuation or non-use of RAS inhibitors in our patients. So this study, which was published in 2020, the univariate analysis, it was shown that hyperkalemia as well as hypokalemia both were associated with higher risk of morbidity and mortality. But in multivariate analysis, when the discontinuation of RAS inhibitors was adjusted, then the hyperkalemia was no longer associated with the mortality. In fact, RAS inhibitor discontinuation, that was the strongest predictor of all-cause and cardiovascular mortality. And RAS inhibitor down titration or discontinuation was associated with the doubling of mortality across the patient subtype. If you see this study in stage 3-4 CKD patients or in heart failure patient, if the patients are on maximally tolerated dose of RAS inhibitors, the mortality is roughly around 10%, but in those group of patients who either had to discontinue the treatment or has to be down titrated the dose, the mortality is more than 20%. The MRA discontinuation has got equally the serious consequences. The mortality, all-cause mortality, is higher in that group of patients who discontinued the MRA as compared to the patients who are continuously on MRA. And this hyperkalemia is the most common reason for discontinuation of MRA. So hyperkalemia doesn't directly causes the morbidity and mortality, but it in fact increases the RAS inhibitors down titration or discontinuation, and that leads to increased mortality and morbidity. So do we need to choose between one of these undesirable outcomes, or are there better ways to manage hyperkalemia? How we can move away from this point? So these are the different guidelines which says how the patients of hyperkalemia should be monitored. When you initiate the therapy, KDIGO guidelines says it should be monitored at every 2 to 4 intervals, 2 to 4 weeks interval. But heart failure guidelines that says when you initiate the RAS inhibitors, the potassium should be monitored initially at 1 week, then every 1 month, and then every 2 months. And the different guidelines says that when the patient develops hyperkalemia, then how this group of patients should be managed. This group of patients should be managed. First is a review of the drugs. If the patient are taking some drugs which apart from the RAS inhibitors also causes hyperkalemia, so that drug should be stopped. The second line of treatment is the dietary management of hyperkalemia. Third one is use of diuretics. And fourth one is sodium bicarb tablet that also reduces hyperkalemia. But the most important is the potassium binder. And now we have a choice between the potassium binders. Earlier we were using the sodium polystyrene sulfonate, but now we have in the market that is sodium zirconium. So all the cardiology guidelines, they also show that this potassium binder is very important for our patient, and if the patient develops hyperkalemia, then the potassium binder should be used. So these are the 3 different types of potassium binders. First is the sodium zirconium cyclosilate. Second one is sodium polystyrene sulfonate, and the third one is patiromer. So, what are the difference between all these three? Let me tell you that the Patron is not available in our country right now. And this SPS, sodium polystyrene sulfonate, that we are using for last several years. And this sodium zirconium, this is available in the market maybe a couple of years back. So what are the advantage and disadvantages of these drugs? The first one is that sodium zirconium, this is selectively binds the potassium, but other two molecules, they are non-selective in binding. The site of action regarding the sodium zirconium is a small or large intestine, and another both are working on the colon. And third point, which is very, very important for all of us, that the time of onset of potassium binder. So time of onset that occurs in sodium zirconium within 1 hour. And that's the reason this drug can be used in emergency situation also. If dialysis facility is not available and patient is living in the remote area and the patient is saying that we have some kind of problem and lab test showed that the potassium is very, very high. So in that condition, you can use this molecule very well. What about sodium polystyrene? The onset of time to initiation of action is not stated, it is quite variable, and it may be from 4 to 7 hours. We have longest duration of study available for sodium zirconium. Calcium content is almost zero, only Patron contains lot of calcium. Sodium content is little with sodium zirconium, but sodium polystyrene contains a lot of sodium. The molecular composition, sodium zirconium, it is non-polymer, another both are polymer. And the next point is very, very important, that is drug-to-drug interaction. There's hardly any drug interaction with sodium zirconium, and only the pH-dependent drugs should be taken at an interval of 2 hours, but Patron that needs to be separated from the food or other drug by 3 hours. So Patron is very, very difficult to take, and sodium zirconium, this is ideal for any time your patient can take. Another one is that the volume intake of water. Only 45 ml of water is required to take sodium zirconium as compared to the 45 to 60 ml or more than that in another two compounds. So for us, sodium zirconium is quite suitable compound, and that should be used in place of sodium polystyrene, because one serious side effect of sodium polystyrene, that is colonic infarction or perforation, that occurs once in a while, but that is very serious complications. This is the international Delphi consensus best practice recommendations, that hyperkalemia should be recognized as a predictable, treatable, and manageable side effect, and RAS inhibitors should not be de-escalated or discontinued due to hyperkalemia. A novel potassium binder that should be used and to manage the hyperkalemia. And if you identify a particular group of patients who develops recurrent hyperkalemia, then preventive measures should be taken. And closer cross-specialty collaboration is the key to success. Consistent treatment approach should be the goal in our patients. So this is the Guardian Hyperkalemia European Steering Committee recommendation regarding the interdisciplinary recommendations of recurrent hyperkalemia. So the disease-modifying therapy such as RAS inhibitors should no longer be considered as a reversible cause of hyperkalemia. Once the patient develops hyperkalemia, that means that group of patient is susceptible to develop recurrent hyperkalemia. So every acute episode of hyperkalemia constitutes an opportunity to treat and prevent recurrent hyperkalemia, and early identification and management is key to success. So this is another study which shows the submaximal dosing or discontinuation of RAS inhibitors that is going to associated with poor patient outcome. If you see, if the patient is on maximally tolerated dose of RAS inhibition, the mortality is less than 10%, but if the patient is either discontinued or down titrated the dose of RAS inhibitor, mortality is more than 20%. So this is the structure of sodium zirconium, and this is inorganic crystalline compound. It's not a polymer. It's insoluble and highly stable in water. It is not absorbed systemically, and this is highly effective potassium binder, and it exchanges potassium for hydrogen and sodium. So this is harmonized and extension trial, which showed that during correction period also, when the sodium zirconium was taken 10 mg thrice daily for 48 hours, there was significant reduction of potassium from 5.6 to less than 4.5. And during the maintenance phase, as compared to the sodium, as compared to the placebo, sodium zirconium 5 mg as well as 10 mg was highly effective in controlling hyperkalemia. And throughout the study period of 11 months, serum potassium level was less than 5.1 milliequivalent per liter. And during the extension phase also, potassium was very well controlled within the normal limit. So this is the same slide. Okay, so this is the important one. We recommend hemodialysis in a patient of hyperkalemia. If other measures failed, or if the patient has severe hyperkalemia, if the potassium is more than 7, then the immediate dialysis is the treatment of choice. So what does dialysis do? Dialysis, this is very effective, no doubt this is very effective. Within 4 hours, potassium can come down to less than 3.5 milliequivalent per liter from the value of 5.5. But within 6 hours, again the potassium rises, and that goes more than 5 milliequivalent per liter. So dialysis is a temporary phenomena. It cannot, you cannot continue dialysis on daily basis, and you have to be dependent on some kind of therapy, either potassium binder, dietary management, to maintain the serum potassium at the desired level. So this is another study, dialysis study. If you see in the pre and post dialysis phase, sodium zirconium group has got even the pre-dialysis phase, the serum potassium is less than 5.1, and in the post dialysis phase also, serum potassium is less than 3.5. As compared in the placebo group, serum potassium is consistently in the higher range. This is another trial. This is the realized potassium trial, and this was the prospective and randomized control trial of 447 patients, and after randomization, the patients were divided equally in the two groups, sodium zirconium plus spironolactone group and placebo plus spironolactone group. In the sodium zirconium group, patients were in slightly higher age group, and the GFR was low, anti-BNP level were high, and the more patients were on the loop diuretic group. And the primary endpoint, that is achievement of normokalemia, that was higher, 71.2% in the sodium zirconium group as compared to the placebo group. But if you saw the adverse event was higher in the sodium zirconium group, two important parameters, that is peripheral edema and the cardiac failure. So why it was so? Because probably the sodium zirconium group has got a sicker patient, and the anti-BNP level were higher in this group of patient, and probably this is the reason why this group of patient has got a higher incidence of cardiac failure and peripheral edema. So these are the practical tips. I am skipping some of the slides. So this is a brief study of sodium zirconium cyclosylate on RAS inhibitor optimization in patients with heart failure with reduced ejection fraction. And this group, in this group of patients, the sodium zirconium was able to maintain normokalemia throughout the study period. And if you see, the more number of patients were able to tolerate ERNI or AC inhibitor or ARB, more number of patients were able to tolerate the MRA, and the more number of patients were able to tolerate the quadruple therapy and triple therapy for heart failure. And if you see the marker of heart failure, that is quite significantly low in the sodium zirconium group. Anti-pro-BNP level was significantly lower, and then the hospitalization mortality rate was also significantly low in the sodium zirconium group. So this is important slide, how we should manage. If the serum potassium level is less than 3, then you need to stop the potassium binder and optimize the RAS inhibitors. But if the serum potassium level is 3.3 to 3.4, then and if the patient is on the lowest dose of RAS inhibitor, then discontinue the potassium binder and optimize the RAS inhibitor. If the potassium is 3.5 to 3.9, you consider optimization of RAS inhibitors and continue the potassium binder. If the potassium 4 to 4.9, no changes is required. If potassium is 5 to 5.4, probably consider increasing the dose of potassium binder. And if the potassium is more than between 5.5 to 5.9, then further increase the dose of potassium binder. But if the potassium is more than 6 equivalent per liter, then probably you need to stop the RAS inhibitor or optimize the or decrease the dose of RAS inhibitor and increase the dose of potassium binder. And how this group of patients should be managed. When you initiate the potassium binder, the first monitoring should be done at the interval of 1 to 3 days. Then after 1 week, then within 2 weeks, and then monthly, and then every 2 months. So in a nutshell, if the patient has got normokalemia, maintain or optimize the dose of RAS inhibitor, maintain potassium binder. If the patient has got mild to moderate hyperkalemia, maintain RAS inhibitor and reduce the dose of RAS inhibitor and increase the dose of potassium binder. But if the potassium is more than 6, probably you need to follow the local guidelines of potassium management and stop RAS inhibitor. If the patient has hypokalemia, then either reduce or discontinue the potassium binder and optimize the dose of RAS inhibitors. So to conclude, heart failure guidelines recommend that recommends optimum GDMT, and hyperkalemia is predictable, treatable effect of optimum heart failure therapy in patient with a history of at high risk of hyperkalemia. RAS inhibitor therapy should no longer be considered as a reversible cause of hyperkalemia, and hyperkalemia can be managed with sodium zirconium to optimize GDMT. In a realized potassium trial, patient with sodium zirconium had 4.4 times higher odds of maintaining normokalemia and optimization of MRA therapy, and real world registry data showed that sodium zirconium is effective to maintain normokalemia while optimizing the GDMT. Thank you for patience hearing.
Thank you, Vedya sir, for your crisp lecture on this hyperkalemia management. So it's a matter of concern that we nephrologists or physicians not using maximum tolerated dose of RAS blockade in our patients. And one of the main reason is this hyperkalemia.
Yes.
And now we have something in our armamentarium to give to our patients so that we can continue with the RAS inhibitors or similar drugs.
Correct.
One thing you had shown that there is a higher incidence of heart failure in those patients who are taking sodium zirconium cyclosilicate. And you had shown that these patients have baseline higher NT-proBNP. Could it be due to the increased absorption of sodium from the gut? Because this potassium, we are exchanging potassium with sodium and hydrogen. That could be a reason?
Possible, that is possible. But if you see this potassium binder, sodium zirconium, that is not at all absorbed from the GIT. And the explanation what they have given, that is because of the more seeker patients were included in that group, because the anti-pro-BNP level was quite high and the dose of diuretics was higher than the other group. So they have explained in that way. And since potassium binder is not absorbed, so probably I don't know the answer, actually.
Sir.
Thank you once again, Dr. Professor Vaidya for giving an excellent lecture on potassium binder. And certainly it is an enabler to optimize the maximum dose of ACRB and other pillars of therapy. My comment is that in CKD, hypokalemia is also not uncommon. So hypokalemia is more dangerous in the long term than slight hyperkalemia. So we should not be very enthusiastic about lowering down the potassium, because if patient is having heart failure, yes, hyperkalemia is associated with bradyarrhythmia and immediate risk of death. But in the long term, if patient is having heart failure, it can cause fibrosis and worsen the situation. So,
correct.
Hypokalemia.
Correct.
In fact, hypokalemia
I agree with Professor Om that we are seeing a lot of patients in our clinical practice, especially those patients who are lean and thin, and the diagnosis is probably CTIN. They are making a lot of urines. The patient doesn't have peripheral edema. So that group of patients are hypokalemic patient. And the beauty of that group of patient, when you supplement potassium in that group of patient, and probably we should not use the sodium bicarbonate tablet in that group of patient if the patient has hypokalemia. When you supplement potassium in that group of patient and the patient started maintaining normal potassium level, serum creatinine level decreases. That is the beauty of treatment of hypokalemia in CKD patients.
And
that is, of course, my personal
And one more point I want to highlight here is that our population is more tolerant to hyperkalemia.
Yes.
What we are studying in our textbooks, our patients have hyperkalemia, but they have lesser manifestation.
Yes, yes. Our few dialysis patients who are on maintenance dialysis for last 4-5 years, what we are observing every time you do serum potassium, monthly we are taking CBC and KFT test. So in that test you see that the serum potassium level is quite high, 6 to 6.5. Even then the ECG changes doesn't take place. And the patient is least worried about the hyperkalemia. In fact, the treating consultants are more worried about hyperkalemia than the patient. So that group of patients, this potassium binder is very useful in decreasing the hospitalization.
Pankaj sir.
Yes.
Actually, what I have observed is that hyperkalemia that we get in our patients is many a times pseudo hyperkalemia, and it is not correlating with the ECG changes. That could be one of the reasons that our patients are tolerating it better.
Only thing is that during the blood collection, that's a very important point. If the technicians apply the tourniquet, that may be, I think, one place where chances of pseudo hypokalemia is high. Correct. Okay.
So if no more questions, we'll close this session. Thank you, Vaidya sir, for your excellent deliberation.
Thank you, sir. I would request Dr. Ashok Vaidya sir and chairperson sirs to kindly move toward the award distribution podium for collection of their memento, and Dr. Mritunjay kindly proceed for memento presentation. Now moving on to the next session, that is on the nephrotic syndrome, and to chair the session we have the leading pediatrician and a very good academician and patron of Dr. Vijay Jain sir. Kindly come on the stage, sir. And the second pediatrician from Gaya, Dr. K Kumar sir. Kindly come on the stage. Then we have Salini Sinha madam, Dr. Salini Sinha madam, and Abhishek Kumar, Dr. Abhishek Kumar, and Dr. Sanjeev Kumar from Department of Medicine, NMCH. Kindly come on the stage. And to deliver the talk, we have Dr. Professor Harshvardhan sir. He is a very good orator, and we at Gaya are always enlightened with his talks. Dr. Harshvardhan sir, kindly come on the stage. Dr. Jain sir, kindly take over the mic and start the session. Thank you, sir.
First of all, thanks to the
Dr. Neeraj and Dr. Mritunjay for giving this subject of nephrotic syndrome to a pediatrician. Basically, nephrotic syndrome is a disease of childhood below 16 years. The books say and the incidences are 3 to 5 per lakh, but actually the figures are not correct. In my 50 years of successful practice, I have seen every month 1 to 2 cases of nephrotic syndrome. I have treated so far more than 500 cases of nephrotic syndrome so far, successfully. The disease is notorious for one thing, relapses and remissions, relapses and remissions. So, and it is the most common childhood renal disorder which we come across. And the diagnosis, Dr. Rishikesh is here, Kranti is here. We can diagnose the patient as soon as he enters the chamber. This is nephrotic syndrome. So now I don't go into detail because I may go on speaking about nephrotic syndrome for hours and hours. So I invite Dr. Harshvardhan to deliberate, to give his deliberation on this subject of nephrotic syndrome.
So, good afternoon to all, and I would like to thank the organizers for giving me this opportunity to speak on a very important subject. But primarily I am a adult nephrologist, so I'll be dealing with nephrotic syndrome in adults. This talk would be focusing on that. So the learning objective of this talk is recognize the clinical features and diagnostic criteria of nephrotic syndrome, understand the key etiologies in adult and children, develop a systemic approach to initial workup, apply evidence-based management strategies, and identify complications and when to refer to a nephrologist. So if we see nephrotic syndrome defined as proteinuria more than 3.5 gram per day or urinary PCR more than 3.5 gram per gram plus hypoalbuminemia, which is less than 3 gram per deciliter, peripheral edema, hyperlipidemia, lipiduria. So nephrotic syndrome is proteinuria more than 3.5 gram per day with hypoalbuminemia, edema and hyperlipidemia. And nephrotic range proteinuria is proteinuria more than 3.5 gram without full-blown nephrotic syndrome. And nephritic syndrome, we all know, hematuria, RBC cast, hypertension, oliguria, and mild proteinuria. If we see the epidemiology, it's around 3 per lakh annual incidence in adults. It's 16 per 1 lakh annual incidence in children. And minimal change disease is the most common etiology in children. So peak incidence in children is around 2 to 6 years. In adults, the increasing prevalence is gradually increasing of FSGS, especially in African Americans. And diabetic nephropathy is the leading cause of secondary nephrotic syndrome worldwide. And membranous nephropathy is the most common primary nephrotic syndrome in adults, but different centers have reported differently. Some say it is FSGS now. If we see the pathophysiology, it's the endothelium, which is the fenestrated capillary endothelial cell with glycocalyx, which gives you a charge selectivity. Then you have glomerular basement membrane, which is type 4 collagen, laminin, heparin sulfate, proteoglycans, which is a charge barrier. Then you have a slit diaphragm, which is nephrin, podocin, final size, which is a selective size barrier. So injury to any component, which leads to loss of selective permeability, massive protein leak. So you have a loss of charge barrier leading to selective albuminuria, and protein barrier, non-selective albuminuria. So again, this, as you can see in this diagram, it is endothelial fenestrated capillary plus glycocalyx. You have glomerular basement membrane, which is charge barrier, and you have podocytes. So barrier injury leads to loss of selective permeability. You have proteinuria. So mechanism of edema, we all know it is, there are two hypotheses, underfill hypothesis, which albuminuria leads to hypoalbuminemia, leads to decrease in oncotic pressure. There's fluid shift to interstitium, decrease intravascular volume. You have RAS activation, and you have sodium and water retention. The overfill hypothesis, you have primary renal sodium retention, ENaC activation, intravascular volume expansion, edema, and which is independent of albumin level. So both mechanisms likely coexist. So consequence of
nephrotic syndrome is hyperlipidemia and hypercoagulability. So hyperlipidemia leads to increased hepatic lipoprotein synthesis. You have decreased lipoprotein lipase activity. You have raised LDL, VLDL, and lipoprotein A. You have decreased HDL. So hyperlipidemia in adults leads to accelerated atherosclerosis risk. Hypercoagulability in nephrotic syndrome is primarily because of the urinary loss of antithrombin 3 protein C and S. You have increased hepatic synthesis of fibrinogen, factors 5, 7, and 8, increased platelet aggregation. You have more chances of renal vein thrombosis, and risk is around 1.5 to 3% per year. The main classification of nephrotic syndrome is primary, which is idiopathic, and secondary. The primary causes are minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, membranoproliferative GN, and IgA nephropathy. And secondary, most common is diabetes. Then you have amyloid, lupus, infection, drugs, malignancy, and the list goes on and on. The common causes by age group is children 1 to 10 years. Minimal change disease is the most common. Adolescent, minimal change disease and focal segmental glomerulosclerosis. In adults, usually membranous, but FSGS is also very common. In elderly, it is usually the membranous nephropathy. So the key features of minimal change disease is most common in children. Light microscopy is usually the normal looking glomerulus. Electron microscopy, you have diffuse podocyte food process effacement, and IF is negative. And you have selective proteinuria, mainly albumin, and response to steroid is excellent. Usually 90% of the children respond to steroids, and around 70 to 80% in adults. It has got a very high relapse rate, especially in children. The secondary causes needs to be ruled out as are NSAIDs, lithium, lymphoma, malignancies. Focal segmental glomerulosclerosis, rising incidence. Now most common glomerulonephritis in African Americans, associated with APOL1 gene variants. Light microscopy, you have segmental sclerosis in some glomeruli. Electron microscopy, you have diffuse food process effacement. And the variants are not otherwise specified: perihilar, tip, cellular, collapsing. These are the variants. That is called the Columbia classification. Then the steroid response is less than you see in minimal change disease, and almost 30 to 50% progress to end-stage renal disease within the span of 10 years. And it can occur in transplant population. Membranous nephropathy, we all know, most common primary nephrotic syndrome in adults. You have, now membranous nephropathy is something where you get a new antigen being discovered almost every 6 months. So currently, the most common way of diagnosing it is anti-PLA2R antibody, which is around positive in 70% of the primary membranous, which is a diagnostic biomarker. Then you have thrombospondin antibodies. Then there are a whole lot of other antigens which are being seen in membranous. In light microscopy, you have thickened glomerular basement membrane with subepithelial spikes. Immunofluorescence, you have granular IgG4 deposits and C3 deposits along the glomerular basement membrane. And rule of third is there, which is a famous rule of membranous. That is 1/3 goes to spontaneous remission, 1/3 is stable, and 1/3 progresses. It has got highest thromboembolism risk amongst nephrotic diseases, renal vein thrombosis. And the common secondary causes of membranous are lupus, malignancy, hepatitis B and C viruses, and drugs. So if any elderly, if you have features of secondary, one needs to rule out any underlying malignancy. The clinical presentation, we all know: edema, proteinuria, fatigue and malaise, and infections. Usually the diagnostic workup is urine dipstick, where you have more than 3+ proteinuria, spot albumin to creatinine ratio more than 3.5 grams. 24 hours urine protein is usually more than 3.5 grams, but this is not very usual. You can see various, the values of proteinuria, but usually more than 3 grams or 3.5 grams. Serum albumin is usually less than 3. Cholesterol is raised, and urinary microscopy, I mean, we see oval fat bodies or fatty cast in light microscopy. Essential workup is ideally CBC, serum albumin for the diagnosis, lipid panel, urine routine, renal ultrasound. Basically, this is something which we normally do, and then according to the thing which you are suspecting, you can add on things in your diagnostic workup list. So the most important thing is when to perform a kidney biopsy. So ideally, all adults with nephrotic syndrome with first presentation should be biopsied, ideally. Then steroid-resistant nephrotic syndrome in children. If anybody is having atypical features, hematuria, low complement, renal impairment, or age more than 12 years at presentation, when you are suspecting a secondary cause, then frequent relapser or steroid dependent before starting any kind of immunosuppression which would be there for long term there with the patient. Biopsy may be deferred, where 1 to 12 years of age when you're classically suspecting it to be a minimal change disease. Clear diabetic nephropathy, when you have a positive PLAR2 antibody for membranous nephropathy, also biopsy can be deferred, but then your opinion is varied here. And what are the contraindications? So solitary kidney, bleeding diathesis, uncontrolled hypertension, these are usually contraindications of doing a kidney biopsy. But kidney biopsy is a relative safe procedure of, diagnosing causes of nephrotic syndrome and treating accordingly. So proteinuria more than 3.5 plus hypoalbuminemia plus edema, history examination, basic labs, you do it. If it is a child, you start with steroids. In adult, do a biopsy and accordingly do a targeted therapy. Management, generally supportive measures, salt restriction, fluid restriction only if severe hyponatremia, diuretics, ACE inhibitors, ARB, first-line antiproteinuric therapy in adults, statin therapy for nephrotic syndrome in adults, protein intake. In secondary, when you are suspecting diabetes, protein restriction should be there, but then in primary membranous, you should be, supplementing 1 gram of protein for every extra 1 gram loss in the urine. Edema management is mild edema, salt restriction, oral diuretics. When you have moderate edema, you can increase the diuretic dose, add metolazone. When it is refractory, you can think of, giving IV furosemide infusion. And when edema is anasarca, you can try, you may be requiring high dose of furosemide, maybe continuous infusion, metolazone or other methods. Management of minimal change disease in children, first episode, usually prednisolone for 60 milligram per meter square per day, maximum 60 milligram for 4 to 6 weeks. You can taper it. For first relapse, you can repeat the steroid dose. Frequent relapses, various drugs are available, cyclophosphamide, calcineurin inhibitors, mycophenolate, rituximab. In adults, you start with prednisolone 1 milligram per kg per day, maximum 80 milligram. You taper over 6 months. Response may take longer than children. And if the patient is steroid resistant or dependent, calcineurin inhibitors, rituximab, cyclophosphamide, mycophenolate, mofetil. These are the drugs which we commonly use if you don't get the response. So management of focal segmental glomerulosclerosis, again prednisolone, ACE inhibitors, ARBs, steroid resistant calcineurin inhibitors. Then you have the genetic variants of focal segmental glomerulosclerosis, genetic workup when you get a monogenic cause of focal segmental glomerulosclerosis. Usually they do not respond to immunosuppression, and ideally immunosuppression should not be given to them. When you have a secondary cause of focal segmental glomerulosclerosis, you need to treat the underlying cause, and ideally ACE inhibitors, ARBs, immunosuppression usually not indicated. Management of membranous nephropathy, ACE inhibitors, ARB conservative therapy, and the drugs which we commonly use is rituximab. You have modified Ponticelli regimen, calcineurin inhibitors, and if you are having high risk features, let's say serum albumin 2 or rising creatinine, then early immunosuppression should be used. So basically, management of membranous nephropathy is on risk stratification, mild, moderate, and severe. So you decide accordingly. So managing complication, thromboembolic complication is a major complication, and the risk of thromboembolic episode is around 1.5 to 3% per year, and it's up to 30 to 40% in membranous nephropathy. Renal vein thrombosis, especially membranous nephropathy, risk factor is albumin less than 2, immobility, where you have any foreign body there like central lines and other immobility if it's there. Anticoagulation strategy is prophylactic anticoagulation. Consider if serum albumin is less than 2 or 2.5. Warfarin should be used with a target of 2 to 3. The DOACs can also be used, but less data in nephrotic syndrome. Therapeutic anticoagulation for documented venous thromboembolism, minimum 6 months or until nephrotic syndrome remission. So we do it according to the scoring system. Infection risk in nephrotic syndrome, you have urinary loss of IgG and complement factors, you have impaired T cell function, you have immunosuppressive therapies which makes them prone to infection. You have edema which causing tissue provide culture medium. Common infection is, the capsulated organisms, spontaneous bacterial peritonitis, cellulitis, pneumonia, sepsis. Ideally, the person should be vaccinated with pneumococcal, influenza and hepatitis B vaccine. Other complication is acute kidney injury, which we commonly see with pre-renal AKI, aggressive diuresis, sepsis, intravascular volume depletion, bilateral renal vein thrombosis, flank pain, hematuria, sudden rise in proteinuria, rising creatinine, acute tubular necrosis like non-steroidal anti-inflammatory drugs, use of IV contrast, aminoglycoside, higher risk in nephrotic syndrome. Then nephrotic syndrome can also have acute interstitial nephritis, especially drug-induced, where you have eosinophilia, rash and fever, and collapsing variant of focal segmental glomerulosclerosis can have rapidly worsening of renal function. So it requires urgent intervention. So special population, as pointed out, nephrotic syndrome in children, steroid sensitive, more than 90% in childhood. Complete remission, relapses are common, steroid resistant. So growth and steroid toxicity are there if you continue using steroids. So nephrotic syndrome in pregnancy and the elderly. Pregnancy, preeclampsia mimics nephrotic syndrome, and currently it is the most common cause of nephrotic syndrome in pregnancy. So active nephrotic syndrome increases the chances of preeclampsia, preterm delivery and IUGR risk. ACE inhibitors are usually contraindicated. Use the drugs which are safer to use in pregnancy. Safe immunosuppressions are azathioprine, cycloneurine inhibitors and low-dose steroids. Avoid cyclophosphamide, mycophenolate or rituximab. They have got higher venous thromboembolism risk in pregnancy. So use low molecular weight heparin. Elderly, membranous nephropathy and amyloidosis. Amyloidosis is also common. It is not that uncommon to have nephrotic syndrome in adults. Screen for malignancy, paraneoplastic membranous nephropathy is very common. Biopsy is important. Age alone is not a contraindication. Steroid side effects amplified. Use lower steroid doses, shorter courses, and rituximab is being increasingly preferred over cyclophosphamide. So when to refer? New onset nephrotic syndrome in any adult, steroid resistant, steroid dependent nephrotic syndrome in children, rapidly declining renal function, when you are suspecting secondary cause requiring immunosuppression, need for a kidney biopsy, refractory edema or complications, consideration for more aggressive immunosuppressive therapy, and nephrotic syndrome in pregnancy. So monitoring and follow-up, ideally urinary PCR or 24 hours urine protein measurement should be done almost every 1 to 3 months. Serum albumin every 1 to 3 months, serum creatinine, GFR, lipid panel, blood pressure, all these has to be monitored accordingly. And you need to see that you need to adjust the steroid doses accordingly and see for steroid toxicity, because it is, the toxicity is pretty common with drugs. So what are the key take-home messages? Nephrotic syndrome, proteinuria more than 3.5 gram per day with hypoalbuminemia, edema. Children, presume minimal change disease, start empirical steroids. Adult, biopsy. Always try to do a kidney biopsy to know the cause of nephrotic syndrome. Anti-PLA2R antibody is a non-invasive marker of membranous nephropathy. You can go ahead with that. ACE inhibitors, ARB, are foundational in all nephrotic patients for proteinuria reduction. Thromboembolism is the most dangerous acute complication. Prophylactic anticoagulation is if serum albumin is less than 2.5. Monitor for steroid toxicity, infection, AKI and hyperlipidemia. Refer early. Delayed referral worsens outcomes. Thank you.
Hello. Is there any role of levamisole?
So yes, I mean, it has got a role, but definitely it's now not the first line drug which you normally use. So after
whether cyclophosphamide is better than levamisole?
Yes. The current recommendation also suggests that.
Now, for the house, two things are very important. As far as, because the children suffering from nephrotic syndrome very prone to have infections, so the vaccination is very important. You have already told about the pneumococcal vaccine and flu vaccine every year, but we shouldn't give live attenuated vaccine.
Right.
Like BCG, like chickenpox, like MMR. These vaccines should never be given if the child is getting prednisolone. The dosage of prednisolone, you are told according to meter, it is 2 milligram per kg, and the same dosage of cyclophosphamide. Third, there is a new word, congenital nephrotic syndrome. That is also there. We come across the cases. If the nephrotic syndrome occurs since birth to 3 months, the definition is birth to 3 months, it is called congenital nephrotic syndrome. Again, it may be idiopathic or may be secondary. So that should be also considered in diagnosing the case of nephrotic syndrome. But the vaccination part is very important. That's the most important thing. And of course, if you are giving cyclophosphamide, you have to take care of so many things. And if doesn't act, you may cyclosporin has also been recommended besides cyclophosphamide. So,
and vaccination should be given at least 4 weeks of stopping the steroid therapy. At least 4-week gap should be there.
Sir, I would like to add to it. So, since vaccination is very important, considering the pediatric population, and since the pediatric population is the one who have very frequent relapsers and all. So we must not take a chance to not give them the opportunity to get vaccinated. So now the recommendation is, if the child is on alternate day therapy, we can give. So we should not miss that chance. And sir, I would like to congratulate you you have done a great justice to this topic, which we know it is a mammoth task to consider the whole nephrotic syndrome in such a short duration of time. Since this gathering is a heterogeneous one, we have a good proportion of nephrologists as well as practicing physicians. So as nephrologists at a tertiary center, it is very easy for us to say that why the steroid was started and what should we do now. But we know that there are compelling reasons to start steroids. And then when we see those patients, we don't know what to do of them. So if you can guide us as nephrologists and also the physicians, how to introduce the steroids as well as when to stop them, how to manage those cases. So
basically it's a difficult thing, because ideally when you
एक चीज का ध्यान रखिएगा for the house, since the dose of prednisone is 2 milligram, अगर 15 kg का बच्चा है तो 30 kg हो गया, 30 milligram हो गया, तो दवा दुकानदार क्या कहेगा, बड़ा पावर का दवा दे दिया है ना, वो इसको 5 milligram कर देगा. आपने दिया 30 milligram, 10 tablet of 10 mg 3 times a day, वो उसको 5 milligram कर देगा. And naturally it will become the resistant. It's a steroid resistant nephrotic syndrome. So ध्यान रखिएगा जरा इस चीज को. Yes sir.
I will present a subset of patients. A group of patients having massive proteinuria, right? No edema, normal total protein, normal albumin, right? Normal lipid profile. What to do? I think many of you must have seen. Have you seen these cases? Heavy proteinuria, no edema, normal total protein, normal serum albumin, normal lipid profile. No, the problem is, what is the recommendation? Is there any recommendation by KDIGO
The answer is no. I have searched it. I had to give talk on this topic. This is one. The second thing is how to approach the subnephrotic proteinuria patients. That is another question. It's a very difficult thing. And my experience, I will tell you. I biopsied 9 of my 20 patients. All of them, we have reports from Lal Pathology. They all have minimal change disease. They have minimal change disease. Yes, 4 gram, 3.5 gram, like that. And all of them, 9 of 20 patients, my patients, they have minimal change disease. I wanted to discuss this matter for a long, long time, but today I have got a platform. And about a subnephrotic proteinuria, I had a talk in Bhagalpur. There also I searched KDIGO. Till date, KDIGO doesn't have any guidelines how to approach for subnephrotic proteinuria. They have sporadically suggested in some recommendation few things, but there is no straightforward guidelines. This is why I wanted to share with you.
You have spoken very well, Dr. Harshvardhan. Congratulations. Thank you. No more questions.
Thank you, Dr. Harshvardhan.
We should end the session.
Thank you, Dr. Harshvardhan sir, for the wonderful presentation. Now I am going to request Dr. Mritunjay sir for the further momentum. Yeah. Now I would like to request our chairperson for the next session to kindly take their seats. Dr. P K Singh sir, Dr. Gunjan Kumar sir, Dr. Neeraj Kumar sir, Dr. Santosh Kumar sir, Dr. Chandra Kiran sir. It is my honor to introduce our speaker, Dr. T. Brozen Singh sir, who will now enlighten us now the topic of acute kidney injury in the ICU and sepsis.
स्लाइड चेंजर यूज करेंगे यहाँ पे हो जाएगा ठीक
हेलो हेलो Hello.
Hello. Now I would like to welcome T. Brojen sir, who is the professor and head RIMS Imphal, and we are discussing the very important topic, that is the AKI in intensive care unit. That is the most important problem faced by the intensivist we are dealing with in day-to-day practice, and hope this is very beneficial for us and the crowd as well. Thank you. Yes, sir. Please continue, sir.
Yeah, thank you. And thank you very much, the organizing committee, Dr. Mritunjay sir, then Dr. Pankaj sir, for inviting me in this August gathering. The topic given to me is acute kidney injury in ICU and sepsis. When I got the topic first time, I thought that it should be like acute kidney injury and sepsis in ICU like that. But somehow I have prepared, and this topic is very important, as our chairperson had already said. And even the definition of acute kidney injury also has been changed in this 2026. So we know that acute kidney injury is a common complication in ICU patient, and it causes multiple system sequelae and lesions in even the extra-renal organs also. And the thing made worse by presence of sepsis, which is very important in ICU population, and it exerts a negative course and the overall prognosis of the patient in terms of morbidity and renal outcome. Many studies have found that this isolated AKI, which is non-ICU AKI, they have mortality around 10%. But when AKI develop in ICU patient, and it is most of the time associated with sepsis, and the mortality rate goes up to 50%. And this subset of group of patients require more RRT in comparison to non-ICU AKI patients. And there is increased chance of CKD by 3-4, and this has got great impact to the patients. Many studies in Europe have found that around 50% of the 54% of AKI is because of the sepsis, and even in the Indian studies and the other developing countries also, it is associated with around 37%. And this AKI may develop in the community or even may develop in the hospital. Those patients who develop AKI in the hospital setup or iatrogenic in the sense, it has got more worse prognosis. This is an Indian study from Andhra Pradesh. Here they have studied around 650 patients of AKI and found that nearly around 70% of the patients were sepsis-associated AKI. And they have studied the outcome at 1 week and 1 year. At 1 week, around only 9% of the patients can get complete recovery. At the end of 1 year, survival rate was around 72% had recovered, and out of this 72%, out of those remaining, 28% expired, and this around 28% of the patient had developed CKD. There are multiple predisposing factors of AKI in ICU and the sepsis patient. These are hypotension, then hypovolemia, then we are using many drugs in the ICU like contrast, aminoglycosides for prevention of infection. All those things has impact on the patient, and the chance of developing AKI is very much high. Then on top of that, cardiac dysfunction, tissue edema, fluid overload, then abdominal hypertension like ascites, all these things will contribute to the development of AKI in ICU patient. Then existing renal disease, existing heart failure, chronic liver disease, presence of anemia in the patient, then need for mechanical ventilation and the surgery also will predispose the patient of ICU to development of this AKI. Coming to the pathophysiology of this sepsis-associated AKI, previously that was thought that renal hypoperfusion is the male culprit, but many animal studies had found that even with the gram-negative infection, there is increase in the renal perfusion, and there was no this clear-cut acute tubular necrosis. Now the hypothesis has changed that there is stimulation of inflammatory cascade, there is macrovascular as well as microvascular dysfunction associated with cellular abnormal responsibility to the injury. All these things contribute to the development of AKI in sepsis in ICU patient. This is a diagrammatic presentation where sepsis-associated AKI is developed with the systemic and the renal inflammation that will produce microcirculatory dysfunction, then mitochondrial dysfunction. All those things will lead to sepsis formation. Then on the other hand, presence of AKI in ICU patient will lead to sepsis, and this is interacting each other and form a cascade. Now coming to the diagnosis, how we will diagnose the AKI. This is KDIGO criteria for diagnosis of AKI. Here, main two parameters are there: functional criteria with the urine output and the serum creatinine level. Then another criteria is structural criteria, where they have included the biomarkers. So definition goes that when there is increase in the serum creatinine by 0.3 milligram per DL developing within 48 hours, or increase in the serum creatinine by 1.5 times from the baseline that has occurred within 7 days, or increase in the serum cystatin by 1.5 times baseline that is known or presumed to have occurred within the prior 7 days. And urine output of less than 0.5 ml per kg per hour more than 6 hours. So this is the staging of AKI. AKI stage 1, stage 2. This is just repetition of what I have told. And this is the staging, severity staging of AKI, which is published in the KDIGO in March 2026. Here they have included the structural criteria. In this, they have incorporated the this importance of biomarkers, and this, if patient has got presence of biomarker, they put as B1. If biomarker is absent, then B0. So diagnosis of sepsis and the AKI, there should be one focus of infection or evidence of documented infection, then the presence of AKI by KDIGO criteria. These are some of the important biomarkers which being used in KDIGO guidelines also. Cystatin C, as we all know, this is very important, and it raised even before the increase in the serum creatinine in patient of AKI. Then others like NGAL, internucleal 18, then KIM1. These are some of the biomarkers which is being used. But this biomarkers also has got drawback, and we should do interpretation very cautiously, because it may increase in other conditions also, like UTI, CKD, even in the SLE, which is common in this our setup. They can influence, or they can give false positive tests for the biomarkers. So interpretation should also be incorporated with the clinical pictures of the patient. This is a very important portion, how to prevent AKI in ICU. Prevention will be hovering around maximum fluid management, hemodynamic management, then prevention of and the treatment of the infection, use of diuretics for volume overload patient, then keeping a good control of the glucose, then other things. I will come one by one. Now coming to the fluid management, KDIGO has recommended using buffer crystalloid instead of using this normal saline for volume expansion in patient with AKI. But this normal saline should be used when the patient has got traumatic brain injury, or patient is at the risk of developing AKI or AKD, like in the case of pigment associated AKI, contrast-induced AKI, tumor lysis syndrome, etc. In this case, we should use normal saline. Otherwise, buffer crystalloid or balanced crystalloid is the drug, is the IV fluid of choice. And this AKI patient has got severe metabolic acidosis, but it is not always that metabolic acidosis should be subjected to RRT. They have recommended that even the severe metabolic acidosis with pH less than 7.2 may be tried with intravenous bicarbonate before starting RRT. And they also had suggested that for those patients who are undergoing surgery, it is better to put around 1 to 2 kg of fluid positive balance during the next 24 hours of the post-operative period instead of using no fluid gain. So they have recommended using adequate hydration in this group of surgical patient also to prevent development of AKI. And coming to the hemodynamic management, we should try to keep the patient mean arterial pressure above 65 as a target to fluid therapy. And if it is not maintained by fluid therapy, then vasopressor administration, especially norepinephrine, should be started. And vasopressin is the second choice of drugs. And we should assess the fluid status of the patient before giving fluid, and before starting the vasopressin, we should hydrate the patient by seeing the parameter of the hydration. This we can do by seeing central venous pressure. We usually try to keep the patient central venous pressure around 12 to 13. Then we can measure IBC diameter. It should be ideally 1.5 to 2.5 centimeter. If it is less than 1.5, then we should try giving IV fluid again. And if all those things fail, then we should use vasopressor. And it has been suggested in this new guideline that those patients who are undergoing cardiac surgery without CKD, they may be given prophylactic intravenous amino acids for prevention of development of AKI. That we were using previously, nephrosterine, all those things can be given for surgical patient if patient is not having CKD for prevention of AKI. This slide I have included specifically because many of times we got the reference for giving contrast in patient of CKD or in patient of ICU, whether we should go for contrast. This patient, is there any chance of developing AKI? So for that purpose, we have to see the hemodynamic parameters of the patient. KDIGO had recommended to use either left ventricular end diastolic pressure or central venous pressure or bioimpedance vector analysis, which is not readily available. But left ventricular end diastolic pressure and the central venous pressure we can assess clinically on the bedside, and we can advise the patient for hydration before going for contrast administration or contrast imaging. They have recommended using sodium chloride bolus at the rate 3 ml per kg for 1 hour before the procedure. After that, we will subject the patient for this echocardiographic examination, and we'll see the left ventricular end diastolic pressure. If it is less than 13, then we can increase the IV fluid rate to 5 ml per kg per hour. And if it is between 13 to 18, then you restrict to around 3 ml. Or if it is more than 1.5, then 1.5 ml if it is more than 18 mm mercury for at least 4 hours after the procedure. Then if the patient is already on the central line, and if we can measure the central venous pressure, that also we can use as a parameter for assessing the IV hydration for patient going for contrast. If the CVP is less than 6 centimeter of water, then 3 ml per kg per hour should be given. Then if the CVP is between 6 to 12, we can give around 1.5 ml per kg per hour. And if the CVP is more than 12, you give around 1 ml per kg per hour. And this has to be started 6 hours prior to the procedure and continue for 12 hours after the this procedure. Now coming to the other recommendation for prevention of AKI in the ICU, use of diuretics. In KDIGO, they have recommended using these diuretics only when there is volume overload, and it is not advised for those in routinely use. And the glucose control target of around 140 to 80 has been recommended. And for hepatorenal associated AKI, we can use terlipressin, norepinephrine as a first line. Then add midodrine or octreotide as an alternative along with albumin. In the tumoral lysis syndrome and pigment associated AKI, then we should use IV crystalloids. These are the guidelines for KDIGO consensus guideline for prevention of AKI. We should monitor the patient stage-wise, and according to the different stages, we have different intervention. Like you discontinue all the nephrotoxic drugs, ensure the volume status and the perfusion pressure, and maybe we have to monitor the patient with invasive or non-invasive mechanisms also. Now coming to the treatment, we have to hit the target by many mechanisms. We should control the infection by using appropriate antibiotic based on the local susceptibility pattern. Then IV fluid resuscitation. If require vasopressin support, then avoidance of nephrotoxic drugs. These are the pillars for prevention of ICU AKI as well as treatment of this AKI in sepsis and ICU. So management of vasodilatatory shock require timely fluid resuscitation, as I already mentioned, vasopressin therapy, first epinephrine, then vasopressins. Then we should try to find out the reversible factor for refractory shock, such as metabolic and electrolyte abnormalities, control the source of infection, then timely intervention with lung protective mechanism, mechanical ventilation are some of the important therapeutic adjunct. Coming to the antibiotic therapy, that will depend on whether the patient has got sepsis, which is definite or probable, or shock is present or not, along with that. If sepsis is definite, whether the shock is present or not, then administer antibiotic immediately within 1 hour. If the sepsis is possible and the shock is present, then also we should administer the antibiotic within 1 hour. Then if sepsis is possible but shock is absent, we have some time to investigate the source of infection, then other non-infectious causes of acute illness, and treat accordingly. But we should administer the antibiotic preferably within 3 hours of the diagnosis. This one just as I already told, our main target for prevention of AKI as well as treatment of AKI is to maintain the mean arterial pressure around 65, more than 65, and this target may be a bit higher in patients with chronic hypertension. Coming to the RRT in AKI, renal replacement therapy should be taken into many factors like patient's wish, then local export availability, then other parameters. AKI recommend that AKI is that previously there was debate about the early initiation and the late initiation. Now KDIGO had recommended that deferred or late initiation is the better choice over the early initiation. Deferred initiation involves waiting the patient have medically refractory complication or persistent stage of stage 2 or 3 exceeding for more than 48 to 72 hours. If the patient has got stage 2 or 3 AKI and the persisting more than 48 to 72 hours, then we should take up for the initiation of RRT. And this deferred RRT, keeping the patient in deferred RRT, the physician treating the patient should be in a position to take up the patient immediately whenever he required the RRT. These are some of the indication for urgent RRT. We all know that severe hyperkalemia, which is not treatable, which is not correctable by medication therapy, then severe acidosis, which is refractory to medication therapy, diuretic resistance pulmonary edema, excessive fluid accumulation refractory to medication treatment by using optimum dose of diuretics, appropriate in the interval, then we should take up for RRT initiation. Then uremic complication like bleeding, pericarditis, then encephalopathy. In addition to this, severe intoxication with a dialyzable drug or toxin should also be subjected to this RRT initiation. Another thing is that those patients who is with the hepatic encephalopathy may be beneficial by initiating RRT early, even if the patient is not having much uremic symptom, because that clear the ammonia level and help in recovering his level of consciousness also. So what should be the modality? KDIGO guidelines had clearly mentioned that CRRT or acute PD is this more beneficent than the conventional intermittent renal replacement therapy. Then CRRT is especially indicated when there is brain injury and there are previously we call it ISNEZ. They have changed to the prolonged intermittent renal replacement therapy. This is an alternative to CRRT in critically ill patient also. Dose, what should be the dose? If we are giving CRRT, that should have the delivery and effluent volume of around 20 to 25 ml per kg per hour. Then if we are using IRT or intermittent hemodialysis or prolonged intermittent hemodialysis, then target KT by B should be around 3.9. Or if we are using acute PD, a weekly of KT by B 2.2 is the adequate dose of dialysis. Coming to the anticoagulation, KDIGO had recommended using resonance citrate for CRRT and then unfractionated low molecular heparin or low molecular heparin for other form of dialysis. When to discontinue? This is an important question. And then obviously it should be stopped when there is clinical improvement, but presence of urine output more than 450 ml per 24 hours without exposure to diuretics, or if the patient is on diuretics, urine output of more than 2.3 liter per 24 hours is an parameter which we can decide for stopping renal replacement therapy. To conclude, AKI is prevalent in critically ill patients, especially in ICU patient, and it is complicated by presence of sepsis again. And features like hypovolemia, hypoperfusion, sepsis, and shock. These are some of the contributing factors. Early recognition of the pathophysiology AKI by careful review of the patient history and the hospital course is essential for better outcome. Early initiation of management strategy is required to further progression of the AKI and to CKD and increase mortality. Thank you.
Thank you, doctor. Very good. One question I would like to ask you. You see, just 10 years ago, we were used to see all these type of renal diseases divided into acute renal failure and chronic renal failure. These were the terms used there. Acute renal failure were ascribed to so many conditions you have described, besides other conditions leading to hypovolemia or loss of blood or anything like that. So in the setting you have described in ICU and sepsis resulting in this AKI, is there any guidelines to start the antibiotics which should be broad-based and which should be used? Or is there any protocol for aminoglycosides to use in these conditions, or what are the antibiotics we should start? Because as a doctor in OPD, we are actually not seeing these cases too much. So please suggest something about that thing.
Yeah, actually, regarding antibiotic therapy, it will depend on the pattern of the local sensitivity pattern. And if we cannot get the culture sensitivity report immediately for prevention or for sepsis treatment, it's better to cover both the gram-positive and the gram-negative. So, and if the patient has got some predisposing condition to AKI, then we should try to avoid the nephrotoxic antibiotics like aminoglycosides and all. And so antibiotic guidelines will depend on the pattern of the local culture sensitivity patient pattern.
Audience, any question?
Sir, one question I would like to ask. Yeah. Generally, patients with sepsis presented with AKI, and in that case, we have to administer higher antibiotics. So many times we are confused that about the dose modifications of the antibiotics, which are the nephrotoxic. We have to avoid the nephrotoxic antibiotics, but in that case, patient is in sepsis, so we have to give. So what about dose modification? Because we have to remove the source, and the cause of the AKI is the sepsis. So regarding, we have to modify the dose according to the creatinine clearance, or we have to give the full dose. So many times we are confused about that. Please elaborate, sir.
Yeah, for this though, for antibiotic, we have to see the creatinine clearance, and accordingly we have to modify it, because even if you give the full dose, it's going to produce more harm. And as the this concentration will be more as patient goes to AKI, urine output will be reduced, and the clearance will be less. So there will be more accumulation of those antibiotics. So creatinine clearance will guide you, and to some extent this urine output and all we have to assess.
Okay, sir. But initially, sir, we have to give the loading dose, sir, and we then modify the maintenance doses.
This maintenance dose.
Okay. Okay. Thank you. Thank you so much, sir.
Thank you. We conclude the session. Yes. Yes.
You have already told that whenever we have to give antibiotic in sepsis, septic shock, we have to give and broad spectrum antibiotic, gram-negative, gram-positive, anaerobic, all. And the loading dose remains the same. And for modification of further dose, you require to calculate the eGFR. But in AKI, there is no such validated formula to find the exact GFR. But if patient is oliguric or anuric, we should assume that GFR is less than 5. So calculate all the further doses on that basis. And don't be ashamed to consult the book or your ready reference in the mobile. You cannot remember all those doses of antibiotic in various reduction of. And the most important thing is de-escalation of the antibiotic. Once you get the culture report, you please de-escalate the antibiotic according to the sensitivity. And if you want to give aminoglycoside, suppose sensitivity comes only with aminoglycoside, then you have to give an aminoglycoside. And only practical thing which already known to all of us, that the single dose of amino acid is less nephrotoxic than divided doses. Thank you.
Yeah. Since there are many physicians participating in this CME, I would like to give one very important suggestion. UTI is a very common cause of urosepsis in ICU. They'll end up in ICU. Do not use nitrofurantoin if there is renal impairment. It will not work. Remember it. Remember the lines of Lawrence pharmacology. It is very clearly written there. So do not use nitrofurantoin. If the renal impairment is there, it will not be effective.
Any more questions from the audience? So we can conclude the session. Thank you.
Thank you.
Thank you, sir, for the wonderful presentation. As we are running out of time, I would like to invite our next panel discussion on topic electrolyte disorder in nephrology update. I would like to request our chair. I would like to request our panelist, Dr. Rishi Kishore, Sir, Dr. Dharmendra Prasad, Sir, Dr. Prem Shankar Patel, Dr. Atma Prakash Nayak, Sir, Dr. Manoj, Sir, kindly please join on the stage.
लॉरेंस पर है वे आदमी है भाई चलता है कि नहीं लॉरेंस नहीं चलता है ना.
So we are moving forward for the panel discussion on electrolyte disorder in nephrology practice.
Good evening, everybody. So, for the last event for today, we are going to discuss about electrolyte disorders in nephrology practice. This is a very vast topic, and we have a little bit less time, so we will try to keep it short and very discreet. I am Dr. Abhishek Raman. I am a consultant nephrologist at Medanta, Patna. We have with us our expert panelists, Dr. Rishi Kishore sir, who is a senior consultant in Mediversal Hospital, Patna. Dr. Atma Prakash Nayak sir, who is senior consultant in Paras Hospital, Darbhanga. Dr. Manoj Gupta sir, assistant professor in Kathiar Medical College and practicing nephrologist in Purnia. Dr. Prem Shankar Patel sir, associate professor in IGIMS. Dr. Pankaj Mishra sir, who is a senior consultant in Medica, now I think Manipal Hospital in Ranchi. And last but not the least, Dr. Jamshed Anwar sir, who is a senior consultant in Paras Hospital, Patna. So without any further ado, let's start with the questions. First, my question will be to Rishi sir. Sir, very common problem that we face in our day-to-day practice. How do we approach a patient with hyponatremia?
Yeah, Abhishek. So hyponatremia is quite common. We frequently encounter the same condition in ICU, and it's a very disturbing element, especially in the elderly. So before going for the approach, we think for the three things for hyponatremia. Number one, duration, whether it is acute or chronic, and the time period interval is 48 hours. It is important because in the case of the chronic hyponatremia, we have we can treat very aggressively, but in the chronic condition, to avoid the condition is that severity. So based on the sodium concentration, we see the severity. Mild condition, if the sodium concentration is 135 to 130, moderate if it is 130 to 125, and the severe less than 125. So severe condition we have to go very seriously because nervous system is quite sensitive for the hyponatremia related because of the RAGE ICP. And third consider we think what type of the hyponatremia we are dealing. So third types is most important. Actually the true hyponatremia what we see is the hypotonic hyponatremia. So first we have to see the serum osmolality. If it is less than 285, then it is a true hyponatremia. Other type of the hyponatremia, that is the isotonic hyponatremia and the hypertonic hyponatremia. We are actually not bothered. So if we see for the true hyponatremia, it is real like a hypotonic hyponatremia. Then we have to classify which type of the hypotonic hyponatremia is based on the volume status of the patient. If it is a patient, if we check for the clinical symptom and check for the edema, if the patient is dry, it means this is hypovolemic hypotonic hyponatremia. So in this condition, we have to actually the sodium and water both lost from the body, but the the proportion of the sodium loss is much more than that of the water. Second type is the euvolemic hyponatremia. In this condition, the sodium remains the same, but the water increase. And this euvolemic hyponatremia is quite common. And if we have to go on more detail, then in the condition of the euvolemic hyponatremia, we have to check the urine osmolality. If the urine osmolality, if the patient have the concentrated urine, then that it means we are dealing for the patient of the SIDA, that is the syndrome of inappropriate ADS secretion. In this condition, the urine will be little bit concentrated. If we check the urine osmolality, it will more than 100 milliosmol. And if the euvolemic hyponatremia, if we see the urine is dilute, it means we are dealing something like that polydipsia, some drug-induced hypothyroidism, and sometimes the phenomena that is the weird protomania. And third type of the hypotonic hyponatremia is hypervolemic hyponatremia. In this condition, there is a water retention in the body, and especially if we see both the sodium and water increase, but the proportion of the water increment is much more than that of the sodium. So it is just like a dilutional hyponatremia. So for checking all these things, we go directly for the three tests. One is the serum osmolality.
Just finish up with hyponatremia with you, sir. Can we have a few words about the management of hyponatremia?
So, just if you see for the hyponatremia, we have some mind. We check the history, we check the drug, if any drug is responsible for the hyponatremia or not, and we see the duration. In the condition of the hypotonic hyponatremia, we give the fluid supplement, NS and many more, and check. In the condition of the euvolemic hyponatremia, such as the SIDA, we restrict the fluid. we give the salt solution, and sometimes we use the tolvaptan. In the condition of the hypervolemic hyponatremia, we restrict the fluid, we restrict the salt, we use some Lasix, and so on. So it's a very vast topic. We will have the shortage of the time.
I think you have done justice to the topic anyway, sir. It is very important to see what kind of hyponatremia we have, because I think fluid restriction is the main treatment. I mean, the initial treatment, the most important way to treat hyponatremia in case of hypervolemic and euvolemic hyponatremia. Now,
I'd like to add one thing.
Yes, sir.
We should never add tolvaptan when diagnosis is hypovolemic hyponatremia.
That is
and that's common thing as a nephrologist we encounter. Tolvaptan is not equal to hyponatremia.
Tolvaptan is the drug of the choice in the euvolemic hyponatremia with the CEDA condition.
It is aquaretic. It is for extra water, not to correct sodium.
That's true, sir. Sir, now let's move on to another electrolyte. My next question is to Dr. Atma Prakash Naik, sir. What are the common causes of hyperkalemia, sir, and drugs that are responsible for it?
Okay. So hyperkalemia is a medical emergency in most cases. The common causes are whether there is reduced excretion of potassium, whether there is increased intake or accumulation of potassium, and whether there is transcellular shift. So these are in these three categories we can categorize the causes of hyperkalemia. Common drugs that can cause hyperkalemia, as we know all, ACE inhibitors, ARBs, non-steroidal MRAs, and also mineralocorticosteroidal MRAs. Even the newer drug which might be coming in the future, baxdrostat, has been shown to be proven to have adverse effect of hyperkalemia as the major side effect, adverse effect. And there are other drugs like non-steroidal NSAIDs, and then you have heparin, succinylcholine, lithium. There are various drugs that can cause beta blockers. These are the common causes that can cause hyperkalemia. And apart from that, we have to look at in which setting there is an hyperkalemia, whether it is due to rhabdomyolysis, whether it is due to crash injury, whether it is due to burns, or if there is a history of established renal disease like chronic kidney disease. So those are common causes of hyperkalemia.
Very well put, sir. I think one drug that we usually overlook in our practice are beta blockers, which can cause hyperkalemia, but we don't tend to stop it if a patient presents. Yes, sir.
We have forgotten to stop potfluor.
That is it. If we have a very complicated treatment chart, like in Vedanta, then obviously we might forget.
Potfluor is going on and K1 is also going on.
And K1 is also going on. So we must learn how to actually check the drug chart every day when we go for our rounds. Finishing up, most importantly, the patient presents to us with hyperkalemia in the emergency. We all get scared. How do we manage it, sir?
So the important step is what is the hemodynamic status that you have to first look at, whether it is unstable hemodynamic status or it is the and what is the renal function, means if the patient does have some residual renal function left, based on that, therapy would be guided. If the patient is already bradycardic, there is no urine output, you have to straight away go with, you have to include the cardiologist as well, and also go for hemodialysis, because there is no other way that you can correct it immediately. Apart from that, if there is a residual renal function, that means the patient does have a good urine output, then you can give diuretics, you can give the GI drip, which is the glucose insulin, and you also have First thing is to stabilize the cardiac membrane, which is the calcium gluconate. You have to stabilize that, because that is going to save the patient in addition to these steps.
What is
and also there are, in the long term, there are the molecules that has already been discussed previously, the sodium zirconium, and then is SPS, and there is patiromer, which though patiromer is not available here.
There is always an inertia from IC people or medicine people or some other people. In spite of having severe hyperkalemia, if you patient is having some little bit of urine output, every instance, dialysis should not be done. So I have seen patient losing. I think being a nephrologist, if a patient is having a hyperkalemia of serum potassium of 6.5 and having any kind of symptoms, I think we should not try conservative treatment alone, and dialysis should be done as soon as possible, and we should try to convince even in our ICU people, our medicine colleague or even other specialties, because most of the time they say, "तो अब तो dialysis हो रहा है इसका," मतलब it's seen कि like you are doing some kind of crime or patient is very critical or dialysis will worsen the hyperkalemia, and there is a normal perception between even in ICU and even with our physician colleague.
And also I forgot to add that first of all we need to recheck the potassium level, because there is inappropriate application of tourniquet and there is hemolysis which can give a spurious reading of hyperkalemia.
So one thing I think there is some confusion about, at what potassium should we actually initiate treatment for hyperkalemia?
So actually based on the findings, and if there are ECG changes and if there is ECG changes, you have to start the therapy. There is no, there are in the two arms that we study hyperkalemia based on potassium level. So with ECG changes, without ECG changes, based on that we have to do the therapy.
Dr. Abhishek.
You stop.
Don't expect it for day after tomorrow you will deal with hyperkalemia. But if you don't have any apparent cause, still there is a hyperkalemia, then you suspect the kidney may not be excreting hyperkalemia, there is overproduction of potassium channels, then that whole story will decide whether what you expect tomorrow morning. Do you expect tomorrow morning a normal kalemic patient, or you expect potassium may worsen tomorrow? In that case, even at 5.9 potassium, I will convince my colleague, let me do the dialysis. I don't expect potassium to be normal tomorrow morning. But telmisartan has been stopped, bisoprolol has been stopped, good urine output, even 6.6 potassium, you think tomorrow you will be in a better position.
Better position.
Yeah, there are two different settings, I think. One is chronic patient, stable patient, OPD patient, and second one is ICU patients. So ICU patient, we are very closely monitoring the patient, and daily we are doing KFT. So if the potassium level is more than 6, definitely we can start potassium binder. That is very important. And that drug is now a wonderful drug, and we can use it, utilize it in our ICU. But some patients come to emergency and ICU suddenly, and you find that potassium level is more than 6.5 or more than 6, and there are ECG changes. You don't have any other choice. You have to rush for the dialysis. No doubt about that. But in OPD patients, some patient comes and you have done the KFT and you find that potassium level is more than 6. Definitely you go for ECG. And if the drug is causing the hyperkalemia, stop the drug and give potassium binder for some time, 2-3 days, and it will come down. But monitoring is very important in that group of patient, because this is the group of patient where recurrent hyperkalemia is possible. So monitor that patient carefully in OPD patient, and when the potassium level comes down to below 5.5, you can be comfortable.
So,
patient will get convinced, he will bring the dialysis line, somebody will say that the dialysis should be done, then they will say, oh, what is dialysis, then patient will say, we are trying. So I think it's better, give them a good message that we say AKI, potassium is high, my personal view will be dialyze the patient straightforward. Don't wait, because by the time the dialysis started, I have seen patient living, the patient आज आया dialysis कल चालू हो रहा है, या patient आया कार्डियोलॉजिस्ट के पास चला गया, डायलिसिस से पहले उसकी पेसिंग हो गई, मतलब कार्डियोलॉजिस्ट के पास गया, they have done the pacing, अब डायलिसिस पेसिंग के बाद होगा. So I think nephrologist should, हम लोग थोड़ा इससे पीछे हो जाते हैं, I think nephrologist should take over, and in AKI in hyperkalemia setting, I think dialysis is the first option.
Usually hyperkalemic patients don't die once they are hospitalized. The reason is very simple. The first drug that should be given is calcium gluconate. And if the patient develops cardiac arrest, then you can very well intubate your patient and dialyze the patient immediately. We have saved a lot of patients like coming to the emergency and patient developed cardiac arrest in the emergency only. The patient was intubated, ECG changes were there. So immediate within half an hour you can initiate the dialysis. It doesn't take more than half an hour to initiate dialysis. Putting the catheter, starting dialysis, the time is roughly around 30 days. And during that period, you don't need any consent. Just you inform your patient, inform the relatives, save your patient, that's it.
Manifestations and treatment of hyperkalemia needs to consider the acuteness of hyperkalemia as well. Treatment choice and modality depends upon the how acute hyperkalemia has developed. In acute case, as Dr. Manoj is talking, in AKI most of the time it is acute. It will develop even in hours or minutes in patients, particularly in anuric patient. And as far as medical management and dialysis, which modality should be considered first will also depends whether patient is in remote area or in central hospital. Medical management always should become as a bridge therapy till the dialysis is not arranged. It's my opinion. Remote में treat करो या hospital में, you should start the anti-hyperkalemic measure once the changes of hyperkalemia is there, and hyperkalemia is not associated with the reversible factor, as boss already has told that it is not associated with reversible factor that will resolve after withdrawing the reversible factor. It's the only kidney that will excrete the potassium significantly. So you have to dialyze the patient to save your patients. This is the point.
It should not be a shift, hyperkalemia to shift. DKA patient coming with hyperkalemia, if you give aggressive therapy for hyperkalemia, tomorrow will have a persistent hypokalemia. Because you are hypokalemic for a long time because of uncontrolled diabetes, suddenly develop severe acidosis, you see hyperkalemia, you correct acidosis, now you see 1.8 potassium for 5 days.
And now, this discussion of dialysis versus medical treatment, will it change after the introduction of Lokelma, which claims that its action starts within 1 hour? So, can we avoid few dialysis using this drug?
Actually, in
patients, we have
patients,
experience. We have taken a chance. A patient was non-oliguric. Potassium was around 6.5. There were no ECG changes. So we discussed with the ICU people and we started Lokelma, and we avoided dialysis. The very next day, the potassium was around 5.5.
Actually, very well said, Dr. Jamshed. Actually, we are also using Lokelma quite frequently these days and getting good results. Apart from Lokelma, one more thing that Jamshed will agree, we have used potassium binding resin retention enema. That is very effective in reducing potassium level, because maximum potassium concentration is there in the rectal mucosa. If you use about 30 grams of potassium binding resin along with sorbitol and water, retain it for 45 minutes, you will get excellent reduction of serum potassium level.
We can keep on discussing hyperkalemia.
Believe me, for last 3 months, I have not utilized dialysis machine for hyperkalemia in my ICU setup. And the reason is very simple. Whenever the serum potassium is more than 6, I put the patient on sodium zirconium, 5 mg twice a day. And if uremia is not an indication of dialysis, then those group of patients doesn't require any kind of dialysis. So this molecule is a wonderful molecule. It works within 1 hour and it's very effective. Try this molecule, sodium zirconium. It's very good molecule.
Hyperkalemia with heart block. First, you should go for pacing.
There's no point of discussion, because once there is cardiac problems, so you have to put your patient on dialysis. I am talking about a stable patient who has serum potassium more than 6. If the patient has got hyperkalemic heart problems, whether if the T wave is taller and there is a widening of QRS complex, you can't wait in those group of patients. You have to dialyze. There's no point about it.
If there is a heart block, let cardiologist do the case.
Yes.
Sir, this is
a... Be in a hurry, don't go the physiologist too much.
Sir.
Let them do the TPI, wait for them to do their job, and dialyze the patient.
Okay.
If they die during your putting the line, you will be behind the bar.
Sir, this is a very grey area, but But to doing for the dialysis, it's an emergency, it's not an ideal situation, because if we start talking about the CKD stable patient, the CKD stable patient have some adaptation. If you see for the distal tubules collecting duct, there is a potassium channel adaptation, increased number of the potassium channel. So CKD patient is not vulnerable for hyperkalemia. They can tolerate the hyperkalemia more effectively than normal patient. If sir is asking just for the two groups, one is the unstable acute patient, where sir is favoring for the dialysis, and other is the chronic stable patient. I am also not favoring for the dialysis. I would go for the medical management first.
See, if CKD patient developed hyperkalemia, that means adaptation has failed. Yes. So despite his good adaptation, colon producing more and little tubule producing more potassium, still now he has developed hyperkalemia.
Okay, now, lastly, the important question is, sir, what about our chronic CKD patients on dialysis who have hyperkalemia? Do you favor potassium-free dialysis or not? Atma, sir.
Patients, first of all, as has been discussed yesterday also, sir said.
We face this all the time in our dialysis units.
Every incidence of hyperkalemia is an opportunity to prevent the further episode in the future. So if the patient if the patient is non-compliant and if he is not maintaining the dialysis schedule, I would prefer giving him at least some hours of potassium-free dialysis during each session that he comes for dialysis.
Some people differ.
I will differ. Because the potassium has the rebound phenomena. It will definitely, if you see the potassium, it is intracellular. If there is acidosis, there is inefficient dialysis. Even you do for the potassium-free dialysis for 4 hours, the potassium will rebound because the sodium-potassium concentration is around 140 millimole inside the cell, and it is 3.5 to 5.5. It is all about the redistribution. So there is no question for the, I will not favor for. That's my opinion.
Yeah, rapid transition of potassium by using potassium-free dialysis can just provoke arrhythmias also.
Yes, so lots of AF patients, AF cases.
Yes, yes.
They never do potassium-free in last 2 hours.
That I think, sir, the concentration gradient increases.
Then you have
So then. But we are, I think all of us are tempted to do potassium-free dialysis once we see the potassium being around 6.5, because our CKD patients are well tolerated to high potassium.
Can you quote any for the potassium-free dialysis? Sir. Can you quote for potassium-free dialysis in any book?
No, because I think obviously the arrhythmia chances increase drastically, and we have also seen that many patients get AF, get admitted with very high heart rates.
1 hour. Also, if there is such a setting that you have hyperkalemia,
AF is very common, sir.
And especially with the phenomenon of like rebound, redistribution, it has been recommended that you keep the patient in-house, monitor the patient. Again, if there is no rebound hyperkalemia, then only you discharge the patient, which in some practical purposes might not be possible, but it can be practiced.
Again, I will divide my patient in two groups. One patient who has very high degree of serum potassium. Suppose serum came for dialysis and potassium is 7. What you will do? You will do potassium free or with potassium? I think you cannot go for potassium free because there will be sudden decline and patient can develop arrhythmia. But if second group of patient, if the patient has got serum potassium between 5.5 to 6, then definitely I will go for potassium-free dialysis so that it can help in the patient management. You can increase the duration, you can increase the frequency of dialysis, that is another way. But in that group of patient, if there is mild hyperkalemia, definitely I will use potassium-free dialysis.
That 5.5, 5.6 will already be corrected by the normal dialysis. Do we need?
No, in that condition, the potassium reduction will be more. If you use potassium-free dialysis, the chances of arrhythmia is very less. So the degree of potassium reduction, that will be more as compared to the potassium-free dialysis.
Moving on to the next electrolyte, I think we've already discussed hyperkalemia for quite some time now. Something that we see less commonly, but we get a lot of references for is hypokalemia. So Dr. Manoj Gupta sir, how do we evaluate hypokalemia, diagnostic evaluation?
See, hyperkalemia, we know that the level is less than 3.5. We divide it into two categories, whether it's a severe one, where its level goes below 2.5, or some books say 2.6, and mild to moderate is around 3 to 3.4. If the patient doesn't have any underlying cardiac disease or any not suffering from sepsis, most of the time the mild to moderate hyperkalemia is asymptomatic. Patient doesn't develop any kind of symptoms. But if the patient is having some kind of cardiac disease, CAD, or some kind of alveolar dysfunction, or patient having multiple comorbidity, so this kind of hypokalemia should be taken seriously. And any level less than 2.6 is considered to be a severe kind of hyperkalemia and should be taken seriously. So regarding the approach, you should think, first thing is, we should take a proper history that what is the cause of hypokalemia. Most of the time, the cause of hypokalemia may be because of 2-3 reasons. Either the patient is having a decreased potassium intake, and the third is patient is having increased loss. The decreased potassium intake, patient is taking, a normal patient, even if take a low potassium dose, doesn't develop hypokalemia, but the patient is chronic malnourished, patient is on internal feeding, or patient is on TP, these kind of patients are more prone to develop hypokalemia. But normal patient on a poor oral intake of potassium patient doesn't develop any kind of symptoms. Regarding the renal loss, you have to find out the increased loss of potassium is either through GI, it can be upper GI, it can be lower GI, or either through a renal. So if the patient is suffering from the renal kind of renal loss of potassium, then you have to, there are 3-4 tests that will differentiate whether the loss is whether from GI or whether it's from renal. The tests are 24-hour urine potassium, urine spot potassium, and there is something called urine potassium creatinine ratio, and something called TTKG that we are reading it for our school days, but seldom we do in our day-to-day practice. So if the serum potassium, if the 24-hour potassium excretion is more than 40, then means there is some kind of renal loss. The patient is suffering, there is a renal loss. It can be because of some kind of renal tubular acidosis, or it can be because of some kind of drugs. Or if the renal potassium is low, then that means it is a non-renal loss. So it either it can be upper GI loss or lower GI loss. So the next thing you have to look at, that is the patient ABG, whether the patient is having any kind of metabolic acidosis or metabolic alkalosis, and you have to also look for the serum osmolality as well as urine osmolality. So if the patient is developing any kind of metabolic acidosis, that means the most of the potassium is lost from the metabolic acidosis with a low potassium, that is upper GI. And if the patient is having a metabolic acidosis along with an high potassium, that is because of renal tubular acidosis. Similarly, if the patient is having metabolic alkalosis with a low potassium, that is a low 24-hour potassium, that is non-renal, that is because of lower GI, that is because of venous edema and everything, and high potassium, that may be because of some Gitelman's and Barton. So in clinical practice, if you really want to know about the serum potassium concentration, I will say if you are not able to find an history that signifies that what is the real loss for a renal potassium, so before giving any kind of potassium correction, you should do all these 4 tests, and that will differentiate that what is the real cause of hypokalemia, because sometimes even for nephrologists it becomes very difficult to find out what is the exact reason for giving a hypokalemia. So your lab should be well equipped, and you should have a center where all these tests, I think most of the centers are doing serum spot, urine spot potassium, as well as 24-hour urine potassium. Yes. That is freely available. And after doing all these tests, you can find out, you can put the different categories, that which category your patient is suffering from. And regarding the treatment, I would like to say that mild to moderate potassium correction, if the patient doesn't have any underlying disorder, underlying cardiac morbidity, you can correct it orally. And if the patient is having severe kind of hypokalemia, you should give IV, and we know that it can be given from a peripheral line and central line. So central line, the rate should not be more than 20 milliequivalent per hour, and in peripheral line, you should not give it from more than 10 milliequivalent per hour. And you should always use a non-dextrose based solution to correct serum potassium, and the regular monitoring of potassium is important, because most of the time if you give a potassium, there is something called redistributing hyperkalemia. So overzealous of hypokalemia treatment should be avoided as compared to hyperkalemia, because if you are not able to monitor serum potassium regularly, I think giving IV is little dangerous.
Yes, sir. So I think history taking, I think, plays a pivotal role in diagnosing what kind of hypokalemia there is. Obviously, if somebody coming with diarrhea becomes very obvious that hypokalemia is due to such.
And hypomagnesemia is also a common cause
yes.
with underfractive hypokalemia.
So I think hypokalemia has been well covered by sir. If somebody would like to add.
Yes, sir.
One is spot uric potassium creatinine ratio.
Yes, sir.
To see that there is an inappropriate loss of potassium from kidney.
Okay.
Second is ABG.
Okay.
Third is magnesium, and fourth is thyroid profile for
Okay.
thyrotoxicosis.
Okay.
So these 4 tests we always do in patients who come with hypokalemia.
Okay.
And if you will do these 4 tests, we can differentiate between the things. Many a time, thyrotoxic patient, they are having recurrent hypokalemic periodic paralysis. And they are labeled as a hypokalemic periodic paralysis, but actually they are having thyrotoxicosis. If you will not correct thyrotoxicosis, then they will go into recurrent hypokalemic paralysis. So these are the things. And one very good you have told about the magnesium. One patient, our patient in the ICU, we are giving potassium, but we are not able to correct potassium. Once we have done magnesium is very low, and once we have given magnesium, then this potassium is low.
Urine spot potassium, when you are doing, again I would say to whenever you are ordering this test, you should do it before giving any kind of IV potassium or giving any kind of oral supplement.
Most of the times you are hoping that the potassium would correct anyway. We don't do this test. But sometimes
most of the time the general malady let's correct the potassium.
Yeah.
If it's not getting cured, then our mind setups comes. What's the what is the common, what is the causes of hypokalemia? That is a general practice. I think all of us follow.
Now moving on, sir. Sir, now next question is to Pankaj Mishra, sir. Sir, hypercalcemia is something that we need to usually correct easily. Sir, mic. Something that we can approach in a very methodical way and treat the cause. Once the cause is treated, patient usually gets much better. How do we approach it, sir?
So if you see
Mike.
We are dealing with hyperkalemia. We can divide hyperkalemia based on the severity. 10
hypercalcemia. 10
to 12, 12 to 14, and more than 14. Severe, moderate, and mild hypercalcemia. Then we can order some test. I think whenever we see hypercalcemia, we can get the cause from the investigation. We should first review the drug chart. And very important, most of the, even in nephrology patient, your patient may be visiting orthopedics. And he may be giving a combination which contain vitamin D, a good amount of calcium with a very good absorption, calcium citrate maleate at a very good absorption, and good dose of calcitriol. So you must ask patient repeatedly whether he has any and good amount of vitamin D for so many years. That is the most important cause, not now I see iatrogenic. Then we have to do PTH, vitamin D level, thyroid profile. These 3 tests we must do in all patients. Either we can have a parathyroid dependent hypercalcemia, which will include primary hyperparathyroidism, tertiary hyperparathyroidism, hypocalciuric hypercalcemia, or lithium intoxication. Then parathyroid independent, we should do vitamin D level. It can be iatrogenic vitamin D or vitamin D due to because granulomatous disease. Then we can have a endocrine dependent causes like thyrotoxicosis, and then some rare cause like drugs, lithium, thiazide, diuretics. All these can cause hypercalcemia. For most practical purpose, a stable patient, it is a primary hyperthyroidism very high hypercalcemia, most likely it is going to be for malignancy. And what we encounter, multiple myeloma as a common cause of hypercalcemia in our patient.
Sir, next I would like you to talk a little bit about the management of some of these entities and using denosumab or bisphosphonates in treatment of hypercalcemia due to malignancy.
If there is acute severe hypercalcemia, first thing, it causes polyuria, so we have a dehydration, must give fluid. If patient is full volume depleted, then we can think of giving Lasix. Third line, we can give calcitonin, that we can only give easily available. Then there comes the role of bisphosphonates. Usually we give zoledronic acid, but it has got limitation in our patient, the kidney compromised patient. We can think of giving denosumab, though it was meant for cancer patient, but now as a CKD, as a nephrologist, we are increasingly using denosumab because better safety profile. And then in a rare case, very severe hypercalcemia, ECG changes, we can think of doing dialysis also.
The problem with us is that I think low calcium dialysate is not available.
Not
whole of Bihar, it's not available. 1.2. I think all of us are doing dialysis with a dialysate which is 1.75 millimole.
But I think in an acute hypercalcemia, you don't want to do.
You don't want to do too much.
Any reduction will save the heart.
Yes. Next, sir, is for Dr. Prem Shankar Patel, sir. Let's talk a little bit about magnesium, sir, and its relevance in our clinical practice. As we see that I don't think a lot of us do serum magnesium on a regular basis. What could we be missing if we don't do magnesium?
So it's not only sodium, potassium and calcium is relevant in clinical practice. Magnesium also carries the same significance in clinical practice. As we know that magnesium cation is the fourth most common cations in the body, and majority of magnesium is incorporated in the bone and intracellular space. Only less than 1% of magnesium is in intravascular compartment, and of that 50%, 55% is protein bound, and it's the ionic magnesium which is the functionally active. Serum magnesium or magnesium cation is involved in the as a cofactor in the functions of lots of enzymes, and it is most important cations in the neurotransmitter or the muscular functions. So, but unfortunately, magnesium is always overlooked by the clinician. It should be, we should always give the high index of suspicion whenever we encounter the medically resistant or persistent hypokalemia, hypocalcemia, a patient with unexplained tremor, a patient with unexplained or unresponding seizure, a patient with having unresponding tachyarrhythmias. In that case, we should always look for the serum magnesium, and we should order the serum magnesium, because after correcting this magnesium level, particularly hypomagnesemia is associated with all these factors. Correction of this magnesium often leads to successful treatment of all these entities with the specific treatments. So magnesium is magnesium having also same significance and clinical relevance in pathophysiology or in disease state. As a nephrologist, serum magnesium is also important because serum magnesium having very narrow levels. It is about 1.7 to 2.54 milligram per dl. It's the kidney which regulates the serum magnesium level. After GI absorption, most of the serum magnesium is freely filtered through the glomerulus, and majority is reabsorbed again the tubules. So it's the kidney which regulates the serum magnesium level, and any perturbations in serum magnesium level indirectly contributes in the progression of kidney disease as well. In a patient with kidney disease, persistent hypomagnesemia is associated with the rapid progression of CKD, MBD, mineral bone disease. It's associated with high risk of cardiovascular mortality. So, let's say magnesium or magnesium disorder is equally important to be considered in general practice in general medicine or as a nephrologist. So, magnesium disorder may be hypomagnesemia or hypermagnesemia. Hypomagnesemia in majority of patients is contributed by the either excessive loss through the kidney. Most commonly it's the drug induced, and the most common drugs are diuretics, PPI, for nephrologists is the CNI, post-transplant state, and one important class of drug is the chemotherapeutics, particularly the platinum group of drug is significantly cause the increased loss of serum magnesium in the urine. Second most common is the decreased absorption through the low intake, particularly in patients with malnutrition and patients having the persistent chronic diarrhea in which magnesium is not adequately absorbed in the blood. So these are the common two factors which is responsible for the hypomagnesemia. And in hypermagnesemia, in majority, either it is because of renal failure, because kidney is not excreting the required amount of magnesium. And second important is the iatrogenic consumption of long-standing high-dose magnesium containing antacids or other medications which leading to the hypermagnesemia. In hypermagnesemia, manifestation is most of the time it's several non-specific, and the manifestation is very associated with the serum magnesium level. So hypermagnesemia and hypomagnesemia, most of the time hypomagnesemia leads to the hyperexcitability of neurons and the cardiac muscles. While in hypermagnesemia, it's caused the blockage, either in neurotransmitter blockage or the cardiovascular blockage. So manifestation will leads to sudden bradycardia, sudden bradyarrhythmia, lethargy, or finally the respiratory suppression in the brain leading to the death of the patient. So it's all about, briefly all about the magnesium disorder and its clinical relevance.
Sir, I think we also saw a patient who had PPI-induced hypomagnesemia leading to recurrent arrhythmias. And once we stopped PPI, everything improved, including the magnesium. Something that we give every day in a day-to-day practice, we don't realize that what implications it could have. Lastly, coming to Jamshed, sir. Sir. Yes. They also develop symptoms of hypermagnesemia.
It's again, sir, it's heterogenic because we are giving the replacement inadvertent, unmonitored IV magnesium leading to hypermagnesemia.
Causing UKI also. So, sir, the last electrolyte, I think we have had an overdose of electrolytes today, is phosphate. So hyperphosphatemia is what we commonly face in our practice. So how do we approach it?
In fact, hyperphosphatemia is something that is more important for us nephrologists because almost all patients of CKD below GFR are having hyperphosphatemia, and it is just the beginning of a wide spectrum of disease, which we know as the mineral and bone disease of CKD. So hyperphosphatemia is inevitable in any patients of CKD, as we know that the kidneys usually handles phosphate, and when the GFR falls below 60, the phosphate start increasing in the body, and the bone and the kidney respond in such a way that initiates a cascade of system which ultimately lead to the mineral and bone disease, vascular calcification, and increases the cardiovascular morbidity. So hyperphosphatemia is something that we need to look in each patients of kidney disease. We have to monitor it adequately, all the parameters, be it phosphate, calcium, vitamin D, or the PTH. We need to identify the problems, we need to manage it adequately. Apart from kidney disease, there are certain other causes of hyperphosphatemia, like mostly the drugs. Many patients take vitamin D inadvertently. They keep on taking vitamin D without knowing their calcium and phosphate. This is one common cause. Other is phosphate-containing laxatives and enemas. Most commonly in the ICU, we see that even the patients of CKD, they prescribe the phosphate-containing enemas, which should be avoided, particularly in CKD. So we know that with rise in the phosphate, there is a cascade in which there is a rise in FGF3, which need to handle phosphate, and thus it also reduces the production of vitamin D. And so this combination of increased phosphate, low calcium, and low vitamin D lead to secondary hyperparathyroidism, which ultimately lead to the high bone turnover disease and ultimately lead to high risk of fractures and vascular calcification and other cardiovascular morbidity. So there are different guidelines how to monitor it, how to manage it. They say that below the GFR of 60, all these parameters should be monitored every 6 months or 2 annually. In kids, even more earlier in the G2 stage only. So we should keep monitoring it. Regarding the management, again, this is a vast topic of managing CKD MBD, but the usual KDIGO recommendation is to keep the serum calcium within normal range. We have to look for phosphate. There are a number of options in correction of phosphate. There are a number of binders, calcium containing, non-calcium containing. Recently, iron containing phosphate binders are available, which claim that it will handle both the anemia and the CKD MBD. And when needed, when there is a hyperparathyroidism, then also there are options of calcium mimetics. So the target is to keep all those parameters within the range so that we can avoid the larger morbidity caused by the mineral and bone disease.
So what is your preferred phosphate binder?
Phosphate binder. So it depends on the calcium level. If the calcium is very low, then we start with calcium containing phosphate binder. But if the calcium is within the normal range, usually the KDIGO recommend that we should avoid calcium containing phosphate binder. So most commonly, I guess, Sevlamar is most commonly used.
Cardiovascular benefits are like pleiotropic action.
When we are using calcium-based phosphate binder for low calcium, your calcium usually don't get corrected very fast. And that's again a pitfall.
Because it's taken with the food, so absorption is
it's serving as a purpose of phosphate binders. And you better give calcium-based formulation in between meals if you want to correct hypocalcemia, and you want to give it with foods if you want to get the benefit of as a phosphate binders.
Since we're talking about mineral bone disease also, sir, I think what is your take on stopping active vitamin D formulations?
Yeah, we have to keep checking the calcium and all. Inadvertent use of calcitrol or vitamin D analog should be avoided.
And lastly, I think PTH. What level of PTH are you comfortable with in dialysis patient and then non-dialysis also?
In the dialysis patient, we do not need to suppress too much because of the risk of a dynamic bone disease. So what the KDIGO recommend is to keep it between 2 to 9 times within normal, which is around 60. The normal is around 60. So we should keep it in, what's the guidelines said, between 2 and 9 times of the normal.
So I think we must avoid hypercalcemia.
Yes, sir.
Then keep phosphorus within the limit. Then you can think of keeping PTH in the range. We can't keep PTH in the range at the cost of very high calcium and very high phosphorus.
And sir, we do face adynamic bone disease quite often in our practice. Any particular, have you ever had any experience with teriparatide, using teriparatide for?
No, as such, personally, I haven't experienced.
Small trials have been done. I've used it sometimes. Usually the bone pains improve.
Iatrogenic only. We keep on giving vitamin calcitrol and all. And
once we stop those drugs, still PTH is remaining low, and
then
patient is having symptoms.
Then we can use teriparatide.
Then even though small trials have been done, we've used it in a few patients, and patients' bone pains and all the symptoms are relating to bone pain have improved slightly. Even the PTH, if we keep doing the PTH over a period of time also, even if the patient is taking teriparatide, usually the improvement is very slow. You don't see.
If your orthopedist colleague has teriparatide, will you allow them and will you check PTH then allow them?
Only check PTH, sir. I think you can't allow it just like that.
Usually orthopedics do not check PTH.
Orthopedics don't know.
They think that they're old patient, they are osteoporotic, they will start teriparatide.
And I think once we do a X-ray of, if we send a CKD patient to orthopedicians, they usually diagnose them as osteoporosis and start the treatment for osteoporosis. Irrespective of knowing the creatinine
of
kidney
CKD,
conditions.
they will see this X-ray and they will
I
write
hope
either osteoporosis or
nobody
osteopenia.
minds that you're talking about. I think that concludes.
Dr. Abhishek,
yes,
all we talked about the hyperphosphatemia and CKD MBD.
Yes.
But I will add before concluding the session, it's hypophosphatemia, which is also important, particularly in the dialysis patients or our in CKD patients.
Yes.
Because most of the time it indicates the nutritional status of your
Of those
patients. And secondly, it also indicates sometimes this hypophosphatemia is associated most of the time so many of drugs also causing the hypophosphatemia.
Yes.
And this hypophosphatemia adversely affects the RBC survival very significantly. It leads to low level of ongoing hemolysis. So hypophosphatemia is also important. We should look for the cause and how to manage the hypophosphatemia to keep the phosphate level in the normal range to give the adequate health to the CKD patients or dialysis dependent patients.
You wanted to stop the phosphate binder.
Yeah, of course.
Because I think patients can't take Adfos indefinitely. I think with this, we've had a very healthy discussion. With this, we conclude our panel discussion. If there are any further questions, no questions. Thank you so much.
Thank you, sir, for the panel discussion. Distinguished guests, speakers, and fellow delegates, we have reached the end of our intellectual stimulating nephrology update. I would like to express our deepest gratitude to our speakers for sharing their pioneer research and clinical insight with us today. A special thank you for our esteemed chairperson for guiding us our discussion so effectively, and to the Indian Society of Nephrology East Zone and the API Magadh division for our organization such a significant academic gathering. I would also like to thank you, our attendees, for your active participation and for the thoughtful questions that made today's session so dynamic. We hope you live here with a new perspective will enhance our practice. Thank you for joining us.